the NICU moderated by Dr. Nilesh Darvekar. He is the doctor in charge neonatal intensive care unit and Nelson Mother and Child Care Hospital in Nagpur, Maharashtra. And he has an app on parenting called Being Parents and a YouTube channel, Dr. Darvekar, for training of staff and medical student. And he is also an author to topics in IAP textbook of pediatric critical care and is a faculty for Pedicon, MP Pedicon and Maha Criticon books to bedside. So I welcome you, sir. And we have our esteemed panelist for the day, Dr. Kriti Naranje. She has the current designation is current hospital institute, addition professional and head Department of Neonatologist in Lucknow, and she is a national instructor. Dr. Anand Bhutada is a consultant pediatric intensivist and neonatologist, Nelson Hospital in Nagpur, and he is a fellowship coordinator and guide at Nelson Hospital, Nagpur. Dr. Sanjay Gorpade is a head neonatal and pediatric intensive care service director and professor of pediatrics. And we have Dr. Jayachandran. He's a chief consultant neonatologist. Dr. Shishir Agarwal is a chief consultant neonatologist and pediatrician, national executive board member, Indian Academy of Pediatrics. And we have Dr. Sidhu Charki. He is the assistant professor, lead consultant in neonatal medicine and in charge NICU, Department of Pediatrics in Vijaypur, Karnataka. And we have Dr. Bhaskar. He's Dr. Bhaskar MV, consultant and neonatologist at Kaveri Hospital, Bangalore. I welcome all of you, sir. We call upon all the panelists and the moderator to the dais. Over to you, sir.
Thank you. Good morning, everyone. I welcome you all. I welcome all the panelists, and I thank NNF and the organizing committee for organizing this panel discussion. So today's topic for this panel discussion is technology in NICU. So what is technology? When we say technology, it is actually an application of scientific knowledge in any field. So when we say healthcare technologies, it may be any kind of technology in the form of medical instruments, algorithms, medical apps, or any kind of software which is helping us in day-to-day practice in neonatology. So without wasting much time, let's discuss some technologies which is useful in NICU. We will discuss the most common day-to-day practice. What we see most is neonatal hyperbilirubinemia. Shishi sir. Hello, Shishi sir.
Yeah, am I audible?
Yes, sir, you are audible.
Yeah, healthcare technology. Healthcare technology is any technology including medical device like IT system, algorithms, artificial intelligence, and cloud designed to support the healthcare organizations. Let's discuss the technologies in NICU. The recent technologies in the management of neonatal hyperbilirubinemia. There are Billy blankets. Billy Sphere 360 is a newer device which has been added. LED phototherapy light is something which we have already been using from a long period of time, and a non-invasive bilirubinometer. Billy blanket. The irritance level, we'll talk about the irritance level. There is no distance factor to diminish the treatment and the intensity. For a small pad, irritance factor is around 50 nanometer, and for a large pad, irritance is 35 mu micrometer. The components of intensive phototherapy, light intensity, AAP, American Academy of Pediatrics guideline is irritance level is at least 30 nanometer, and for Billy Soft 2.0 LED phototherapy system, 35 mu micron, 50 micron for small pad, and 35 for the large pad. Nominal irritants measured through soft cover. Peak wavelength. Wavelength between 430 to 490 nanometer has to be maintained. 445 to 470 nanometer, mismatching the peak absorption wavelength at which bilirubin is broken down. The surface area coverage. Large surface area is coverage for combating extremely high bilirubin levels. Provide greater surface area other than fiber optic devices and many overhead lamps. Distance. The distance between the implant and a light source is critical to spectral intense level. In contact with infant skin, eliminating distance deficiencies entirely. Now, we're talking about the newer device that is Billy Sphere 360. In this, the air temperature display can be variable. It is not to be worried. It can be from 0 degrees centigrade to 51 degrees centigrade. Skin temperature display can be up to from 0 to 51. Noise level is always less than 55 decibel. The screen is around 5.1 inches. Touch screen is there. Lamp lifetime is around 20,000 hours. This is something to be worried about, that the lamp lifetime is only 20,000 hours. Lamp type is 16 BC blue light LED tubes. Intensity is 120 micronanometer. Spectral irritance is 420 to 480 nanometers. IV pole weight limit is 2 kg and monitor self weight is 6 kg. Supply voltage is 220 volt. Now, non-invasive bilirubinometer, we have been using this device for a very long time. Non-invasive bilirubinometer, we use it in our center as well, but the accuracy is not appropriate. It is around. It is not a perfect accurate technique.
Thank you, sir. So what this newer technology helps in neonatal hyperbilirubinemia management? So initially we have to add extra fluids for the heating of the baby. Now this fiber optic technology in Billy Blanket, you don't need to you don't need to add fluid to correct dehydration. Secondly, this is a non-invasive method. It is can be done for screening purposes, but for higher readings or when you're suspecting a pathological jaundice, you have to send the lab. Thank you, sir. Next, moving on to surfactant administration, a lot of changes has been there in the surfactant administration. Dr. Bhaskar, what are the new updates on this surfactant administration in premature baby?
Good morning, everyone. There are LISA, this is called Least Invasive Surfactant Administration. As it sounds, LISA sounds like a young model name, so everyone is interested into it. So coming to the advantage, I mean, how do you do the LISA procedure? So the child should be spontaneously breathing. Child should we have a non-invasive ventilation. So you put a laryngoscope, lift the glottis, look at the glottis. So use an rigid tube, either 5 French to 6 French umbilical catheter, or NG tube, or Surfocath, which is specifically meant for LISA procedure, because it's an angulation, as shown in the diagram. So as soon as you pass through the glottis, inject surfactant. If you think that's a regurgitation, you need to go a little more deep and make sure that it should not go inside because it's going to the unilateral line. So then come out. So the advantages here is, one, there is less painful compared to ensure technique. Secondly, the PEEP is maintained throughout the procedure so that there will be better function residual volume will be there. And there will be uniform distribution of surfactant because it will be child is breathing spontaneously. These are the advantage. And what is the evidence say? The meta-analysis which was published previous year says that LISA is better when compared to ensure technique. The incidence of intubation in first 72 hours were less in LISA technique. The chances of BPD and morbidity were less in LISA technique when compared to ensure. But that meta-analysis had a lot of bias. So should always take with a pinch of salt. Then coming to disadvantages of LISA. Though it has told that it is less painful to ensure, because we are using laryngoscope, a child will have a little bit of pain. And we can't use sedation because child should have spontaneous breathing. And They came that PEEP will be maintained throughout the procedure because we are opening the mouth, the PEEP will be lost. And there will be chance of spillage is more compared to insure technique. And one more thing, in insure, we have an whole control on airway. If child wants to do bradycardia, if something happens, we can unbone. But in this technique, we don't have an whole control over the vocal cords go to spasm. We don't have any control over the airway. That are the advantages and disadvantages of LISA.
Yes.
Though it looks promising, and one more, compared to insure, you need to learn the skill uh, to how to do the LISA procedure, which doesn't come easy as intubation.
So you have to be 100% sure that you are in the trachea and not in the esophagus.
Huh.
You know, previously we can put the ET tube, we can check with the ambu bag. That advantage is not there with this
LISA.
LISA technique.
Yes, sir. So next, coming to oropharyngeal surfactant.
Before going to that, I had a discussion with this company person, and I asked one question. Sorry, sorry. I asked one question to him that you said that this black portion should be at the level of the glottis, and I have a range of infants. It may be 1.5 kg also, and it may be 500 grammar also, because we are getting because of this IVF, we are getting nowadays 500 grammars also. So if I put the same length in the trachea of a newborn who is just 500 grammar, are you sure that it won't go to the right bronchus? So he showed me the studies, and what they have actually studied the length of trachea of these premature infants, and what they found that this 2 centimeter, 3 centimeter, whatever length it is approximate for this 400 and 500 grammar also. So even the technique is same. It is there is a single size catheter which can be used for any size baby. So it's not something like that you have to select the ET size as per the weight of the baby. A single universal catheter can be used for all sizes baby. And the one advantage I want to add is you don't have to do the bagging. Okay, so volutrauma, barotrauma is also avoided. That may be the reason for avoidance of BPD, less chances of BPD with LISA technique. Yes, yes, sir.
So going to oropharyngeal surfactant administration.
Sorry,
So
sorry.
there are not much studies in the oropharyngeal surfactant. Presently the POP-R trial is going on, prophylactic oral surfactant administration in preterm infants. So what they do is you take an NG tube, put it as soon as the child comes out of the womb, before cutting the umbilical cord or immediately shifting into the warmer, give surfactant into the oral cavity. What they say is because of the air fluid interface, their absorption will be better in the lungs, but there is no much studies. Because it is compared to LISA technique also, it's less painful because we are not going any procedure over here. Disadvantage is one, the surfactant get wasted because there will be gastric aspiration, or it can cause obstruction, which happened in one of the studies in one of the infant. That's about oropharyngeal surfactant. Coming to the next one is surfactant nebulization. So that's a new entity which has been now looks fascinating. The advantages is it's completely non-invasive. So there is no positive pressure ventilation, there is no intubation, child will be breathing spontaneously. You just need to nebulize, and there's no need of a doctor also, sister can do, you can keep on watching it. But disadvantages, it's very costly because the regular nebulizer cannot be used. We need a vibrating membrane nebulizer, which is specific for this thing. And that nebulizer should produce a surfactant which is potent even after in aerosol form. That should also be there. And there is a recent cohort study, meta-analysis, which was done in China in 2020, stated that it has decreased number of days of mechanical ventilation when compared to the intubated patient. But that meta-analysis has only 2 RCTs, 163 babies and 32 babies, that both were from China. So we don't know. And they have also mentioned that they require further studies to prove that nebulization of surfactant is much better. Why nebulization? Because there will be spontaneously breathing, the aerosol form will definitely reach in the all parts of alveoli. There will be no fluctuation in the cerebral blood flow hemodynamics, which happens with invasive ventilation, invasive surfactant administration. These are the better advantage, but a lot of research should go on to prove, and there will be a lot of wastage also of nebulization surfactant because it may stay back in oral pharynx or go out. Need to lot of research should go on. Then only we will come to conclusion about how effective is surfactant nebulization in developing countries.
Thank you, sir.
Thanks.
Moving to next technology, use of advanced incubator in the care of premature babies. Do we have Dr. Sidhu Chakri on? Sir is there? Okay. So what we see, the recent development in this technology of incubator in premature babies, they have developed an incubator which not only adjusts the temperature and the humidity, but it's a noise-free environment which is very necessary for the neurological development of the baby. You don't need to shift the baby to weigh. You can take the weight of the baby right in the incubator. It's a sterile incubator. Even if you open the door, open the panel for any procedures, it forms a layer of air which avoid fall in the temperature, and there will be minimal fluctuations in the temperature of the baby. This can be used for the minor procedures also. And the newer advantage is that the same incubator can be converted in the warmer into warmer also. So it's not like that you have an incubator and just because you don't have a baby to put who is qualified for incubator care, that is unutilized. So you can make it convert into open warmer also, and the same can be used as a warmer. So a lot of advantages are there. I think Giraffe from GE and Atom from Philips, these are the two advanced incubators which are available, and this has definitely changed the management of very premature babies because it avoids the loss of water from the body, and the weight loss is very less, so that the early discharge is possible. Otherwise, what we used to observe then when we care with those babies in a open care warmer, they lose a lot of body water, and there is very much lot weight loss is there, which take a lot of. Next, please. Yes. Now again, the game changer in the management of premature babies. This is one thing I think which is helping a lot in terms of premature care, and right from the first breath we can support the baby so that the outcome will be better. Do we have Kirti ma'am?
Yes, good morning, everyone.
Good morning, madam. Please, can you guide us?
Yeah, sure. So as we know that the technological advancements are much more in neonatology as compared to other subjects, even though it is a general thing that everywhere in every department of medicine or surgical specialties, there are a lot of technological advancements going on. But I really feel that the neonatology is one such branch where there are many things, and if you see an ICU, there are many things which are attached to a baby, and these monitors are helpful in management of the patient. The recent advances, I would not say that TP's resuscitator is a very recent one. It has been quite well studied right from 2004, but there is more and more use of TP's resuscitator being used specifically in our country and other developing countries. So this device is, I would say, a miracle for the newborns during the first initial hours during the resuscitation of the newborns. As we know that the older devices that we use were the bag and mask ventilation for giving positive pressure ventilation. The others are the flow inflating bags. So the main disadvantage of the self-inflating bags or the bag and mask that we use routinely is that we cannot control the pressures. We do not know how much pressures the baby is getting. And sometimes vigorous bag and mask ventilation will lead to barotrauma, pneumothorax right in the delivery room. And further, there is no PEEP delivery, or there will be minimal PEEP or actually no PEEP delivery. So whatever the recruitment is occurring, it is the lungs are, the functional residual capacity is not being maintained. So the main advantage of this TP's resuscitator is the reliability delivery of pressures, both PIP as well as a PEEP. But the PEEP is the main important thing that will generate your functional residual capacity and keep the alveoli open, which is very important during the transition, because as we know that the fetal lungs are filled with fluid, and during delivery, the lungs, the alveoli get irritated, and it is very important to maintain the FRC. We can adjust the PIP as well so that we can avoid the maximum pressures, and we can start from somewhere between 22 or 25 for more premature babies. Uh, then, we required quite a lot flow in this baby to operate this. So there are ports where we are in one port, as you can see, in one port we can attach the flow meter, which is attached to the blender, because the FiO2 will be regulated only with the help of oxygen blender. So the flow is connected to the one of the ports, and also here there is an option of maximum pressure relief valve. So if we set at maximum pressure, we cannot go above that. So the main advantage is precise and delivery of PIP, PEEP, and with the help of oxygen blender, you can give precise oxygen also. So it is a very good tool, and it is very advantageous, and many studies have studied this device and has been found to be very useful in NRP. So this device has been incorporated already in the guidelines as well. So if possible, we can use. The other advantage is when the premature babies with RDS develop respiratory distress in the labor room itself, you can just give PEEP as well. That CPAP also can be given for the transient period. You just don't require another device to give CPAP, like bubble CPAP or thing. You can, while the baby is being transported, you can just adjust the PEEP, and you can just give the PEEP also. So it will act like a CPAP. So this is the dual advantage of this.
Thank you, ma'am. So as ma'am rightly said, it is very helpful for giving the CPAP to this baby. And from the first breath, we can give the CPAP to the baby. And the only disadvantage is that you cannot adjust the FiO2, you need a blender. So you have to make an arrangement of a blender, or at least air and oxygen point. You can connect it with the TPs, and just you can adjust the flow of air and oxygen, and accordingly you can calculate the FiO2, and then this common source can be attached to this. This can be used for transport also. If you have likewise, we have a transport incubator where we have a constant flow at a major FiO2. In that, we just connect this TP's resuscitator to the baby, and we can transport the baby with the TPs. Lot of people are trying to make a lot of use of it. For example, here we can see we have to adjust the mask so that there should not be any leak. It should cover the nose, it should cover the mouth. Then only you will be able to deliver the PEEP. But it's not possible if you are transporting the baby. So what people have tried, they have attached Ram's cannula to it, and Ram's cannula just fixed to the nose of the baby. So even during the transport, you don't have to put your hand won't be engaged. You just fix the Ram's cannula. Though this need to be evaluated whether how effective it will be and whether it really helps or not. But for short duration, for example, from shifting the baby from OT to NICU, we are using this, and yes, we are finding that it is working at present. Though there are no recommendation at present, but yes, this can be a technology which is very helpful. Even when you are giving TP's resuscitator for an intubated baby, for example, as sir told previously, we used to do insure technique. And if you do a bag and mask, and if with a routine self-inflating bag, you will lose the PEEP. So instead of that, we use this TP's resuscitator, even for the moving after giving the aliquot of surfactant, so that we don't lose the PEEP. Next is advanced transport incubator and ventilator. Again, Anand sir, Anand Butra sir.
Yeah, good morning, everyone.
Good morning, sir.
So, as we are talking about so many technologies over here, this is one technology which is existent for some time now. Neonatal transport had always been a big challenge, and availability of such the picture that you have shown is from Dragger, this incubator, ventilator, trolley. So it has a lot of things inbuilt, so we can give with this CPAP, connecting it with a non-invasive interface, or a high flow nasal cannula can be attached with this, or we can also transport the baby who is intubated with the CMV mode available in this particular incubator ventilator trolley. So the incubator is there, so we can transport extremely preterm babies, maintaining their temperature as well as the humidity, routinely used for transporting the babies in hospital from labor room or the OT to the NICUs, or from NICUs to different departments like for CT or MRIs. But well, inter-hospital transport becomes very smooth when we have this type of technology. So for long-term distance, we had been transporting babies from 200, 300 kilometers, and makes a lot of sense when we have this machine with us, with basically an inbuilt compressor. So we have air, we have a FiO2 meter, we can give appropriate FiO2 to these tiny babies with appropriate PEEP and PIPs. So apart from that, the en route transport, we can have phototherapy machines that can be used, suctions can be added on, and as I told you that it can be used for non-invasive ventilation, especially CPAP as well as HFNC. So extremely good. A lot of jugards have been done where people have used incubator and similar sort of machine mechanical ventilators which are neonatal friendly. We have CPAP and CMV mode that can be used similarly, but it's a very smooth one. The transport becomes very smooth. The entire machine easily moves into your ambulance. It's pretty jerkless and has windows to serve you, take care of the baby en route. So a lot of advantage to that. Vis-a-vis, if you see a conventional ICU ventilator, so it must have turbine to generate the flow. Again, to have a turbine-based neonatal transport ventilator, it's available. It's extremely costly, and it has lots of modes which probably we don't need during the transport. And if you see the compressor to be put in the ambulance, then the ambulance should have a lot of power generation to have to support the compressor, so it's not feasible. So a wonderful invention for transporting sick babies.
Right, sir. I think Drager's transport incubator and ventilator is the only ventilator which neonatal ventilator which has a FDA approval. So one thing, as sir rightly told, you have to see for this FiO2 meter, because there is no other way to monitor oxygen, how much oxygen you are giving, because it runs on a oxygen cylinder. So if by suppose you are traveling a long distance and somehow the pressure of the oxygen cylinder goes down, there is no way to know how much oxygen baby is getting. So the FiO2 meter is must in this. Thank you, sir. Then management of recent technologies are upgraded in the management of birth asphyxia. Our understanding is increasing regarding how birth asphyxia causing damage to the brain. And since then, a lot of inventions has been done. A lot of claims had been done ki how our technology is better than other. Jaya Chandra, sir, what is?
Yes, we all know total body cooling is the standard of care now for moderate to severe perinatal asphyxia, along with other intensive care support and good nursing input. You know, traditionally in the past we used ice packs, then changed into phase changing material. Now lots of products are available which is servo controlled to do the whole body cooling. So the main advantages of the new machines are it provides very stable temperature control during the induction. Especially we can achieve the desired temperature very quickly. We can say within half an hour. We can maintain the desired temperature during the 72 hours of cooling, and we can have the rewarming over 6 to 8 hours in the desired temperature increment, for example, up to 0.5 degree per hour. So during the all three phases of cooling, we got better control without much fluctuation in temperature. Okay, because we shouldn't be doing any harm while cooling. And moreover to that, it needs less nursing input, because we can just set the desired temperature and machine will do the job. And it's more easy to use. And different machines are available now. Ticotherm, Criticool, Neotherm, and also a product called
trim is available. So 4 or 5 brands are available now. Whichever is matching with your financial budget, we can purchase it. And they all provide training to the doctors and nurses how to use it, because it doesn't matter which car or which Porsche machine you got, unless we know how to do it, we may doing harm. And having said all these things, in our country, the most commonly used machine is Miracradle. Even we are using it, we are changing into servo control one. Okay, I think most of the studies happened here is based on Miracradle itself. So that's my take on this high-tech cooling machines. Thank you.
So recently machines have come which can be used for adults also and for neonatal patients also. So if your is not an exclusive pediatric hospital, suppose you are working in a hospital which is adult based also. So if you see recent guidelines of ACLS, they also advise body cooling after a resuscitation. So you can just convince by this way that you can purchase this for the treatment of these adult patients also. So same machine can be used. Only thing is that interface what we are using for cooling the baby, cooling the patient. Thank you, sir. Yes. Now this again new technology in the management. I won't say new technology, but this is how we learn. We find the difficulties and then we learn. This is amplitude integrated electroencephalogram or AEG. So Shishi sir, can you tell about this? Shishi sir?
Is it Shishir Chakri or Shishir Agarwal?
Yes, sir. Hello.
It's written Shishir Chakri.
Sorry, sir. Sir, can you take on this?
Okay. Birth asphyxia is something which we have to deal on a regular basis, and there's a very thin line for birth asphyxia. Video EEG and amplitude integrated electroencephalography is something which is in regular use nowadays, and which we should be doing at a tertiary level care center, and to assess the level of birth asphyxia. Thank you.
Thank you, sir. As sir rightly told, video EEG and amplitude EEG can be amplitude integrated EEG can help in the monitoring of the birth asphyxia, because it's very difficult to apply all these 40 leads on the head of a baby and monitor EEG to see background changes and breakthrough convulsions, which we may not be able to pick up in a EEG of short span of 30 minutes or 60 minutes. So what they did, they integrated it, amplitude integrated technologies device for that. Only 5 electrodes are there. You just apply 5 electrodes and you will be able to get at least 24 hours, even the prolong. You can monitor prolonged EEG with that. Thank you, sir.
Sir, one point.
Yes, sir.
I know it's very good and ideal part of doing total body cooling. I used it in abroad. So it's not difficult to interpret. Any junior doctor can, even nurses
Right.
can interpret it. It's not that technically difficult compared to traditional EEG. The only problem, I want to use it, but how much we can charge from the patients buying a 15 lakhs rupees investing on EEG, and we'll be cooling maybe a couple of cases per month.
Right.
So that's the only problem we are facing here.
Yes.
But I think even in UK at present, they use it as a part of the criteria for selecting the babies also.
Yes.
And not even now, maybe many years back, the amplitude integrated EEG was incorporated into a laptop. So that can be taken to wherever the referring unit, and we can connect that to the baby and evaluate what's the tracing before deciding to take the baby to a cooling center. I'm talking this about 10 years before when I was working there.
Yeah.
But now still we cannot buy it. We know machine is there, cost is issue.
Technology is initially very costly, sir, but with
Yeah,
time, definitely
true,
when we
true.
see that utilization is there, definitely it can come. Now we see this Ambu bag very routinely now. This is Ambu bag which has a peep wall, and there is a we can measure the PIP also. Sir, Sanjay sir, so can you
Yeah,
yes.
good morning.
Good morning, sir.
Basically, whenever we are discussing all these three devices, that means these are the three methodology. TPS resisted audio we have discussed in the previous part. This is absolutely good device. A proper PIP and PIP set can be given. Only the thing about that is the cost. It is a little
Yes.
bit costly instrument. That's part. And another thing, one part that blender is required for the giving the percentage of proper FI2. Second device, what you have mentioned, that Ambu bag with PIP wall. In this device, it's a good device. One little bit disadvantage is whatever the set PIP, actual PIP is going little bit less as compared to the set PIP. But a PIP properly been given with this device. Third device, what you have mentioned here, that a flow inflating bag. When we are discussing flow inflating bag, yes, PIP in PIP can be given, but the reliability is not clear. So these are the three devices. Whenever we are choosing out of these three devices, if it is a cost-effective device, I want to use at a periphery. The middle device at Ambu bag with a PIP wall will be little bit better. That is a cost-effective. But if you are on the scientific ground, if you want to go for, absolutely it should be or it must be a T-piece resuscitator as per the newer technology and of the delivery. In the newer technology, what we have discussed up till now, the cost is only factor. See, whenever you are bringing down the cost, when the cost will come down, majority of us,
Demanding.
if you are using the devices and if the flow of that devices is more across the market in the company, definitely cost will go down. So that is option for the cost. Thank you.
Definitely, sir. One more thing, one more difficulty what we face while ventilating a child. If suppose you are ventilator child with a bad lung and your PWP is quite high, and if you try to do the suction, because very tiny infants are there and inline suctions may not be available all the time of a appropriate site at all the center. So when you try to do the ambu bag with a normal self-inflating bag, you lose the PEEP and the patient desaturate very rapidly, and it takes a lot of time to recruit that patient again. So in that case, all these devices can be helped. This ambu bag with a PEEP wall can help to generate PEEP while bagging back to tube ventilation, and we can avoid the loss of PEEP. Thank you, sir. Yes, then technologies are there in the monitoring of patients also. There are a lot of changes are there, lot of new technologies are there. Shishir Agrawal, sir, can you guide us on this?
Yes. Monitoring is something which is the most important part of neonatal care. Without specific monitoring, uh, uh, it is all about monitoring a neonate 24/7, each and every minute, each and every second. And we need to monitor with different devices. There has to be central monitoring system. There has to be CCTV cameras, and there has to be one nursing staff on each and every device, or each and every baby. 24/7 access to all the cameras in NICU can be monitored on your phone. Uh, you can monitor the patient and staff activity. Monitoring is the most essential part of newborn care. Without monitoring, we cannot be successful in giving a quality care in newborn. Thank you.
Thank you, sir. So as sir rightly said, there are many technologies are there. We are getting a monitor which is specifically designed for the neonates so that they pick up even the poor signal from the neonatal pulses, and they are designed as per the NICU norms. Even their alarms are quite low. So these specific newborn monitors are there. Then central monitoring system, as we all know, it helps to monitor if you are sitting in a, even in your, you get access on your phone also. You can see your central monitor on your phone also if you are busy with some other activity.
So sorry to interrupt. We have about 15 minutes left.
Okay, okay. So this non-invasive hemoglobinometer. Yes, Kirti ma'am, can you talk on this?
Yeah. So as you have rightly pointed out, that monitoring a newborn infant, because newborn infants might not be showing signs and symptoms until they become very sick, and therefore it is very essential that we monitor them preemptively so that we optimize their treatment. Coming to the non-invasive hemoglobin monitor, I think this is a very good monitor. It's actually a co-oximeter, we call it. Along with hemoglobin, we can monitor other hemoglobin blood-related indices like carboxy, hemoglobin, methemoglobin, along with your routine oxygen saturation. So 7 parameters can be monitored in this device, and one of it is non-invasive hemoglobin monitor. The main principle of action of this device is that, as we know, that is spectrophotometry. As we know that when the light is traveled through any medium, it either it gets reflected or it gets absorbed. So the difference in the reflection from the tissue and the blood is different. So the difference between that is converted into a mathematical model, and through that we can get the hemoglobin levels in the babies. In premature and sick babies, we know that just for getting a hematocrit level, we have to prick them, and even a small volume of 1 ml or 0.5 ml repeatedly will lead to a lot of blood loss and subsequently anemia. So this device can be very useful. There are not much data from the neonates, but there are evidences from older infants and children, and the studies are also there from neonatal population as well. But the correlation between actual hematocrit level and this non-invasive hemoglobin monitoring is hemoglobin and actual hemoglobin from the blood uh, is quite well. The correlation, the band element relationship correlation is quite well with this device. So we can use this even in NICU setting. There are two types of devices. This is the commonly used, that we can see the continuous monitoring of hemoglobin, and the other ones which are available are spot hemoglobin, non-invasive, that can be monitored. So we can use it not only intraoperatively, we can use it in the day-to-day NICU practices. This will definitely help in reducing your sampling losses as well as avoid unnecessary blood transfusion, because the usual policy nowadays in NICU is restrictive transfusion. And yes, this is very essential that we can get an instant report in children who are in units who are very sick and can decide upon the need for blood transfusion. So this device is very, I think, is a future model, and it will be soon to be going to be used worldwide. In fact, in Western countries, it is still it has still been used in practice, but in our countries it might take some time because this is a costly device. We have this device in our unit. Recently, we got this device in our unit, and we are planning to start a project on this as well to see how it behaves in our population. Thank you.
Thank you. Next is this nano ETCO2 monitor, a very small device. So do we have sorry, Sidhu sir? Sidhu sir has not. Okay, this is a small device. It is ETCO2, but it's very tiny. And because of that, what we can see that it's just like of this size, and it doesn't increases the load on the ET also. So you can use it for the transport of newborns also, so that you can monitor ETCO2, whether the patient is extubated or not, whether you need to titrate your ventilatory settings during the transport or not. So it's a, and the reading is also very fast. It's not like you are connected and after few minutes you are getting the reading. Instant reading will be there. You can get the capnography, you can get the alarms, you can set the limit, everything, whatever you can do, you want to do on a capnograph, you can do with this small device.
Sir, how much it cost?
It's quite costly, sir. In lakhs.
10
It's in
lakhs.
lakhs. Okay. It's in lakhs, sir. Then technologies have changed in newborn screening also. Sir, we are running short, so short in time. Can you elaborate it fast
Yes.
on newborns?
That congenital deafness screening, of course, within the first month, we should screen for the congenital deafness. And by the end of the 3 months, we must confirm our diagnosis to have hearing aids. And by the end of the 6 months, if intervention is required, that should be finished. And OA is the best method for the screening of the deafness. Newborn screening, yes, that is good, because nowadays common disorders like the congenital hypothyroidism, galactosemia, G6PD deficiency, pyruvate kinase deficiency, then congenital adrenal hyperplasia, cystic fibrosis, lot of disorders we can screen, and if they are properly been treated in time, yes, neurodevelopment disability, what happens in the future can be prevented. That is a good part about newborn screening. Two types of newborn screening methods are available. Apart from that, newborn screening is a little bit different part. But for the metabolic screening, these are the two methods, that TMS, that tandem mass spectrometry, and second is the gas chromatography. With this, actually, ions are separated, and various charge ions, they are been identified with these two methods. About the advanced fetal scan, this has already been mentioned, that early identification of the fetal congenital anomalies, and lot of advanced fetal scans are available, and we are picking up the complicated congenital heart diseases and lot of congenital diseases quite early part. So in that way, the decision making, counseling with the parents, everything can be possible with all these things. Thank you.
Yes, that's why we are getting very less cases of diaphragmatic hernia now. We are not getting that much complicated cases with a lot of anomalies which are undiagnosed. Because of this advanced fetal scan, we are not we are avoiding that kind of patients. Now this TMS, GCMS just 4 drop and you can avoid fatal disease. And that's a technology. That's why we want to discuss this. Just 4 drop of blood and you will get the report, and you can diagnose a rare diseases which can be fatal, which can cause limitations to the baby. Then for the training of staff and medical students, what are the recent advances?
Actually, this is a excellent and of course rewarding advancement in the technology, because everything nowadays, even medical colleges, there are big simulation lab, and this is compulsory as per norm of NMC as well as the National Board of Examination. And the teaching to the students is as like a actual case scenario, and they are facing these various cases, complicated cases, with as actually they are doing like that. With this, what is the development? Yes, development of the cognitive skills, communication skills, everything can be possible, and how to go with the teamwork. So that is the three important parts of the simulation. In fact, whenever we are discussing the simulation, especially intubation, even actually ECG with the monitoring, everything can be possible, even putting the central line, a lot of things can be possible. Even our IAPLS actually doing a lot of things. Even now in the NRP advanced, we are going with the simulations, and with the teamwork, how we should handle this situation. Really, rather than have a passive teaching, this is called as active teaching. With you do the mistakes will be corrected by the assessors, and there will be rectification in the mistakes. That is good methodology for teaching also.
Yes, sir. This is the future. Then apps in medical field. Anand sir, can you guide us on this? How apps are helping in learning of by students and nursing staff?
Yeah, this is actually the future, and not I will say the future. It is actually the present, and whatsoever we are doing, there is a big change in technology because of availability of this device called as smartphones, which is a mini computer. And with this available, I am sitting here from Orange City, Nagpur, uh, available to all of you. I'm sure a lot of hosts will be seeing this panel discussion live across the globe through an app called Zoom. So this is an era of Zoom, and Nilesh and myself, we are blessed to be working with a man, Dr. Satish Devpujari, who can aptly called as an app man, and has developed a lot of apps which can be used in the field of neonatology. He sensed this and made the things very easy for us. So if we divide the medical apps which are available, it can be done for multiple purposes, from hospital information system, from monitoring the patients, treating the patients, and we can do have lot of algorithms which can be practiced. This medical apps is the current as well as the future technology that is going to be a lot helpful for I think someone muted me. So it's going to be the present as well as the future of the country. If you see one by one some of the apps that Nilesh is displaying on the screen, this is the dehydration app that you have been calculating, or an ABG app that is there. So you just have to put the numbers over there. What is the pH? What is the CO2? And for the first time when we were developing these apps, we came to know that there are so many calculated values in the machines. So actual measured values are just to have is a pH and the CO2, and rest of the things are calculated. So you can get ADO2, you can get the metabolic acidosis, interpretation, possible diagnosis, and then how to act. So you just put in the number, you put your pH, what FiO2 the patient is on, what PO2 that you are getting from an arterial blood gas machine, and you put CO2. And if you see the cursor of CO2, if it's moving, the bicarb cursor is automatically moving because this is a calculated value. Then you press get the information what is there, you get the interpretation on the top of the screen. If it's a metabolic acidosis, it guides you further to check your electrolytes, and you see what sort of an anion gap it is there, if it's a low or normal or a high anion gap, and accordingly what's the diagnosis and what you need to do. And it's at the tip of your fingers, so you don't have to remember all those things. So now if it's a high anion gap, so what's the delta delta gap? Similarly, if you see other applications, lot of these are available. There are some which are just for the teaching purpose, like this is an alveolar gas tutor. So here you can see the cardiorespiratory interpretation along with EtCO2 and your cardiac cycles and respiratory cycle. So it's a very good tool to teach medical students, especially undergraduates, and can teach the basic physiological principles with a lot of diagrams, pictorials, and becomes teaching uh, way ahead to learn the things. It's a very nice way of learning the uh, things. Just Sanjay sir said that simulation. So lot of apps are available for simulation technology. So for the teaching purpose. So this is one of them. Apart from that, this neonatal resuscitation program app that have been developed and adopted by both NNF as well as IIP recently. So that's a wonderful app to practice. That's the NRI app, Neonatal Resuscitation Information app, which is there. So you just start this app. So it has an inbuilt basically timer, which is there, and it keeps on guiding you. So someone has to just keep on pressing what things are going on, and it will keep on guiding you. Now you have to start initial steps, or you have to go for a positive pressure ventilation. Have you chosen the mask properly or not? Have you checked for MR SOPA? So all those things are there, and keeps it has a voice inbuilt, so it keeps on guiding you. And there are many medical apps that we see here, the drug doses and the calculation apps, which are very useful in uh, neonatology. So you can choose the inotropes. So there are apps like Lexicom, which is there, Medscape is there, and even drug calculator app is there, IIP drug formulary app is there. So there are so many apps which keeps on guiding you for the various infusions. So you need not calculate GDR or the dosing of the inotropes. Just place the weight, what medicine that you want to do. So it will give you the guidance, how much fluid you have to take, how much drug you have to take. Some of them will have the voice control. Someone will have just display. Few of these apps are available free of cost. Few requires annual subscription, but it's worth spending. So many of these apps are worth spending, and few of these apps which are connected with the medical textbooks as well. So like the Nelson textbook, you have the textbook and you have get an app for that. So you can just download the app, you can read your articles, you can interact. So the textbooks takes revised edition takes few years to come. So with the availability of app, there is a regular updates which are available. So it means a lot. So it's a lot to talk on the apps. Perhaps if there are some questions we can take on it.
Sir, can you talk on this Algoman app?
Yeah, it's another beautiful app developed again by Dr. Satish Dev Pujari. So it empowers each one of us to develop your own application. So this is available online. So just have to download this app, Algoman, and you put any algorithm. So if suppose you make an algorithm that for an NICU entry, what you are going to do. So someone is coming, you have to use your biometrics, then change your clothes, put on the cap, personal protective equipments, go for a hand washing, follow this 2 minutes of hand washing. So XYZ, any protocol you have made. So you just put it down on the paper and give the directions that if it is yes, it's you are going to do this. If it is no, you are going to do this. And this Algoman app is going to convert whatsoever algorithm you have formed into a medical app. So you can create your own medical apps using this. So you have your own algorithms. Most of us do have our own algorithm. So we can have a battery of medical apps developed by the India. And uh, I think so the highest downloads of these apps, medical apps which are available, which are manufactured in our own country, the maximum users are from United States or the UK or Russia or China. So it's a time for us to use our own apps, make our own apps, and it's time to take this local products and make it global. It's already global now. So it's a wonderful app. Let's try Algoman.
Thank you, sir. So So we can create our own algorithm and what we say, what our own protocol. This is a unit protocol. So you can just use this algoman and create your soft copy or this app of your own institute, so that all algorithms, all protocols will be there. Then technology in preventing lung injury, we are going more and more non-invasive. Yes, Jay Chandra sir.
Yes, the norm of current neonatal care is gentle ventilation, but aggressive nutrition. So basically what we are aiming is to provide the ventilatory support and oxygenation without any invasive tube like ET tube in the trachea or lungs. So, but at the same time, we have to provide oxygenation, then ventilation and prevent distress. But the advantage of non-invasive, it is with much patient tolerance and comfort, at the same time preventing ventilatory induced lung injury. Different methods are available, the traditional CPAP, bubble CPAP to flow-driven CPAP, and we use this BiPAP or CPAP. Now more people are using NIPP. So whichever is available in your unit, whichever your nurses are comfortable, whichever your junior doctors are comfortable, select that machine. So that is the main message I want to convey. All are useful. There are some minor difference, some benefits and some advantages, disadvantages between these three categories. But whichever you are comfortable, select such method. All of them prevent ventilator-induced lung injury. And the other thing which even I learned from preparing this talk is about NAVA, the neurally adjusted ventilatory support assist, newly adjusted ventilatory assist. Basically, it's a weaning mode of ventilation, and the main difference is it uses the signal from the diaphragm to trigger the ventilation. So there is, diaphragmatic movement is very helpful in detecting the baby's respiratory drive, and so babies are getting full control of the breathing pattern and improved patient ventilator interaction and synchrony. So it seems to be very newly coming up, but I'm not using it. I don't know any of you are using it.
Very few centers are
using it. So you put sensor in the diaphragm area.
Yes.
Okay.
So even when the patient initiate the breathing, means before there is hardly any change in the air volume inside the airway, the ventilator picks it up.
Yeah.
And that's how it helps in the synchronization of
very sensitive
patient ventilator.
Very good for weaning, isn't it?
Yes.
Okay.
It is good for this neonatology also, and even in pediatrics and adult also they are using this.
Okay. Good.
Now this technology, it's look very simple that they are using non-invasive ventilator, but it's create a lot of technology to adapt to non-invasive part of non-invasive interfaces. You have to compensate air leak.
Yeah.
You have to make changes in so many things. So understanding physiology, understanding how we are evolving in ventilation help in creating such devices like non-invasive ventilation. Thank you, sir. Then there are a lot of use of USG. We know all that neurosonogram we are doing USG abdomen line localization, that we are all doing. Recently, there is a use of ultrasound in lung pathology detection in newborn. Yes, Kirti ma'am, can you guide us? Hello. Dr. Kirti ma'am?
Yes. Hello. Am I audible? Hello.
Yes.
Hello. Am I audible?
Yes, ma'am, you are audible.
Yeah. I think, so the use of lung ultrasound in NICU is coming up very rapidly in last few years, like last 2 years, maybe I say there are a lot of literature which is coming up on use of lung ultrasound in NICU. So the basic thing about lung ultrasound is we have to see how it can be useful for determination of pneumothoraxes, a lot of using of lung ultrasound, and for determination of, like, they have used the lung ultrasound score to determine which baby will require surfactant, which baby doesn't require surfactant and can be managed. Am I audible? That somebody has, hello?
Hello. Yes, you are audible.
Okay. So there has been a lot of use of lung ultrasound specifically to determine whether they're in the acute deterioration as well, like pneumothoraces. Then we can see for the fluids in the lung, pleural effusions can also be detected, but whether the lungs are wet or whether the lungs are dry, it can also be helpful in guiding somewhat how to ventilate as well, whether the lungs are recruited, collapses, consolidation. All these things can be determined with the help of lung ultrasound. So yes, this is a technology, and this is being used quite a lot recently.
Yes. So very rapidly progressing this use of USG in intensive care, not in neonatology, in everywhere. So with this, you can just, as ma'am rightly told, even the decision of whether to give this surfactant or not can be done just by putting a probe on a chest. Okay, so it will tell you, it will help to distinguish between the TTN and even the RDS. So specific features are there, specific scoring system is there. So along with clinical scoring and ultrasound scoring, we can decide whether this baby will be benefited with surfactant or not.
So
Thank
it's
you, ma'am.
like the second stethoscope of neonatologist.
Yes.
Ultrasound has become the second stethoscope of
Yeah, exactly,
nephrologists.
exactly.
Yes, yes.
One more
Rightly
advantage
said,
of
sir.
the ultrasound is the exposure for the radiation, because that has been avoided. That is
Yes, yes,
a additional advantage over the CT and
yes.
other.
Definitely in future we will get this lot of use of USG in critical care. Thank you, madam. Then again, use of technology in medical legal safety. This is a era of medical legal cases, and we should be saving ourselves also. Yes, Shishir Agarwal sir, can you guide us on this? Shishir sir.
Yeah, use of technology in medical safety, that is something really, really important. In our setup, we have CCTV cameras and audio video cameras installed everywhere. And one thing what we do is that whenever we are counting the patient, we counsel the patient twice a day, and we counsel the attendant. We make a live video of those patients while we are counseling them about the current condition of the baby and about the procedures to be done about for the baby. And we share those, and we have a common group of our hospital and resident doctors, and we share that video in that we have each and every, right from the day the baby is admitted and right from the day baby is discharged, every time 2 day twice we do the counseling on video recording. We make audio video recordings, and we keep that video uh, counseling video, and in written consent is also taken twice every day. Every time patient who is visiting the NICU, if some attendants relatives is going to visit the NICU and want to see the baby, we take the in written consent of each and every person who is visiting the NICU and trying to look at the baby. And we make sure that video of attendants who are listening about the prognosis of the baby, we have that video, and we keep those video in our permanent record. Another thing is retinal cameras to document retinopathy of prematurity. That is something which is okay, which is used in some higher centers. I'm not using it right now, but yes, for the medical legal purpose, we need to make, because most of the time that patient refuse to say that doctor didn't tell us this, doctor didn't tell us that when we were admitting the patient, or he did not tell me about the prognosis of the baby. So we make sure that whatever each and every conversation which we have with the attendants of the patient, we make video each and every time, and we store it. Thank you.
Thank you, sir. Then digital note keeping. Dr. Jaya, can you?
Yeah, just very briefly, I will cover this. It's very useful. You know, the long-term storage of our notes will be very easy with digital note writing. I'm talking about paperless NICU, which we have implemented. You know, the size of each ICU notes when they stay for 1 month, and we have to keep it for the n number of years. So everything is digitalized notes. All staff write notes with tab or laptop. The benefits are, one is storage benefit, next standard data entry. Different doctors and different nurses write the notes in different format. Once we got a standard format, whatever data we want to be there will be there. And the handwriting is a big issue. You know, even I used to say to my nurses, I tried many years to improve my handwriting. I couldn't do that, so I implemented digital notes, because once we have our own handwriting, it's very difficult to change, especially at this age. So handwriting legibility issues are not there, and access to clinical notes from anywhere. I can look at my mobile with that. So, and I can see what my junior doctor has written, what my colleague nurse has written. So we can read it, we can amend it. Everything is possible now. And also for audit and research purposes, we can extract the data very easily instead of looking to hundreds of clinical notes. So in this digital world, I think we should be moving forward for digital notes, but at the same time, we have to make sure that the communication and documentation need to be written in paper, signed it, and then uploaded into the patient file. Because for medical legal to cover our back, we know there is audio and video recording, but more than that, the court will ask for the signature. So whatever I communicate to the family, it will be documented. I'm from Kerala, it will be documented in Malayalam. I will sign it, the sister as a witness will sign it, and the parent will sign it. And every day we'll upload that into patient notes. So that also need to be taken care when we are moving from paper to digital notes. Thank you.
Thank you. Even this digitalization has helped, it has reduced a lot of work also, because we send all our culture to one lab, and that particular microbiologist have a software. So whatever report we get, suppose we are getting X number of bacteria and with particular sensitivity. And if I ask, sir, I need an antibiogram, he gives me within 15 minutes. So initially you have to just see all the reports, you have to enter what bacteria, what sensitivity, what resistance. Now this is because of the digitalization. He gives me report within 15 minutes of antibiogram of complete year. So you can create your own protocols also. We can select our first line antibiotics. We can make changes. We can shuffle the antibiotics accordingly. Thank you. So again, considering recent technology, it's not something that we are getting everything from the outside of India. Devpujari sir has come with this ventilator. This is Prana Setu. The name is Prana Setu. He has developed a complete non-invasive ventilation in a one machine. So some unique thing is there, like this inbuilt humidifier is there. So you don't need to purchase a separate humidifier. Humidifier is on the top of ventilator. And this is something new I am seeing for the first time. So so it cuts the cost. And this tubing is same. It's not something that you have to purchase a separate tubing to use this. The same tubing which is available in the market can be used for this. And all the non-invasive are in the same thing, like high flow nasal cannula, CPAP, BiPAP. Then the pressure feedback is there in high flow nasal cannula. Pressure feedback is there. Then CPAP with a backup mode is there. This is something which is for the first time. As we all have seen, we all have used high flow nasal cannula, but we don't know actually what pressure is going. What we see that we have set a flow of 15 liters and 15 liter is going. But you can actually see the graph here even in high flow nasal cannula and CPAP. You can see all these beautiful graphics. You can see the patient efforts. So we can take a separate discussion on this, but this is a technology we are bringing it, and it is a reality now. As a lot of machines has been handed over to different institute, and lot of upcoming work is being done by Dr. Devpujari in the field of this technology and ventilation. And recently is working mostly on the ventilation. So calibration device, which is very costly. If you want to see what my ventilator is giving appropriate tidal volume or not, if you want to calibrate it, the machine is quite costly. So it will be a very low price machine which will be available for the calibration of the ventilator. Then turbine flow, the NIV will be there, which can be used for the transport, and home-based ventilators will be there very soon. And he's working on the high-end ventilators also. Thank you. If there are any questions, we can discuss that.
Can I ask Dr. Sanjay Gorpade sir? Hello.
Yes, yes, sir. Yes.
Yes, sir. Would you like to add some more few points on medical legal issues, that how should we handle medical legal issues, because it is an era of medical legal issues. So what other things we need to take care for this medical legal issues?
Basically, medical legal cases, when that will be happen, that means whenever there is a communication gap, because this is the most important part in our day-to-day practice, especially in a private practice. We are giving the maximum time for the medical treatment of the patient, but we are giving the minimum time for the counseling. So do counsel, do some counsel, like that your cycle must be. And if the relation of the patient with the patient's parent with the doctor is good, definitely number of medical legal cases will go down. Number two, record has got a tremendous importance in medical legal aspects. And this is a lagging in private practice. We are in a hurry of seeing the patients, taking rounds, doing lot of work. So in that case, like our medical colleges, we must do right counsel, do right counsel. You can add in counseling side writing whatever the things, and whatever we have written. And if you want to take the digital record, the scan record must be, because that signature is very important. Seen by who? Yes, seen by is there, but your signature must be there. That is the evidence that you have seen the patient. So in the medical legal aspect, counseling is one. Second, written record is two. Third, signing the record is three. Fourth, various types of the consent you must take, but before that, explain to the relatives if possible video recording, because nowadays video recording is available in all the NISUs. In fact, in some of the NISU, just I inspected yesterday's NISU, they have the counseling group with the video recording, and they're keeping that record in their computer. So whenever actually something happens, this will be the evidence in front of them. So whatever the record, they can be scanned and we can keep in the digital record also. This will definitely minimize the whatever things are there. Second thing, in the whenever you are taking the consent, not the printed consent. Apart from the printed consent, the preferably the consent must be in the regional language, which is understandable by the parents, and in the written handwriting. That should be additional part whenever we are taking the consent. So these are the certain things you must learn whenever you are taking the medical aspect cover in NISU. One more thing, what happens commonly in NISU, that is a medical negligence that happens, that is IV extravasation. And this is a grave grievance, and definitely nothing can be saved that doctor, because that IV extravasation is one important part. And second part about the ROPs, lot of cases of the ROPs are coming up. So when you are managing the NISU, ROP screening in time as per protocol is must. That will be preventable from the board point of view. That will prevent the vision of the patients as well as prevent the medical legal aspects also. Thank you.
And that's why these retinal cameras are important.
Yeah.
Because patient may say that there was unnecessary laser was done and my baby is now suffering from tube vision or peripheral vision is lost. So in that case, this retinal cam can help. Yes, sir.
Excuse me, sir. Due to constraint of time,
Okay.
we shall be
Thank you.
granted.
I thank NNF and organizing committee for arranging this panel, and I thank all the panelists. Thank you, sir. Thank you.
Thank you, moderator and the panelists. We would like to extend our token of appreciation. I request the moderator to just give the flowers to the panelists.
Can you share the recording of this with us on the group, please?
I would like to call the panelists to give token of appreciation to the moderator. Thank you, sir. Now we have a plenary in hall here by UNICEF and IAP. I would like to request all the families, everyone to join in the hall here.
Thank you. Can we leave now?
So, I'm audible. So who has else? Who has came? Students, those who are participating, please come in front. Please come in front. Please come in front. Otherwise, nobody will recognize you. Come in front. come in front and sit A, B, C, D, any of them.
Choose whichever number you like.
No, we will take out the chit.
Sit होगी क्या?
हाँ, chit नहीं अभी हुई नहीं है अभी.
फिर कर दो ना.
आप बैठो ना, अभी सारे आ तो जाएं. नहीं आप बैठो ना आप. Chit is there, chit is there. Yeah, 10 seconds for each for question. I'll be explaining the rules, so you listen carefully. So what happened? Dr. Ravi Sachan, the collection of chits. No, kuch facilitator, that's okay. So why is he writing?
This is for you to give it to introduce. They tell them that these are all helping us.
Okay, that's fine. Wow, this is got experience.
No, that's just something to help you. That's all.
No, sir, really it is.
Scorekeepers.
Yes. Thank you so much. Thank you. No, let the Dr. Sasidhar do these things. Yeah, Dr. Sasidhar.
You need to tell him so that he will.
Yeah, this is your honor. Please do that honor for me. Who has not come yet? So team from West Zone, FMC. So you are Dr. Sarvesh and Dr. Okay, fine. So East Zone, not yet. Can you call if you know? And North Zone you are. So what's your name? Sukanya and Soumya from IMS. Okay, that's good. So North came and West came, and then who's this from Central? You are Central. Okay. So South and Southeast is still to come. So if you know each other, then can you please call them? Otherwise, I'm sending. ये fan कुछ open fan, it's getting a little hot. Fan. So timekeeper and scorer. Dr. Divakar, where you are sitting? हाँ कहाँ पे? नहीं नहीं पीछे क्यों यार, यहीं आओ ना ऊपर. और क्या? And where is one mic each mic table? One table each mic. Every table. Six mics will be required. Are they working? So get it 3 more. Yeah.
You have more mics, huh? Mics ಜಾಸ್ತಿ ಇದೆಯಾ? ಅವ್ರಿಗೆ ಕೊಡ್ಬೇಕು, participant ಕೇಳಕ್ಕೆ ಕೊಡ್ಬೇಕಲ್ಲ ಇವರೇ.
Yeah, in front of me, because that will be easier. No, at least participants should be, see you.
Panelists will be sitting there.
No, it is the judges will be sitting there. Yeah, you can sit next to the timer. Yeah, you can keep the and she'll be going to assist you. Na, just keep a look there, है ना? Just overall देखते रहना and you will announce that. Sneha, Praveen, and Sunil. Do you have number? Sorry? Okay. So, take the number from the group and please call. Everyone? All the 3 teams? Okay. Okay, just call is the another team. Yeah. East central team, I think. Central, you are the central team from the UP. From where you are? Osmania. Okay, it is a central actually. And then you are from the FMC. Okay. So call another team also, please. So you can take the number from here and you call. Whosoever it is, team is not here. And please check all working or not. They are working. Please check. Cable. Okay. कभी ये याद आया. And who will be the volunteer? Supritha. And he is assisting in the scoring. And you and where is Ratnesh? Okay, Dr. Divakar, you will be helping me at the stage. Junior, can you do the scoring independently or not?
I can do so, but ma'am said she wants one
No, one senior to be there, but I need one senior to be. No. Huh? नहीं थोड़ी देर में
No, sir. Lot of. It's raining. Careful.
Hall B. No, ठीक है, that's fine, that's fine. थोड़ी देर में. What? This same sheet I have shared with you.
Oh, you have submitted the same thing.
No, not submitted. It is for our internal record. What is the name?
Sir, here it is you, Allavarappu. Chaudhary spelling CHOUDHUR.
So don't worry. You have to write your own. Your name. पीछे पीछे पीछे.
It's raining.
Internal communication.
So हाँ आ रहे उधर. Junior, can you do it? Scoring on your own. Yeah. I'll just indicate you to whom it is to be direct question, and I'll just indicate you. Yeah. I will discuss you. I will say this is the right question, and team goes to and 10 correct marks, or that I will hint you, right? And Dr. Divakar, what you need to do? Come here.
Check.
On.
Check.
Yeah. Please do that.
Check.
Dr. Jagdish, na? Dr. Jagdish. Who's the? Who's Dr. Jagdish? Huh? He is, na? Actually, Dr. Jagdish, what I do, either you support me at my stage or you score at the scoring. Where would you like to comfortable? In the support, you have already done the quiz process, and you know that. You know? So what you are supposed, I think Dr. Shashidhar can also. Actually, the chit will be collected and screening of the chit will be required.
So in fact, will be I have others you are supposed to write on the chip. The direct will answer.
Okay.
पटना वाली
पटना वाला और कानपुर. We didn't join. Akash, Dr. Akash. Patna, Dr. Sneha and Dr. Sunil. Calling us, she's not attending. हाँ ये से बता देगा ఎక్కడ తీసుకో అక్కడ తీసుకుని
That is why these are unfortunate.
உங்களுக்கு டைம் இருக்குமா நான் காலையில் எழுப்பிடுறேன். Central zone. Yes. Drop a message in the line of control. Nobody responded for the last 15 minutes. On the way, you are on the way. I don't know. I don't know. With the advantage, they will come in time.
So we will start for the inauguration, you know. So I'll invite you, both of you, to.
Good afternoon. Welcome all to this coveted final round, national level round for NNF PG quiz for the year 2021. This is the moment that I think all of you have been waiting for. And this has been very competitive year where the best 6 teams have qualified for this round. So to conduct this round, I'm the local coordinator. I'm Dr. Shashidhar from St. John's, Bangalore. We have a great team here, also led by Dr. Jagdish. We'll have 6 teams here labeled from A to F, A, B, C, D, E, F. The F team will come and you will have to come and pick the chits. We will invite you, and whatever chits you get on the lottery will be your team number, right? And as you must be aware, we have a chit system, and you have to start writing your team names in the
like this one
book that is there, and you have to tear it and give it to the chit collectors. You can maybe start doing that and take the book with you, whichever team you go. And for collection of chits, we have Dr. Suprita,
yeah,
and Dr. Ratnesh Kumar, and Kasturi. So all 3 of you will be standing behind the participants, and once the team time is up, you have to collect the chits.
In front of the team.
In front of them?
Yeah.
Oh, please stand in front of them. We have our timekeeper, Dr. Anusha. We have scorekeepers, Dr. Dheeraj, Divakar, and Dr. Junior Prakash.
You'll be correcting.
We have the eminent judges here. If there are some problems or some referees which needs to be referred, they are Dr. Chandrakala from St. John's Medical College, Bangalore, and Dr. Jagdish Dalal from PGI Rohtak, Associate Professor and Head of Neonatology. Yeah. So may I welcome for this quiz program, please. Our President NNF.
Dr. Sasidhar.
Sir,
I welcome
Dr. Ranjan Kumar
Dr.
Pejawar,
Ranjan Pejawar, our Honorable NNF
Dr.
President,
Siddharth
and
Ramji, sir, please.
President-elect Professor Ramji.
And Dr. Dinesh
Yes, sir.
Tomar.
Sir, please come on the stage.
Sir, please.
And our Secretary General, Dr. Dinesh
Please.
Tomar. So, sir, this is our final round. So, yeah.
Yeah, so these are the 6 teams from all the 6 zones.
Sir, please come. Okay. Sir. Just hold on. Yeah, please take this one. Dr. Sasidhar, can you please come? Come on the stage.
Okay.
Dr. Sasidhar is the local coordinator for today's quiz. Dr. Chandkala and Dr. Jagdish. Yeah.
They're referees.
Most important.
Yeah.
So can I
Yeah,
please
yeah. Yes,
request
sir,
you to
I
light
would
the
like to
lamp, sir,
please, sir,
inaugurate the
invite
program.
you to just light the lamp, sir, for the inauguration. Yeah, yeah. I will not take a couple of minutes, not more than couple of minutes.
Can we switch off the fans, please?
Right. No, no, no.
Get started already.
Yes, sir. Yes. So can we have one photograph?
Yeah, okay.
Thank you to all the dignitaries for uh,
Leave it, leave it.
inaugurating the function.
Can we have, sir, one photograph here? One photograph, sir. Maybe. Sir, I would like to invite Dr. Ranjan Pejawar, sir, our president, to say a few words, sir.
Good afternoon. I hope you have had some juice and some food. The mind works better when it is not hypoglycemic. Sorry that it has been scheduled on the last day. We have taken a decision. Probably from the next conference, it will be at the end of the PG CME or advanced CME. That is what we did for nurses quiz. Second point is, we consider quiz as one of the important aspects of our annual activities and our nnecon. It is a healthy competition, amongst all finalists to enjoy and, if possible, win. And we all know that only 2 teams can win, and we have to enter the quiz with that in mind. This year, we have started giving a small support, even from the divisional rounds, so that the people who come for quiz will have some snacks, and the coordinator will have some money for communication and hiring the audio system and things like that. And hopefully we will look at the response and maybe hike it up a little bit next year. Dr. Siddharth Ramji is more generous than me, and I'm sure he'll do that. So end of the day, I have to acknowledge the hard work done to organize this quiz. It takes a lot of coordination. Dr. Ravi Sachan, the central coordinator for doctors quiz, Dr. Kumar Ankur, who is the central coordinator for the nurses quiz, Dr. Shashidhar, who is the local coordinator for the doctors quiz, and all those who help. I am very grateful to them. Thank you. And I wish all the best to all the participants. And the other man who has coordinated the coordinators is none other than our secretary, Dinesh Tomar. He deserves a special mention. All the best. May the best team win.
When we actually started this whole process, I asked Ravi to calculate how many rounds will be there total. So there will be roughly 180 rounds. So from 180 rounds, from college round, divisional, zonal, you are in the finale, so you are already a winners. Whosoever may be the first, second, third, it may be a slight margin and the luck on your particular day, but all 6 teams are the winners. Because you have had a long journey coming from your college to till this level, and I wish you all the best to all of you.
Thank you.
Not only in this quiz, but in your future life also.
So I request our incoming Honorable President, Professor Ramji, sir, to please say a few words, sir.
Well, I have really nothing to say. It's always gratifying to see young minds put their knowledge to test, I think it helps you read much more than what you normally would have done as part of an MD pediatric program, because the quiz is greater. But I think it also, you get to meet many friends. This is a journey that you all make, and I hope this bond that you create as part of the working for the quiz, not only in your own area, but across the country, will help you continue to network and do good for the newborn. So all the best to all of you, and what's that? No, mentors, what is it? The ad that goes?
Dimag ki
Dimag ki batti jala de. So all the best to all of you, and enjoy yourselves.
Thank you, Honorable President, sir, for your enlightening word and encouraging us. Thank you so much for taking out your busy schedule. Thank you so much, sir. Thank you, sir. Thank you. Thank you so much. So I request Dr. Sasidhar to please continue,
Please,
and
can
then
you can sit.
I request all the team members to please come, and one of your team member will come and take the chit from the.
Yeah, one from each team.
One from each team. One from each team. Take
You
a
can
chit.
take. Start taking, please. Okay. Whoever has the lucky hand.
One from each team.
Okay.
And what is that? And
okay, please
and
go to your respective teams.
Yeah. So whatever the chit is, you please rearrange yourself as per the chit.
Please switch off your mobile phones.
Please, and I request audience to please switch off or keep it in a silent mode. That should it should not disturb.
Please check the mic in front of you as well. And start writing your
Please sit
team
down.
names.
Please sit down. Notepad.
One writing pad.
Okay, just give me the notepad.
Okay, there you go.
And now, yeah, Dr. Sasidhar, please.
Yeah, so please start writing your team names, and you have to tear it and give it to our chit collectors. Please stand in front, all of you.
So please introduce yourself, your team.
So we'll have a round of introduction. Please tell us your name, your college, and the zone you're representing. Yeah.
So Dr. Sasidhar, you introduce yourself. That's fine.
So we have our chit collectors who are graciously and accepted our invitation. Dr. Suprita, Dr. Ratnesh, and Dr. Kasturi. We have a timekeeper, that is Dr. Junia, Dr. Anusha. Scorers are Dr. Junia and Dr. Dheeraj Divakar. So any conflicts or any questions will be referred to our judges, Dr. Chandrakala and Dr. Jagjit.
Okay, so it's done.
Yeah. So please start introducing yourself, your names, which college and which zone you represent.
Yeah. Please stand and face the audience, and you can introduce yourself, all the team members, your name and from where you are. You're representing institute.
You are representing South Zone.
South.
Southeast Zone.
Team F. Write down the Team F. Bangalore Medical College. East Zone. East Zone. Team East Zone. Team D South Zone. Team C.
Dr. Shaurja from AIMS Delhi representing North Zone.
North Zone.
Dr. Sukanya from AIMS New Delhi representing the North Zone.
Team B. Team B.
Dr. Kamla from Armed Forces Medical College representing West Zone.
West Zone. Okay.
Dr. Sarvesh from AFMC representing West Zone.
Okay. Team B is West Zone.
Dr. Aditya from Osmania Medical College representing Central Zone.
Central Zone. So Team A is Central Zone. So Dr. Divakar, can you please announce as per the team wise?
Representing Central Zone.
Yeah. Team A. Team E. Team E from East Zone. Team E from East Zone.
So we have Team A from Central Zone.
Fine. Yeah.
Team B from West Zone, Team C from North Zone, Team D, South Zone, Team E from East Zone, and Team F from Southeast Zone.
Okay, so I hope this is clear to all. So let's begin with though you have qualified for the several rounds and you know that what are the rules and regulations are there. So this is our participants list, and I hope it's clear. And for this today's quiz, we have got our honorable judges, Dr. Jagdeep Dalal, who is head and associate professor at the PGI Rohtak. And another is Dr. Chandrakala. She is head of department at St. John Medical College, and you all know. So we are just going brief through the quiz, the rules. The quiz will be conducted in the 6 rounds, and of these, last round will be the visual rounds. Right? In the first 3 rounds, the order will be from team A to team F. In the next 3 rounds, order will be from F to A. I hope it is clear. Each question carries 10 marks. Each question carries 10 marks, except for the visual rounds, which has got a 2 part. One is identification part, and another part will be some related to that questions. If you are able to answer that half part, you will be given 5 marks. If you are given right answer, correct answer for both the part, you will be awarded full marks. That is 10 marks. Number 1. Number 2, there will be a no passing, right? And there will be no passing marks. You cannot pass the question, right? And the participants are provided with the slips. Please mark their team name, identify whatever the pad you have given. You just write down the team E. For almost 6 rounds will be there. So at least 8 on 8 papers, you mark the team E, team E for all the 8 papers. And then you need to collect, our volunteers are there. They will collect the chit from you, and that will be handed over to the Dr. Sasidhar. And the Dr. Sasidhar will screen out what are the correct answer, and the Dr. Sasidhar will hand over to me. And then I will announce the marks. Is it clear? And remember, once I finish my question, the time starts only after that. Right? Suppose we'll have one mock round. Suppose I ask any question, and that time begins after my completing the question, and that you will given the 10 seconds for that. Right? Meanwhile, in the just after completing my question, the other teams, who are the indirect teams, right? They are supposed to write their chit or answer, whatever it is. And after 10 seconds, the direct team is supposed to respond. Clear? Is it clear? Any confusion, you can ask me again. I'll make it again. Yeah. Sorry? Yeah. First 5 round will be passed, right? And second round will be, there will be no pass. Because that is a visual round, everybody can see. So how can it be a pass round? Okay, fine. So I hope it is clear now. Okay. The scoring pattern, what we have given, just told you that 10 seconds are provided to, the 10 seconds are provided to each question. And stipulated time start at the end of the quiz facilitator's question and at the end of the 10 seconds, which will be signals by our timekeeper, right? They will ring the bell, and that after 10 seconds, you are supposed to respond the question, right? And during the same, this 10 seconds time, after team should correct the answer on the slip. So again, you can bell the ring, please. So this is our, I hope it is audible. Team A, is it audible? Yeah, please ring it again. Ring it again. Final? Okay. So, and if at all at the end of the round, if there is a tie amongst the 2 teams, then we'll have a tiebreaker rounds. Fine. So I hope we are ready to go. Best of luck and all the best. So we will have a round 1. So who is I'm just throwing a one question. Ready, right? So who is the chief minister? This question goes to team F. Who's the Chief Minister of Karnataka? You have to wait for 10 seconds, right? And whether you have people written. So if I said, who's the Chief Minister of Karnataka? Direct question, team 2F. She is supposed to wait for 10 seconds. And meanwhile, you are supposed to write, the Chief Minister of Karnataka. And then you are supposed to, collect the cheat. Again, I'm throwing the one question for the mock test, right? It is a direct question to team D. Who's the Prime Minister of India? Yeah. Collect the cheat. Collect the cheat. Collect the cheat. Do it like that. What is the mock test? Collect the cheat. You are supposed to collect all the three teams, and you are supposed to collect from all the three teams. Yeah, come in front, and you people have to be very fast. You have to run between the teams. So I hope still it is not working. Can we have another question for mock test? Is it okay? Huh? Fine. So direct question to team B. Who's the Home Minister of the country? Ten seconds. You have to keep an eye. Just after finishing my question, and just as I finish my question, you have to wait for 10 seconds and then ring the bell. Right? Is it okay again? Team A, are you ready? Team B, are you ready? Team C, are you ready? Ready? D, E, and F. Are you ready? Again, I'm asking. Okay, fine. So I hope everybody is clear now. So round one. So first 3 rounds we'll have start from the team A. So this first question goes to the team A. Direct question. As per the NFHS 5, how many babies under 6 months are exclusively breastfed? Okay, collect the cheat. Yeah. So direct team, please answer.
59%.
How much?
59.
59%. Okay, so this is the as per the NFHS 5 data is there. So it is a 59%. You said it is approximately 63 to 63.7%, which is close to 65%. So who has written? So it is the team C who has written the correct. It is a 64%. So team C will be given 5 marks, right? Clear? Okay. So team B, are you ready? Be attentive, right? So direct question to you. Ministry of Health and Family Welfare, Government of India has launched the program in 2015 to improve the quality of maternal and newborn during intra and immediate postpartum period through providers who are competent and confident. So what is the name of the program? Yeah, collect the chit. Yes.
नवजात शिशु सुरक्षा कार्यक्रम NSSK.
NSSK. Okay. So let's see what is the answer for this. It is a Dakshta program. It is the competent provider through providers. So let's see who has written. Okay. So direct team has not given a correct answer. So therefore the indirect question will be considered. Team D has written correct. It is a Dakshta program. So team D will be given 5 marks. Team F has given Dakshta correct answer. So team F will be given 5 marks. And the team C will be given 5 marks. It is Dakshta. Okay. So next question to team C. Are you ready? Yes. No, you have to speak. I am ready.
Yes, sir.
Just be attentive and confident. So next question to team C. As per the Sustainable Development Goal 2030, what is the NMR to be achieved? Okay.
12 per 1,000 live births. 12.
12. Okay. Let's see what is the answer. So C is absolutely right. It is a sustainable development goal which is 12 or less than 12. That will be right. So therefore, the direct team will be given 10 marks, and therefore indirect question answer will not be considered. Okay, that's good. So this is the our country's status, sustainable development goal and national health policy, and as per the INAP. See, and as per the SDG, all the three has already been achieved. Okay, that's fine. So next question goes to team D. Are you ready? Okay. So under the Pradhan Mantri Rashtriya Swasth Suraksha Mission, it is the first time in India that neonatal care has been included in a special care package, and how much amount of the rupees per day is included in advanced neonatal care package? Okay, so 450. So let's, what is the answer is? It is the 6,000 rupees per day. So is anyone has written? Okay, it is the team C which has written 6,000 per day. Okay, so team C will given a 5 marks. Okay, let's move to the next. Team E, are you ready? Okay. In case of sepsis in a young infant, a combination of oral and injectable form is a standard first-line antibiotic therapy in healthcare facilities. The NM will be given the first dose of each antibiotic before referral to a health facility. Which oral and injectable antibiotics ANM can give? You have to answer both oral as well as injectable. Okay, yes. Okay. Both injectable and oral. Okay, let's see what the answer is. So it is a combination of injection, gentamicin and oral amoxicillin is the appropriate choice of the treatment in young infant for the sepsis and the setting where the referral is not possible or it refused. So it is the two component which is to be answered. So therefore you will not be awarded any marks. And let's see who has given the. Team F has written gentamicin and amoxicillin oral injectable. That's absolutely correct. Team F will be given 5 marks. And the team C, again, it is injection, gentamicin and oral amoxicillin. That's a correct answer. So 5 marks, right? So 5 marks will be team C to 2 and team F. Okay, let's move to team F. Are you ready? Okay. As per the NFHS 5, the total neonatal mortality rate is. Okay. 23. Okay, let's see what this answer is. It is around 24.9 and which is around 25%. So 23, because this is a neonatal mortality rate which is very close to 1 and 2. We are struggling to come down in a 1. So that has to be very exactly. So let's see who has given the correct answer. So team B has given 24.9. That's good. Exactly. Team B will be given 5 marks. And team D 24.9. That's correct. Team D will be given 5 marks. And the C is given 25 per 1,000 live birth. That's also correct. So team C, D, and B will be given. So your answer will not be considered. Okay. So after the 1 round, I request Dr. Divakar to, yeah, please count it. So we'll be moving to the next round, and meanwhile, let's get the scorer count the time. Oh, sorry, marks. So are you ready?
Yes.
Team A? Yeah.
So at the end of round 1, the scores are Team A 0, Team B 5, Team C 35, Team D 10, Team E 0, and Team F is at 10 points.
Okay, so who's the leading team?
Leading team is team C with 35.
Okay, so team C is leading. Okay, fine. So can we move to the round 2? Team A, are you ready? Okay. So you have to fill in the diamonds with what is A and B. Yeah.
The baby is apneic or gasping, or the heart rate is less than 100.
Okay.
First diamond. The second diamond, the baby is having a labored breathing pattern requiring oxygen support.
Okay, let's see what happened. So she is absolutely right. It is the gasping or apneic breathing and heart rate is less than 100 beats per minute, and another box is labored breathing and cyanosis, and therefore the team A will give full marks. Okay. So we'll moving to the next team B. Are you ready?
Yes.
Okay. Oligosaccharides present in human milk, which inhibits Haemophilus influenzae. Particular oligosaccharides you have to name. Yeah. Collect the team. Yes.
No.
Let's see what is the answer. Glucosidated glycans. The oligosaccharides are carbohydrate polymer. In addition to their role in the nutrition, helps protect the infant because of their structural mimics specific bacterial antigen receptor, and it prevents the bacterial antigen attachment to the host mucosa. Fucosylated glycans specifically inhibits binding by H. Haemophilus influenzae. So let's see whose the answer is. Only one. Okay. Team C again. Yeah, that's okay. Acceptable. Team C is acceptable. So, yeah. So he has written something. No, lactoferrin is not there. HMO. Yeah, judges. Yeah, it is actually one. Okay, that's fine. So team C, are you ready?
Yes, sir.
Okay. So administration of high concentration of inspired oxygen without positive pressure in an infant with respiratory distress can lead to respiratory failure. Which is this phenomena called? Yeah.
Absorption atelectasis.
Yeah, let's. So let's see what the answer is. Has anybody written? Yeah, but it is written there in the. Okay, that's fine. Good. So the team C will get the full 10 marks. So team D ready? Okay. Oh, sorry. So identify the symbol commonly used for pedigree notation. Yeah. Okay. So let's see what the answer is. It represents the consanguinity. So team D gets the complete 10 marks. Team E, are you ready? Team E. A term male unit with a birth weight of 3,200 grams having respiratory distress, he is put on the oxygen through the short binasal pronge at 0.5 liter per minute. Approximately what concentration of oxygen, that is a FiO2, is being administered to the neonate? Yeah. 35%. Let's see what the answer is. It is the 35%. The infant weighing up to 10 kg infants flow, and this is all taken from the WHO manual of oxygen therapy. So the answer is right. So moving to the next, team F, are you ready? 10 points. So identify which reporting form is this. collect the chit. Yeah, please. Speak loudly. Combined Akbar score. Extended combined Akbar score. Okay. So let's see. So this is expanded Apgar score reporting form. So I think they will give it a complete marks. So team F get the full complete 10 marks. So round 3. Are you ready? Team A, are you ready? And among yourself, you please decide who is going to answer, because there should not be confusion, me and you. So among decide who is going to answer. So team A, are you ready? Round 3. A 7-day-old baby born at term with a birth weight of 2,800 grams is brought with the complaints of difficulty in breathing and inability to feed at the breast. On examination, temperature is 36 degrees centigrade and respiratory rate is 96 minutes with a moderate retraction with grunting and central cyanosis. On auscultation, air entry is normal. What is the respiratory grading of the respiratory distress as per the Downey's score?
Seventh.
Yeah?
7.
7. Chit collected? So let's see what is the answer is. This is a total score is 7. Right? Impending respiratory failure. So the team A will get complete 10 marks. Okay. So team B, are you ready?
Yes.
Neonate with untreated classical galactosemia are prone to develop a sepsis, particularly to which organism? Collect the chit. Okay.
E. coli.
So E. coli.
E. coli.
Okay, let's see what the answer is. It's absolutely correct. It is the E. coli. Okay. So we move to team C. Team C, are you ready?
Yes, sir.
As per the term neonate fails at the room air challenge test at 37 weeks PMA and the baby requires a 5O2 of more than 0.03%. And what is the diagnosis and classification of severity of the disease? You have to answer both the component together. Collect the chit. Collect the chit. You have to answer before the bells rings. No, we will not consider this one. Okay.
Shall I answer, sir?
Yeah, please go ahead.
Bronchopulmonary dysplasia,
Okay.
grade 3.
Bronchopulmonary dysplasia, grade
3.
3. Let's see what the answer is. So this is a BPT classification, moderate classification.
So why moderate?
Mild, moderate, severe. Moderate. It is a moderate. Right? So you have
Isn't
to.
it 1, 2, 3 as per the
कैसे बोलते हैं नहीं हो रहा
Sorry?
है नहीं हो रहा है
NICHT classification grades as 1, 2, 3, right? So like actually, I mean, ideally the respiratory support, the type of respiratory support should also be
So this is as
specified.
per the classification for the every it is given. It is not particularly for NICHD criteria. If I would have asked it is as per the NICHD criteria, that would have been grading it's there.
Fluharty.
Right?
Yeah.
Okay.
So in
So-
Fluharty, the NICHD
so one
criteria
question.
is given.
Yeah, so team B has given a correct answer. So team B will be given a indirect marks. Team B for ball, right? Okay. So next,
So just one doubt before we move on.
Sorry?
Like FiO2 of, I mean, Fluharty says the.
so what is judge's opinion?
Okay. Okay, so. Okay, so. Fine.
So there will not be a direct question.
Okay,
I'm
sir.
sorry. And
Thank
but
you.
the team B has written a correct answer. It is the BPD and the severity score is moderate. So team B will be given. Okay, team D, are you ready? So what is support trial? Which disease is associated with? I mean, you have to Yeah, collect the chit. Collect the chit. Yes, please. Use for? Okay. So let's see what is the answer is. So surfactant positive airway pressure and pulse oximetry trial, which is good, and it is associated with BPT. So the direct answer is correct. So sorry? RDS. Okay, half correct. Okay, he said RDS. So half will not be awarded. Half will not be awarded. So anyone has collected, given the right answer? It is the full form of support trial and for which disease it is associated. No, it has to be a complete answer. So to maintain oxygen saturation, positive pressure trial, oxygenation. No. This is not correct. Team A is not correct. A support trial, surfactant, positive pressure, oxygenation, and they have given ROP and BPT. It's not complete correct. Yeah. Speak loud. You have got mic. Team E. So team E has written it is BPT for, and it is written randomized control trial, right? Pulse oximetry. The name is not complete. You can see it yourself. You can correct yourself. The full form is not correct. Okay. Yeah. So, but I think they have not given the correct full form of that. Surfactant, they have not written complete full form of this. But the full form has to be complete, you know. So none of the team will give any marks. Okay, let's move to team E. So are you team E? Are you ready? So near infrared spectroscopy, that is NIRS, is used to measure the tissue oxygen saturation. In this context, what is RSCO2 stands for? Sorry? Cerebral oxygen saturation. Okay, let's see. So it is the regional cerebral hemoglobin oxygen saturation. So who has written? Team C. Anyone else? Okay. So yeah. So regional cerebral hemoglobin saturation. So teams, though they have tried, but it has not written oxygen. So it has to be a full form completely. So as it is. Yeah, team D. Yeah, RSCO2, regional cerebral hemoglobin oxygen saturation. I want this is to be written as it is, which is written in the book. Fine. So I think none of the team has given the correct answer.
Sir, isn't it like very obvious that it is hemoglobin oxygen saturation because it's there in the RSCO2 as well?
No, if and but. So none of the team will get any marks. So team F. Team F. Are you ready? Okay. Name of the staging used for virilization of the female with congenital adrenal hyperplasia. Yes. No. So any team has given. Let's see what is the answer is. All team. So only the direct team has not given. Okay, so team A get 5 marks. Team C get 5 marks. Team B get 5 marks. Team D get 5 marks and team E gets 5 marks. Right? Okay. So can we move ahead? So round 4. So score. Okay, score, yeah.
So at the end of round 3, the scores are Team A is at 25, Team B is at 25, Team C leading with 55 points, Team D at 25, Team E 20, and Team F at 20 points.
Okay, so at the end of the 3 round, Team C is leading. So can we move to team round 4? And for this time, the direct question goes in the reverse direction. So therefore, the Team F will get the direct question. Team F, are you ready? Okay. So Team F, a newborn baby is on mechanical ventilator with the setting of 18/5, 40 and 40. ABG shows pH of 7.24, bicarb of 23, PaO2 is 80 mm of Hg, and PaCO2 is 50 mm Hg. Calculate alveoarterial oxygen gradient, that is AADO2. Take some time. Okay, so how much? 20 seconds, double. Yeah, you will give. Judges are so generous. Okay, collect the chit. Collect the chit. Collect the chit. Okay, yes, Team F. Yeah. Team F. Yes, please. 10. Decide amongst yourself who are going to speak. Okay, said, let's see the answer. 10. So this is the calculation. So it is going to be a 155. Let's see what is answer. So it is the Team B who is given a correct answer, 155 exactly. So Team B will get a indirect 5 marks.
So the FiO2 was not clearly mentioned, so we have written down the formula of the case.
Who's saying?
Yeah.
Huh? Okay. Yeah.
The FiO2, I could not find out the FiO2 being mentioned clearly, so I've written down the formula of that, that equation. Will that be considered?
Just hold down. So what you are saying, FiO2 is not clear.
In the question, sir, amongst all those FiO2 was not clearly,
FiO2 is not clear. Oh, setting. So it is actually PIP and then 5, then 40, 40 it is. Either way, the digit is going to be the same.
we have written down the formula. We have substituted the values except for the FiO2 and we have written down the formula, sir.
I think everybody is understood. So, okay, fine. That's no issue. So this is all about. So Team E. So no, Team B will be given a 5 marks indirect. So Team E, are you ready? Okay. What is the prognosis of the newborn with a congenital diaphragmatic hernia in terms of intrauterine measurement of lung to heart ratio, that is called HR, by ultrasonographically? Collect the chit. Yeah, please. We just want good, bad, or okay. Okay, let's see what the answer is. So it is exactly LH ratio, if it is less than or equal to 1, it shows extremely poor prognosis. So direct question is correct. So they will get the 10 marks. Okay. So Team D, are you ready? A 37 weeks male baby with a birth weight of 2,800 grams was delivered by emergency LSCS. Indication was fetal distress and MSL. Developed respiratory distress soon after birth. Started on CPAP with 5/50. Here I think 50 is a FiO2. but respiratory distress was persisting before, and put on HFO with a map of 20 centimeter of water, frequency 15 hertz, FiO2 is 100%. After 2 hours, ABG shows pH of 7.20, PaO2 of 60 mmHg, PCO2 of 60 mmHg, and bicarb is 24. Calculate the OI, that is oxygenation index. And I hope judges are already liberal. So we can give a double time, that is 20 seconds. Please, time starts now. Yeah. So this time it will be 20 seconds. Okay, collect the chit. Collect the chit, please. Yeah. Sorry? You please speak loudly, otherwise I'll disqualify. 30? 33.3. Let's see what the answer is. It is 33.3. So the direct will get, team D will get a complete 10 marks. So team C, are you ready?
Yes, sir.
A preterm neonatal with birth weight of 1025 grams is on 120 ml per kg per day of EBM, that is express breast milk. Calculate the GIR. Collect the chit, please. Quick. Okay, 10. Calculation. Okay. Okay, collect the chit, please. Team C.
Sir, 6.6 mg per kg per minute.
6.6. Okay, let's see what the answer is. So GIR, the formula is this, and we have calculated this is a 6 mg per kg per minute. So we'll consider it as 6. So anyone has written? No. So the team D will get team C will get 10 marks. Okay, the amount of dextrose in the milk is considered this. In the breast milk like this, we have taken it from the NNF guidelines. Okay, team B, are you ready? Yes, team B. Team B?
Yes, sir.
Okay, so respond quick. As per the ACOG guidelines, committee opinion at 2018, the management of magnesium sulfate before anticipated preterm birth for neuroprotection in preterm birth reduces the risk of cerebral palsy in surviving infants. What is the gestational age below which antenatal magnesium sulfate is indicated? You have to tell the gestational age. It will be only 10 seconds for this. Okay. Yeah, direct team.
Less than 32 weeks.
Less than
32 weeks.
Less than 32 weeks. Okay, fine. Let's see what is the answer is. ACOG, it is exactly 32 weeks. So team will get the complete marks. So team A, are you ready? Okay. So prenatal treatment of dexamethasone therapy to be started for CAH at 6 weeks. Chronic villus biopsy is then performed to determine the sex and genotype of the fetus. The therapy is stopped only when if the sex of the fetus is. Collect the chit. Okay, yeah.
Male.
Male baby. Okay, that's fine. So let's see the answer. It is absolutely correct, but it is very unfortunately that we in our country, because the antenatal detection of sex is not permitted and it is illegal. Therefore, it is very difficult to start this antenatal therapy in our country. So which is to be a very sad affair. Okay, let's see. Round 5. Yeah, score please.
So at the end of round 4, the scores are: Team A is at 35, Team B is at 40, Team C is leading with 65 points, Team D is at 35, Team E 25, and Team F at 20.
Okay, fine. So again, the team C is leading. So buck up the guys. Only the rest two round still is left. So hopes. So some change in and upside down in the team order. So round 5. So F, Team F, are you ready? Okay. Characterization and antimicrobial resistance of sepsis pathogens in neonate born in tertiary care center in Delhi, India, a cohort study. You have to name the study. It was published in the Lancet Global Journal in 2016, and it was a landmark study in our country. Okay, let's see. Chat is collected. Okay, I think audience has already prompted. So it is the Danish study, which is called Delhi Neonatal Infection Study, which was a landmark study as far as infection is concerned. So it was published in the Lancet Journal, and 4 of the institute in the Delhi, they were part of the study. Okay, so team E, are you ready? Ready? Okay. What is ROAR study? You have to name, expand the form. Yeah? Answer? Okay, no answer. Okay, let's see what is the correct answer actually. So it is the room air versus oxygen administration during resuscitation. So anybody has written? Room air oxygen versus resuscitation. Okay, so we can grant team F marks, indirect marks, 5 marks. So we are very fortunate enough that I can inform to the August gathering that the genesis of this principle, the room air study, they came from the India, and we are proud to say the one of the researcher, the great researcher, in which the guidelines all over the world is being changed, and it is all from the India, and none other than our incoming president, Dr. Professor S. Ramji. So we must feel, proud. I'm feeling the goosebump. We must feel proud that our Indian studies, they are changing the global evidence. So none other than our professor and incoming president, Dr. Professor S. Ramji. Thank you, sir, for enlightening us and giving the evidence that actually the room air works, sir. So it is the major landmark study which changed the evidence in the whole world. So it is a neonatal resuscitation. Okay, fine. Sorry. So team D, are you ready? Okay. Maternal intramuscular dexamethasone versus betamethasone before preterm birth, a multi-center double-blind randomized controlled trial, was published in September 20. And what is the name of the study? This is again a very landmark study. Okay, yeah, please. Okay, he is not answering. So let's see what the answer is. It is the asteroid study. So who has written? Okay, team F is correct. Asteroid study, so you will get the 5 marks. And the team C again is written 5 marks. So you written asteroid study. So this is also very one of the landmark study. They have changed the evidence. They have changed the practice of neonatal treatments. Okay. It was again published in the Lancet Journal. So team C, are you ready?
Yes, sir.
Okay. So in a M mode echocardiography, imaging parameters called shortening fraction is used. What is the formula used to calculate FS? You have to write down the formula.
Sir, shall I answer?
Yeah, please.
End diastolic volume minus end systolic volume upon end diastolic volume.
So have you written?
Yes.
Yeah, just show me. And now you speak. Yeah.
End diastolic volume minus end systolic volume divided by end diastolic volume.
Okay, okay. So have it has been collected? Nobody has written. Okay, let's see. So it is the fractional shortening will be the ESD, left ventricular in diastolic, minus in left ventricular systolic divided by left ventricular in diastolic, but it is multiplied by 100.
So that is so obvious.
It is obvious. So the ball is in their court. Okay, so our judges are too generous. Okay, yeah, 10 marks. So fine, so can we move ahead? Team B, are you ready?
Yes.
Okay, so what is peanut trial? Yeah, please collect the shit.
Can you answer?
Yeah, please answer.
So, preterm erythropoietin in neuroprotection outcome trial.
Okay, let's see. So it is correct. Preterm erythropoietin neuroprotection trial. So diet team will get the full marks. Okay. So team A, are you ready? The name of the fetal surgical intervention used for congenital diaphragmatic hernia, that is CDH. Collect the chit, please. So why you are tearing every time? You just make it already teared and then write. So yeah, please answer.
Feto, sir.
Feto. Okay.
Fetoscopic endoluminal tracheal occlusion.
Okay, let's see what the answer is. He's absolutely right. It is a feto-endoluminal tracheal occlusion, right? That is called feto. So great. So round 6. So this is round. Yeah, please score the card. Scorecard, please. And meanwhile, I just reiterate you. This is a visual round. There will be no chit, and this visual round will consist of two parts. One part will be related to that images, and something related to that particular intervention or whatever it is. So there will be no chit collection for that. The volunteer can rest now, and only the direct question will be given. No indirect marking will be given. Our scorer to please note, no indirect marking will be given. Okay. So team F, are you ready?
Sir, score at the end of
score. Yeah, please.
So scores at the end of round 5 are: Team A is at 45, Team B is at 50, Team C is leading with huge margin at 80, Team D at 35, Team E at 25, Team F at 40.
Okay. So who's the second leading?
Second leading is Team B with 50.
Team
B with 50. The difference is of 30.
So B, you just buck up yourself. Yeah. Okay. So are you ready for round 6? Everybody is ready? You understood the this round? No chit will be collected, and that they will be having two parts, and that has to be, you can answer separately, and then you will given half marks. No, you can respond immediately after that. You need not to, because nobody is going to write the chit. Immediately after completion my question, you can immediately respond. Right? Is it okay? Shall we go ahead? Okay, let's see. So team F, comments on the position of the tip of the UVC and where it is actually. Yeah. Sorry, we speak little loud. Please. Okay, question is not clear. Comment on the position of the tip of the UVC. It is only the, you need to, where is the tip is lying. It has got only one component, that's all. Tip, where the tip of this tube is lying. Right ventricle. Okay, so let's see what the answer is. So this is actually left ventricle, in the left ventricle, right? So it is in the left ventricle. Okay, so next around team E, are you ready? This waveform pattern is seen in which test? Bera. Okay, let's see what is answer. So it is absolutely right. This is the BERA, brain stem waveguide response audiometry. Okay, that's fine. So complete 10 marks. Team D, are you ready? Okay. To identify the investigation used for intrauterine assessment of the fetus. It is actually a procedure. So what for it is? Yeah, please. You need not to wait. No. Okay, time is over. So let's see what the answer is. It is the fetomagnetoencephalography, FMEG, right? So it is the neurophysiologic imaging of the preterm brain development, right? This is the, you need to just identify the procedure. A new horizon of understanding of the fetal and neonatal brain development is useful in understanding the long-term neurodevelopmental outcome consequences. Okay, let's see team C.
Yes, sir.
Are you ready?
Yes, sir.
Okay, let's see what is it is. Oh, it is, though the picture is not very clear, but you can identify. Antenatal sonography, finding of keyhole sign is suggestive of
POV, posterior urethral valve.
posterior urethral valve. Okay, let's see. So basically, this is a lower urinary tract infection, what is called luto. So the posterior urethral valve is one of the common, but so what is it's, I think, correct? Yeah, we can go ahead. Okay, so 10 marks too. So this signs of lower urinary tract obstruction, and these are the signs, and the keyhole sign is one of the indication for the luto. Okay, let's move to team B. Are you ready?
Yes, sir.
Okay. So what is the diagnosis and prognosis? If you find it, what is the diagnosis and what is the prognosis, depending upon the tube position? Yeah, please.
Congenital diaphragmatic hernia. And the prognosis is severe, sir.
Prognosis is?
Severe.
Severe. Okay, let's see. So it is a CDH, chest radiographic of an infant with a left-sided congenital diaphragmatic hernia. Note the proper position of the orogastric tube in umbilical venous catheter. So it is in the liver and the stomach is herniated into the chest in severe CDH. So I think this is correct. So they will be given a correct mark. Okay. So team A, are you ready? Okay. So what this red is depicting? What does the arrow indicate? You know, this block.
Air trapping, sir. We have to prolong expiratory time for air to completely wash out. There's been air trapping.
Little clear.
This air trapping, we have to prolong the TE so as to
Okay.
allow proper.
So this is
expiration.
air trapping. Okay. So let's see what it is. So this is a trapping of that what we call auto peep. So I think the answer is correct. So they will be given a complete 10 marks. So extra question we do we need? What is the score of that one? Is any tie?
No tie.
No tie.
Yeah.
So Dr. Divakar, can you please
Yeah.
let me the score, final score?
Yeah. So after end of all the 6 rounds, the final scores are: Team A is at 55, Team B is at 60 marks, Team C is the winner of the quiz with 90 marks, Team D is at 35, Team E is at 35, Team F at 40. So winner is Team C with 90 marks. And the first runner-up, Team B with 60 marks.
Okay.
Second runner-up, Team A with 55 marks.
Okay. So can you please, so team C from which zone? Team C is from North zone.
North zone.
Okay. And team A?
Team B is the first runner-up,
Okay.
which belongs to West zone.
Okay, fine.
And the second runner-up, Team A, belongs to Central
That's
zone.
fine. That's fine. Okay. So, so at the end of this, there is a no tie in between the teams. So therefore, we are not going to tiebreaker round or requiring some extra question. So we can stop or just Can we make it in the first? Yeah, just please make it the first screen. So I hope this is the end of the quiz. And I would request our President sir, so if you again say a few words and felicitate our students. Mike, Mike. Sir.
I think, first of all, I think all of you did immensely well. I was sitting with some of your seniors and faculty who owned up that they didn't know the answers. So I think you guys have done really well. And of course, I realize the ambiguities that you had pointed out. And I think in the future years, we shall take care of that ambiguity. So I'm actually deeply impressed by the fact that a lot of you knew many things, and it shows a great deal of your scholarship, or intent to scholarship, and I'm very pleased. And I hope that some of you, if not all, will eventually take on to neonatology as your primary vocation after you graduate. So all the best to all of you, especially to the AIMS team. I think you did outstandingly. You know, it's like a T20 match. You got all your good runs in the first over, right? You got all your marks. Then thereafter, it's sitting. But I think everybody else did a great deal to catch up, and I think it was wonderful. So thank you so much. It was very enjoyable. I congratulate all of you. Thank our panel of judges who I think were fair to answer. You know, there's sometimes there's always an issue of what if it's a little incomplete. Somebody asked me this question. I think somebody pointed out, sir, oxygen is assumed. No, there's something called carboxyhemoglobin where there's no oxygen, there's CO2. So you can't assume that hemoglobin saturation always means only oxygen. There are other molecules to which hemoglobin binds. So I hope it's a lesson for you that you have to learn to be precise in medicine. You can't assume. I think somebody pointed out about the
oxygenation,
FiO2 not being mentioned. I appreciate that because, you know, it could be anything. What does 18 by 4 by 40 by 40 mean? Yes. But I realized in the subsequent question, they had the precision. So it's a lesson to all of us that when we communicate, we have to learn to be precise and correct. Then you get the right response. Otherwise, you can get a varied response different from what you intend. So, right. Thank you for pointing out those little anomalies. And I'm sure in subsequent years, this team will ensure those little anomalies are taken care of. So thank you so much, and over to you.
Thank you, sir. Thank you. Thank you. May I request sir to please be here if you have a time, sir? Yeah, okay. Nitin ji, give them for the certificate distribution. Nitin ji. So, team. First of all, give the participation certificate. Participation certificate. Participation. So team F, team F, team F. Yeah. Team F, I would like to, sir, team F to please come and over the stage and collect your prize, certificate for participation. So please encourage them, give them a big round of applause. They are already qualified winner, zonal rounds, so they are already winner. Yeah. So team F. Thank you. You have not written names. So I call team E to please come on the stage and yes, sir. Thank you. So I would like to invite a team D. Please come over the stage and collect your certificate. And apart from that, sir, these certificate they will receive some prize from the our sponsoring, and the winners will get a Dell laptop. Yeah. And now I would like to invite team A to please come. Team A. Thank you. And now I would like to invite team B. Team B. So second runner up. Second. Second runner. Yeah. First, second in the team. Second prize. Yeah. Maybe second prize. Second runner-up is there? Second runner-up. Yes, sir. They got the second prize. Yeah, along with the check. Sir, they will be giving some prize for the. They will receive some money. Okay. So now I would like to invite for the winner of this our team today. That is team B. Team B. Yeah. Oh, sorry. Team C. Team C. Sir, come. Please come. Please come. Dr. Sasi, please come. Yeah, sir, we'll have a group photograph. Okay, thank you. Thank you so much. Who left? Yeah. Who left?
I was a little surprised that none of you answered the roar, because the road trial was the first
Team A.
resuscitation for preterm. After we had completed our Reserve 2, which was the large international multi-site study on.
Sorry.
We then did it. So I was a little surprised that nobody knew that answer, because that was a landmark after our term baby resuscitation. The roar was a landmark which said you can do the same for preterms also, right?
Sir, team A has because is the third they are receiving, so they have a third prize. Team A, please come.
Please
Yeah,
return
second
your
runner
other
up.
certificates and receive this new certificate.
Come back and give the participation certificate. Yeah, now take this one. Okay. So, yeah, I invite all the participants to please come in the stage for a group photograph. Yeah, Dr. Sashi, please come. And all my volunteers to please come. All volunteers to please come. Yeah, all volunteers to please come. Yeah, definitely. So we have got a sir appreciation certificate for our scorer and timekeeper, along with the नितिन नितिन अच्छा वो उनको भी देना है ना अरे जो ये वॉलंटियर्स को अप्रिसिएशन ओ सॉरी
Come here.
yeah this
I think if you can close yourself in, we will.
we can we make in second row or in the first
Want all of us?
okay
Just move yourself closer.
thank you so Nitin for appreciation certificate for a scorer or nahi who oh, no issue so there is no appreciation certificate अरे जो भी होता है ना उनके लिए क्विज के लिए जो क्विज जो फैसिलिटेटर होते हैं और उनके लिए okay sir that we are come to the end of the session
Thank you. Thank you to Professor Siddharth Ramji. And one big round of applause to our quiz master, please. Dr. Ravi Sachan, who conducted this national round very well. I request all the participants to stay back. You will receive your prizes from Himalaya Drug Company in a while.
Yeah.
So please stay back.
All of you are supposed to stay here only. Don't leave the venue. You are going to have another award ceremony also.
Yeah, so please
thank you,
back
sir. So I am really deeply indebted for your time, sir, for gracing the occasion. Thank you so much, sir. Thank you. And at the end, I would like to thank Dr. Chandkala for taking out your time and sparing here and helping all throughout the quiz. Thank you so much. Thank you so much. I think for our judges, they are so generous. Please at least give them some appreciation and round of applause. And this is thank you again, Dr. Jagjit Dalal, where it is. Dr. Jagjit, thank you so much for sparing your valuable time. I'm deeply humbled with your presence, and thank you for gracing the occasion. Thank you so much. Thank you. Himalaya. Yeah, you can start your process. We have to vacate this hall before 2 o'clock. So we can have another. Huh? Okay.
The program was scheduled for 4 o'clock.
Okay. So please, all of you, please don't leave the venue. You stay for another 15 minutes. He's saying you will have another prize distribution for that. Yeah. He knows. Excuse me.
past 2 o'clock.
Yeah.
We are.
What you Ah. Good. I'm glad. Next year we are going to keep this just like last year. Very nice. At the end of PGCME or advanced.
They want to load the picture. Now we have the prize distribution ceremony for all the winners.
Who won?
AIMS New Delhi. I think Dr. Sauraja and you can take this.
Like I said in the morning, quiz is one of the most important programs, activities of the NNF, and you people have won through until the zonal rounds and come here, which I consider as a great achievement by its own. Secondly, this time we have had support, good support from Himalaya Wellness Company. They are based in Bangalore. Their baby care division is responsible for all the prizes which have been distributed during all the rounds. They have been very generous. Their baby care division is the one which supported. NNF is very grateful to them. And from their academic grant, we could also give a small amount to each level of competition, not institutional, but divisional, zonal. We were able to give a small token money so that small expenses like, invitations and maybe coffee and snacks like that could be done. And the institution, the coordinators didn't have to struggle for getting the expenses reimbursed, either by their institution or look for help. So they have done a great job. I request Dr. Ravi Sachan to announce the result and call the winners.
So Team C, yeah, please come, Dr. Soumya and Dr. Dr. Sauraja. Yeah, please. Yeah, these are the winner.
You are the ultimate winners?
Yeah, the one winner.
They will be getting a Dell laptop worth of 65,000 rupees.
Okay, that's fine. So you can announce.
Good afternoon, everyone. The winner will get a Dell laptop worth of 65,000 each.
During my times, we hardly get a certificate, the winners.
They will also receive a zonal prize for winning the zonal round, which they have not received earlier.
Rest of the four zonal winners, they have got their mobiles. So this North Zone team was a virtual round. So their mobile was pending as a zonal round prize. Only one team is there as from South Zone, which was a virtual round. So they have to receive their zonal prizes. We'll giving them today.
So they will again. So one mobile and one laptop. That's good. Please come. So hold it. They are not able to hold the prize. Heavy. Laptop is heavy. So I would like to invite now the team D, for okay. तो उनका जोनल का इनका तो होगा ना डी का होगा ना इनका जोनल
ये साउथ जोन है
हाँ
तो इनको बुला लो
yeah South Zone D team please come because they have already qualified the zonal round, so they are receiving because the zonal round was held on virtually, so they could not get the prize and therefore we are felicitating him. So please announce your name, introduction.
Sanjeev from Jipmer.
Dr. Akash from Jipmer.
Okay, so they are from the Jipmer team. The second round.
I would like to thank NNF, Dr. Ranjan, Dr. Ravi, for giving us the opportunity to co-partner in this event. And we'll assure you that, sir, by next year also we'll participate in a more better way. And I'm sure the doctors who are the winners, all the participants will certainly enjoy the next year event also. Thank you, sir. Thank you.
Thank you. Thank you. Great assurance.
Hello. So we have come to the end of this quiz program. So I would like to thank Dr. Sasidhar for the local coordinator. He organized such a well. So give them please a big round of applause for the local coordinators. My youngs, students, junior, and all of you are please come and you have we have the group photograph. You had no? Okay, thanks. So thank you so much, all of you for helping us in the quiz, and it is all credit goes to Dr. Sasidhar. I am really grateful for your organization. Thank you so much. Thank you. Thank you.
Good afternoon to one and all. We will now proceed with the panel discussion. The quiz might be over, but the trivia will continue for the delegates and the panelists present here. Quick question to all those present here. Do you know who first used the word shock, or rather shock? Okay, it was French surgeon Dr. Henry Francois Ledrain in his 1740 text to describe the reaction of a victim to the sudden impact of a missile. But it was only later in the 18th century that Dr. James Latta used the word shock in its present day connotation. We will now have an intriguing discussion on neonatal shock and the approach to follow in its management. And moderating the session today, we will have Dr. Manas Ranjan Upadhyay, who is an associate professor at the Department of Pediatrics at Fakir Mohan Medical College in Odisha. Joining him in the esteemed panel will be Dr. Gayatri Hemanta Radhya, associate professor at JJM Medical College, who has a keen interest in neonatal sepsis and kangaroo mother care. Joining us from Vani Villas Children's Hospital, Bangalore, is Dr. Sahana Devdas, professor of pediatrics, chief neonatologist, and the SNCU Nodal Officer at Bangalore Medical College and Research Institute. We will also be welcoming Dr. Padma Kumar Patil, consultant pediatrician and neonatologist at Sparsh Super Specialty Hospital, and he has his own clinic at Sadashiv Nagar called the Sanjeevani Clinic. Joining us virtually will be Dr. Suman Rao, professor of neonatology at St. John's Medical College. She is the recipient of the Gianni Scholarship by the American Academy of Pediatrics and also the recipient of the Dr. L. Subramaniam's Gold Medal in Pediatric Pulmonology in the year 2000. Also joining us virtually is Dr. Amitoj Singh Chinha, consultant neonatologist in Cloud9 Bellandur. Also joining us virtually is Dr. Anup Jalan, consultant pediatrician and neonatologist at the Navjeevan Child Clinic in Gorakhpur. We will now commence the discussion, and I would like to invite the esteemed panelists and the moderator on stage. Thank you.
Sound.
One more mic.
Thank you all. So without wasting much time, I'll go to the first question to Dr. Gayatri. How do you define neonatal shock?
Good afternoon all. Post-lunch session, this might be a bit boring, but I mean, we'll make it precise and we'll try to finish on time. Thank you for the opportunity. Coming to definition of neonatal shock, shock is a complex clinical syndrome characterized by sudden failure of the circulatory system to maintain the adequate tissue and organ perfusion, leading to inadequate oxygen and nutrient substrate delivery to the body tissues, indeed leading to compromised metabolic waste product removal. This results in cellular dysfunction, which may eventually lead to cell death. This is beautifully summarized in the downslide, inadequate tissue perfusion, leading to production of lot of inflammatory mediators, ultimately leading to cellular death.
Thank you, Dr. Gayatri. So I'll just put a discussion of fast case. So we have a 36-weeker, 2.6 kilo newborn born to a mother with Vasa previa and APH. The baby was delivered by LSCS. During resuscitation, required bag and mask ventilation due to poor respiratory effort. Soon thereafter, the baby was shifted to NICU, where the baby looked severely pale. Temperature was 35.6. Heart rate was 166 per minute. Respiratory rate 66 per minute. CFT 4 seconds. SpO2 84%. And the baby had low volume pulses and BP was 52, 35 and 42. Blood sugar was 62. So my question to Dr. Sahana, how are you going to stabilize this baby?
Thank you, sir. I thank the organizers for giving me the opportunity. So this baby, we have already we know that mom had a APH and Vasa previa. So we are expecting a flat baby here. And so baby also required a resuscitation. And as we know that there is a risk factor, so we have to think of a hypovolemic shock. And like all other babies, how we stabilize any baby, when the baby is flat, we have to go with the temperature, airway, breathing, circulation. And following this, baby is hypothermic. So he has a moderate hypothermia. So we have to rewarm this baby, secure the airway and stabilize breathing. Because baby is flat, maybe NIPPV or intubation may be required, and a quick saline bolus as an emergency of 10 ml per kg over 10 minutes has to be given. And we have to arrange for a packed RBCs, preferably O negative RBCs. And we have to monitor the vitals and look for the improvements of the vitals, and we have to look at the shock index as we progress. Maybe we can give one bolus. If the baby doesn't improve, we can have one more bolus as per the current NRP 2020. 10 ml, 10 ml. And in the third bolus, they say 10 ml per kg of normal saline or a packed cells has to be given, sir.
Thank you, madam.
Thank you.
Next, I will ask Dr. Padma, what investigation you will suggest in this baby?
See, as we've gone through the history and how it presented to the NICU, generally in all the babies with the shock, what we follow, the workup will be mostly metabolic, biochemical, hematological, and the microbiological investigation as per the circumstances. Now, considering this baby having pallor and compensated shock, so with antecedent birth asphyxia secondary to the APH, that is mother has lost the blood. So I'll quickly get the CBC, hematocrit, most important electrolytes and RBS, so that we can correct the important things initially. So, and at the same time, we want the ABG also to see the insult and the tissue damage happened to the organs or the involved secondary to the shock. So the best thing is, even since the cardia is involved, secondary to the insult, RFT along with CPKMB and troponin will also help the renal function and the myocardial insult due to since baby has not responded at birth, so respectively. 2D echo will be of great help to assess the preload, IVC collapsibility, even if at all pulmonary hypertensions, myocardial contractility, and even PPH and degree of myocardial dysfunction. So these are the few things, bedside and as quick as possible.
Thank
so
you, Dr. Padma. So here the baby had at admission PCV of 22%, lactate of 9, pH was 7.1, PaO2 76%, PCO2 32%, base deficit of -12, bicarb of -16, and SaO2 is 98%. So my next question will be to Dr. Suman. How further you will manage this child? Dr. Suman.
Thank you, everyone. Thank you for this opportunity. Now, this baby has actually shown us that this baby is anemic at birth. And therefore, it has convinced us that now we are dealing with hypovolemic shock. In fact, I think I would go back a few steps and think, could we have predicted this? So whenever there is an APH, it is always, I would think, good practice to see whether the bleed is from the mother or from the baby, because we know with APH, sometimes the bleed can be from the baby, and that will help us anticipate that this baby is going to have pallor and anemia. And here with shock, We are not sure at the time of birth if the shock is due to asphyxia, is the shock due to hypovolemia. So that information, whether the bleed was mother's or baby's, by doing something like an app test would have helped. Now that we have to look forward, the big concern is that we are having hypovolemic shock. The echo is definitely helpful, and one bolus is not going to help us. What we need to get into the baby is blood as soon as possible. And if this baby is in shock, I would ask for a rapid cross match, because otherwise the cross match process itself takes around 2 hours. So I am going to say that I want a rapid saline cross match, which in our hospital we have to sign. The consultant or the senior resident has to sign that it is okay to do a rapid cross match and get blood as soon as possible. Now the question is, how much blood? Generally, we are used to giving only around 15 ml per kg. But we need to realize that the PCV is very low down at 22. So one single transfusion is not going to help. And what we need to do is to do something like a partial exchange, where we look at the hematocrit of the blood that we are giving, which we can consider to be around 50 or so. If we can actually measure, that would be even better, and calculate the volume of blood that we need to give. Now, please also note that the PCV is 22 right at birth. Now, this will help us determine when the blood loss happened. Generally, if the blood loss is happening at birth, say, for example, a cord accident, then the PCV takes some time, usually after around 6 hours, to fall, because you need time for hemodilution. The fact that we are having a PCV right at birth, which is 22, tells me that probably this has been ongoing hypovolemia. And therefore, we must first assess the fluid status and decide whether we can just go ahead and give the packed cells, or we need to do something like a partial exchange. Over to you, Dr. Manas.
Thank you, madam. So after the baby received fluid boluses, PRBC, the shock improved, and follow-up ABG was also normalized. So the baby got settled. So I'll be asking Dr. Amitos, we know the oxygen delivery being important in cases of shock, and for which we should have also adequate tissue perfusion and oxygen content of blood, which is predominantly dependent on hemoglobin and FiO2. So give some general guideline for transfusion in cases of shock. Dr. Amitos.
Good afternoon, everybody. Hi, thanks, Dr. Upadhyay. So I think my fellow panelists have already sort of outlined the game plan here. But in general, if there is suspected, if we are aware that there is severe anemia, which we would know with a hemoglobin less than 8 grams per deciliter, or clear signs of hypovolemic shock, and we can estimate a blood loss of more than 20% from any kind of situation with massive bleeding. It could be a placenta previa, abruption, a ruptured cord. We must restore the intravascular volume as fast as possible. And if there is an urgent need, we can first use saline and run boluses of 10 mils per kilo up to 20-30 mils per kilo. And if we have available reconstituted blood, O negative dispersin AB plasma or something like that available, or in anticipation, we could run that. If, however, and I think Dr. Suman Rao already explained about the need for calculating the volume of the packed RBC. So we can estimate that the hematocrit must be restored to something around 35%. And for that, we can use a formula to calculate the volume, which would be the desired hematocrit, which would be 35%. And from that, we should subtract the observed hematocrit, which in this case would be 22%, and divided by the hematocrit of the packed RBCs, which is usually around 65 to 70%, multiplied by the neonatal blood volume, which we usually take as 80 mils per kilo for a term baby and 100 mils per kilo for a preterm baby. So here we can calculate the approximate blood volume that needs to be transfused, and this can be run in a more stable baby.
So now we'll be presenting another new case. So this is a 2 hour full term neonate who is received from a different hospital with history of asphyxia, breathing difficulty, and history of there was no history of PROM. And admission, the baby was hypothermic with temperature of 35.6, heart rate of 158 per minute, respiration of 64 per minute, CFT is 4 to 5 seconds, pulses are poor, BP is 51, 32, 42. blood sugar as 56, there is no pallor. PCB, they carry a PCB report of 58%, ABG 7.15, PO2 is 59, PCO2 36, base deficit -11, bicar -11, and SaO2 is 92, lactate at 7 millimole per liter. So my question to Dr. Anup, how we are going to manage this baby?
Thank you, sir, for giving me this opportunity. Like as a clinician, we know that this is a very common scenario, especially in this part of the country where the birth asphyxia is very common. And first, as a clinician, we should be able to identify the problem. And we know that baby is hemodynamically unstable. Baby has features of shock in the form of prolonged CFT, and the blood pH is showing metabolic acidosis with increased lactate. So, as a clinician, we should be more than the recognition, we should also understand the underlying pathophysiology behind the hemodynamic instability, and which is very important for its management. So, recognition and understanding the underlying pathophysiology definitely will help in the management. And in the cases of birth asphyxia, we know that we should be very quick and prompt in our management, because more we delay, the more it will have a adverse effect on the brain. So also we should also take in factor the multiple interactions between the various modalities of the treatment, like therapeutic hypothermia or the mechanical ventilation. So as a clinician, we should first stabilize the baby. We should provide the baby adequate ventilation by providing securing airway, oxygen, and ventilation to support the breathing. And therapeutic hypothermia will help the baby depending on the unit protocol. What criteria do they follow? And as we see, the baby has prolonged CFT, baby has features of shock, we should give the boluses. But in this baby, as we know, that baby has birth asphyxia, they associated, there might be acute kidney injury, there might be some evidence of SIAD. So we should be very careful in giving the boluses. As far as the anatomic support is there, definitely it all depends what facilities are we working under. If we have the facilities of the echo will definitely help us in knowing the volume status of the baby, as well as the cardiac contractility of the, as well as the cardiac status of the baby, and definitely the underlying PPHN, because birth asphyxia babies, they have underlying associated PPHN. So all these factors might help us in selection of the right inotropes. And apart from the using inotropes, which will be dealt in the next slide, and this fluid and support, then other supportive care should be taken care of, like correcting the hypoglycemia, correcting associated hypocalcemia, and if there is anemia, since there is no anemia in this baby, so it needs no correction.
Thank you, sir. So now the next question is to Dr. Gayatri. Will you go for echo? Is this going to help in choosing right inotrope, vasopressor, or fluid bolus?
Yes, sir. Definitely, functional echocardiograph should be a part of clinical assessment in this case, as mentioned previously by Dr. Padma and Dr. Anu, as it provides the objective assessment of cardiac function and output, helps determining underlying cardiac cause for the same, assess response to therapeutic interventions done, gives insight on semi-quantitative assessment of SVC flow and left ventricular flow. All this will help in fluid management and right choice of inotrope or vasopressor. This is a quite big slide, but I'll be briefly summarizing this, especially when there's a systemic hypotension as we see in cases of shock. There will be decrease of systolic, diastolic, and sometimes both blood pressures. When there is an afterload decrease, like in cases of septic shock, NEC, or a decrease in preload, as we see in cases of previous case of APH, pulmonary hemorrhage, and capillary leaks, decreased contractility in case of our second index case, as we see in asphyxia and cardiomyopathies, increase in afterload, as we see in cases of sepsis and polycythemia and hypothermia, progressive decrease of both SABP and DABP seen in cases of unresponsive PPH and cardiogenic shocks and cardiac tamponates with PDA, sometimes with CCF. So individualized pathophysiology based hemodynamic approach will be Like for decreased SVR, we can consider vasopressins, mainly dopamine and norepinephrine are used in our units, followed by, volume expansion, inopressor. Whereas in cases of hypovolemia, first choice will be volume expansion, followed by vasopressors like norepinephrine and vasopressin. In case of myocardial compromise, as in our index case, we prefer dobutamine, followed by epinephrine. In cases of PPHN, we add over inhaled nitric oxides. In case of increased SPR, we go for dobutamine followed by epinephrine. With increased in PVR, pulmonary vascular resistance, we go for inhaled nitric oxide and IV sildenafil. In case of myocardial compromise, consider dobutamine. Decreased SPR, consider dopamine. And similarly, increased PVR, go for nitric oxide and IV sildenafil. And in all refractory cases, go for ECMO.
Thank you.
Focused bedside functional echocardiography can provide vital anatomic and physiological information. This modality should be further explored to generate data for therapeutic endpoints in management of shock. We recommend that focused echocardiography in neonatal shock should be regarded as extension of the clinical examination. Thank you.
So, thank you, Dr. Gayatri. So this is case number 3, where we have a 26-weeker, 800-gram baby who is shifted to NICU with mild breathing difficulty and was started with CPAP and FiO2 of 25%. At 6 hours, the sister informed you that baby is having blood pressure reading 42, 20, 26, but other parameters are normal, like CFT 2 second, pulse is well felt, urine output normal, heartbeat is 142, respiration 46, and there is no distress, but only blood pressure is low. So, sorry. So I will ask to Dr. Sahana how to handle such situation.
Yeah, thank you, sir. This is an extreme preterm with 800 grammer and 26 weeker. Baby is on NIV with relatively normal vitals except the blood pressures, and the sensitivity of CFT and the blood pressure in diagnosing shock in preterm babies is about 50 to 60% only across the studies. But however, since the vital parameters are normal and thumb rule of MAP, which is equal to gestational age, what we look at it being acceptable. And I would like to just continue to monitor this baby, sir, and with the same plan of management.
Thank you.
Yeah.
I'll just ask Dr. Padma, how do you say a particular BP reading is suggestive of hypotension? That means it is pathological. When you tell a particular reading is pathological.
See, basically the definition of cardiovascular dysfunction is neonate as either of following criteria. So despite administration of isotonic IV fluid greater than or equal to 40 ml per kg in an hour. So these are the criteria: decrease in BP less than 5th centile for the age of systolic, and or less than 2 standard deviation below or normal the age. Need of vasoactive drug to maintain the BP in the normal range. That is DOPA more than 5, doped epinephrine or norepinephrine at any dose. So next is 2 of the following criteria can be considered as low. So that is unexplained metabolic acidosis with a base deficit of more than 5 milliequivalent, increased arterial lactate of more than 2 times, oliguria, that is urine output less than 0.5, prolonged CFT more than 5 seconds, and core peripheral okay. So these are the criteria, and the next most important is, however, this definition is applicable only to the term, but Win and Wong propose the modified definition for preterms also, which has the silent features almost same, mild changes from that is fluid administration of limit of more than 10 with infant less than 32 weeks with systolic BP of less than 2 standard deviation or MAP less than 30. So, and also capillary time of more than 4 seconds.
Thank you.
So these are the chart which has individual gestation wise and systolic map with diastolic BPs. So almost bedside what we calculate is almost plus 2 or 4 of gestation age is what is we see.
So this is my case number 4. The same baby who we discussed previously on day 3 had prolonged CFT, bounding pulse, increased breathing difficulty with hollow systolic murmur, and heart rate of 176 per minute, respiration 67 per minute, and SAS score of 6/10, BP 46, 18, 25, ABG pH of 7.1, PA2 is 69, PCO2 46, base deficit -11, bicarb -14, SO2 is 92%, lactate 8, and liver size of 2 centimeter. So my question to Dr. Suman, how are you going to manage this shock in this particular baby?
So this extreme preterm, I think it's all very clear that by day 3, this baby has landed with one of the common problems that looks like a patent ductus arteriosus. There are many clues here. We have the murmur, we have bounding pulses, and not only PDA, but a complication seems to be in shock and also maybe in failure. Now, of course, we should go back in our unit. I think all of us, many of us are looking at this extreme preterm for adductors right from the word go. By around 12 hours, this baby actually should have had echo done to look at whether this baby is having a PDA. And even before it became so symptomatic, many of us, especially if it is hemodynamically significant, would have taken a decision to close it. But now, for whatever reasons, we are in day 3 and we seem to have ductus which is giving us problems. The first and foremost, we need to confirm it. Though I'm thinking it is a ductus, I don't think I can go rush in and close the ductus without confirming by a functional echo that we are dealing with a hemodynamically significant PDA. There are 2 aspects. The only treatment for a shock in a HS PDA which is going to work is going to be closure of the ductus. So we need to consider treatment to close the ductus. Having said that, we know it takes some time to close the ductus. So till then, we need to ensure that we overcome the shock, we maintain perfusion. And therefore, for this baby, I wouldn't consider any fluid bolus at all, despite the shock. The thing that we would probably look at is using a vasopressor, an ionotrope, basically, rather than a vasopressor, like a dobutamine. So I would do an echo, ensure that I am confirmed that I'm dealing with the ductus, start this baby on dobutamine, and start this baby on a treatment to close the ductus, which in our unit, the first line is still ibuprofen. But if we feel that this baby could have some problems, look at it, and we can consider paracetamol. So paracetamol or ibuprofen, it would be the way to go. Over.
Thank you, Dr. Suman. Here we have another case of 27-weeker baby, 700 gram, shifted to NICU with RDS, started with CPAP with FiO2 of 35%, given first dose of surfactant after stabilization by Insio technique. But at 12 hours, the sister informed you that the baby is having BP 35, 23, 27, CFT of 5 seconds, pulse low volume, urine output decreased, heart rate 172 per minute, respiratory rate of 66 and SAS 3 by 10. So my question to Dr. Amitos, how will handle this particular case? Dr.
Yes.
Amitos.
Yes, hi. So we have another extremely preterm baby where this baby, although the map seems to be 27, which is the same as the gestational age. So by rule of thumb, it could be considered acceptable, but there are signs of hypoperfusion. So this baby seems to be having, could be going into shock. Now, as an extremely preterm baby, many times these babies, they have the cause for the hypoperfusion and shock could be immature myocardium, the immature vasomotor tone. So that would lead to reduced contractility, to altered filling, and thereby reduce the cardiac output. And it would be helpful in this situation to have a look at the heart. So if one has an echo machine in the unit, it would be good to have a look at the heart to see exactly what is happening. Even if one does not know, the techniques in detail, one can still just eyeball the heart. In the 4-chamber view, just look at how the ventricles are contracting, and if the ventricular contractility appears poor, that would sort of confirm it. And in this situation, one should not rush into giving fluids, which is often the first response. Again, if one does not have an echo machine and one is not sure what is happening, one could still run a short bolus while one sort of prepares, some kind of vasoactive medication, which would be the most helpful thing in this situation. Again, going into this, depending on what the unit protocols are and what you find in the echo, one could use any of the vasoactive medicines. Dopamine is the most commonly used vasoactive medicine. It's more of a pressor. It may help improve the blood pressure, but not do much for the cardiac output. Epinephrine and dobutamine could be considered as well, depending on what findings emerge in the echo. And so basically in this case, one should not rush into giving fluids. This baby might most likely need some vasoactive medicines, and doing a functional echo may help decide the best course of action.
Thank you.
Thank you.
So we are having another case of day 16 baby, 3.8 kilo male child who developed poor feeding lethargy, and mother found mottled skin, old clammy skin. In the same day morning, baby was feeding well. And this is a sudden development. And baby was brought to an ICU within 4 hours of this symptom. And it was found to have temperature of 36.8, peripheries are cold, mottled skin, liver of 3 centimeter, heart rate of 186 per minute, CFT 6 seconds, BP not recordable. ABG showing severe acidosis. So my question to Dr. Anup, how you are going to manage this case?
So sorry to interrupt, but we have 10 more minutes.
10 minutes. So, Dr.
Okay, sir,
Anup.
I'll be very brief. Yeah, I'll be brief. Yeah. Okay, this is also a very common scenario, especially in a setting where we are running a very referral center. Baby well for first 2 weeks of life, and suddenly coming to the NICU in cardiogenic in shock. So definitely the baby we think of, or we definitely suspect if there is a cardiac issue with it. So the baby, as we look at the problem, the baby is having cardiogenic shock. So any well baby who was well for the first 2 weeks, sudden deteriorates with features of cardiogenic shock over few hours points to the possibility of ductal dependent congenital heart disease, be it some left-sided obstructive lesions or right-sided obstructive lesions. In this case, definitely there are some signs which suggest that baby has left-sided obstructive lesions. This can be looked at the BP and also the differential pulses and the differential pressure across the upper and lower limbs. And as far as the management is concerned, first we should be able to stabilize the baby. We should go for the temperature management, airway oxygenation and ventilative support. And we should go for the stable IV access and IV fluids, anatomic support. And definitely we should thinking of some cardiac problem, congenital cardiac defect involving the ductal dependent left side obstructive lesions. We should be quick in starting the prostaglandin infusion, and prostaglandin infusion should be, and we know that prostaglandin helps in stopping the ductus to close, and even if it has closed, it helps in re-establishing the patency. And very soon, apart from the X-ray, good echocardiography should be done to exactly define what is the anatomic lesion responsible for this hemodynamic instability. And after stabilization of the baby and institution of the prostaglandin infusion, and we should be make transport ready to refer the patient to a tertiary pediatric cardiac center for the further evaluation.
Thank you. So after stabilization, the baby developed hypertension in the upper limb, and the lower limb BP is still normal, and there is disparity of blood pressure in all 4 limbs. So Dr. Gayatri, further, how should we proceed?
As sir already discussed, this is a case of cardiogenic shock presenting in a otherwise well 3-year-old weak baby with sudden uncompensated shock. Later, after stabilization, the BP has picked up, but still the lower limb BP is on lower side. So definitely we can consider, after doing a functional echocardiogram, we can consider critical congenital coarctation of aorta. So what happens here is, previous slide. There will be left ventricular perfuse upper half of the body proximal to coarctation. When there is this, as this being a ductal dependent lesion, once the duct closes, whether it's a PDA or any other duct, then the left ventricle fails trying to pump the entire cardiac output through upper body. lower half of the body becomes ischemic as arterial blood supply stops. Going to the management part, once through functional echocardiogram, it is diagnosed as critical congenital coarctation of aorta. We go for a either if the baby is stable, we can go for the next slide. End-to-end anastomosis, resection with end-to-end anastomosis. Before that, to stabilize the child in NICU, we start prostaglandin E1 infusion and antihypertensives when the upper limb blood pressures are very high, and diuretics to be added as per the requirement. So the surgical treatment will be resection and end-to-end anastomosis when the baby is quite stable. Other surgeries which were tried were balloon angioplasty, subclavian flap angioplasty can be tried, but still coax are very common with these surgeries.
So this is probably the last case we'll be discussing because we have less time. So this is a full-term baby with MSL and a perinatal depression requiring positive pressure ventilation for poor respiration at birth, referred to NICU for severe respiratory distress. At admission, the temperature was 38, heart rate was 172 per minute, respiration 76, hyperinflated chest, SpO2 86%, chest X-ray was suggestive of MAS, BP was 62/44, and this baby was carried with high frequency oscillator ventilation with MAP of 16%, FIO to 50%, amplitude 14, and the frequency of 9. Baby was labile and there was SpO2 in right upper limb 94% and lower limb 84%. At 12 hours of life, sister noted a BP of 52, 26, 35, CFT of 5 seconds, low urine output. So my question to Dr. Sahana, how to evaluate this baby and manage?
Yeah, this is a common scenario we face day in and day out, and it's a nightmare to the neonatologist. So the natural history of the PPHN, which peaks around 72 hours, and here we are suspecting a PPHN with the meconium aspiration with the PPHN, and the baby has presented at 12 hours of life with cardiogenic shock and could be due to the worsening of the pulmonary pressures. And so functional echo, the bedside echo point of care, if feasible, will help in evaluation the contractility and to rule out the other conditions like rule out the other critical congenital heart diseases and pulmonary pressures and the cardiac output and myocardial contractility. So apart from this natural cause, the worsening of the PVR in this case could be due to increase in the MAP. Next, sir. So we have to, once we do the functional
Madam, short.
yeah, it's already covered. So with in the echo, so we have to rule out the structural heart diseases, and we have to confirm the pulmonary pressures and assess blood pressures have to be checked and look at the cardiac function, and then we take a call. And more so, you have to do the minimal handling of the baby, and when the baby is on ventilation with a good sedation, and depending on lung recruitment, and if required, surfactant has to be given. And depending on the blood pressure and the myocardial function, we can go in this algorithm. If the normal blood pressures with good contractility, we go ahead with oxygen and normal pH. And if nitric oxide is not available, like poor man's thing, you can use a sildenafil. With normal blood pressures and with a cardiac dysfunction, we go for milrinone, because if there is a low blood pressures, milrinone again causes hypotension. And with the low blood pressures and good cardiac functions, we give a slow bolus of 10 ml per kg over 20 minutes, and we watch for the MAP, and then go ahead with the inotropes like DOPA and norepinephrine. And if there is low blood pressures with the cardiac dysfunction, and we have to calculate the oxygen index or oxygenation saturation index, depending on that, ECMO, INO, and then fluid bolus with the other inotropes like epinephrine and vasopressin and noradrenaline. Thank you.
So echo showed PPHN with biventricular failure. So this is last case. This is a preterm baby, 35 week, 2 kg, day 9, presented with poor feeding and lethargy. On examination, the temperature 35 degrees centigrade, heart rate of 178 per minute, respiration 64, CFT prolonged, BP 34, 22, 26, peripheral cold, saturation 91% with poor urine output. So here the baby was warmed, headbox oxygen was started, and saline bolus of 20 ml per kg, 20 ml over 10 minutes given, and started antibiotics and dopamine, and subsequently the dopamine was increased to a maximum dose, but BP still remained low. So here I will ask Dr. Padma, will you agree to this management and what you will further advise?
That slide. See, this is a case of shock, not responding maximum to the dose of. I'll add. What is this? This slide. Previous slide. Yeah, this is a case of severe shock, not responding almost to the maximum dose of dopamine. So we'll add epinephrine, and more than that, apart from regular workup, quickly we have to send for CBC, cultures, ABCs, and other these things. And next, most important, underlying pathology, and accordingly we modify the therapy. So this is a chart again, the same thing which we have to follow. I'll not go deep into it. So all of us know that at 0, what's the most important thing, what we have to start at 5 minutes, between 15 to 20, what we have to do. So this is how it is. So already many of my colleagues have discussed it, so I'll not go into the detail.
So thank you. So this baby had echo suggestive of a pulmonary hypertension with biventricular failure. I'll just put the last question to Dr. Suman. Do you think functional echo in the beginning would have changed the management in this particular baby?
My thoughts are that we are dealing with septic shock here. And we know that in septic shock, you might have to give much higher fluid volumes, maybe even up to 60 ml per kg. And therefore, a functional echo would have had benefit, particularly to look at, is the pump full? See, inotropes is not going to be helpful unless the pump is full. Only then it will help it pump. So I think it would have definitely helped us to know the fluid status and be more confident of giving more fluids. And that could have changed the management.
Okay.
Thank you.
So I should skip a few questions. So last question I'll ask to Dr. Dr. Anup, just regarding steroid. There is a lot of discussion about steroid in shock. So whenever you are starting steroid in shock, are you doing some test to decide whether there is need of steroid in this particular baby, or you just clinically give it? So I'll just ask Dr. Anup to clarify this. Dr. Anup.
Thank you, sir. Thank you, sir. Like we know that when the baby has persistent shock, baby is not responding to fluid boluses and other inotropes or the vasopressors, then definitely we think of the adrenal insufficiency. It could be either absolute or it could be relative. And definitely we go for we try to give hydrocortisone at a rate of 1 milligram per kg or 15 milligram per meter square infusion. This is considered for only when the shock is fluid and the vasopressor resistant, especially in the extremely preterm babies. And definitely before giving hydrocortisone, we can go for serum cortisol level before giving hydrocortisone therapy. But we know that when the level is somewhere equivocal, we are not very sure, but a serum level of less than 5 microgram per deciliter is definitely suggestive of adrenal efficiency, and the hydrocortisone replacement would help the baby. But a level, even if the level is less than 15 microgram per deciliter, they will also respond to hydrocortisone due to the relative adrenal insufficiency. And we know that how does it help? It helps by increasing the expression of the cardiovascular catecholamine receptor expression, and it also decreases the catecholamine metabolism and therefore increasing the intracellular calcium. And those are repeated. It is given at a dose of 1 milligram per kg, and the repeat doses depend on the efficacy and the response we note. It can be given 8 to 12 hourly for 2 to 3 days, depending on the response.
Thank you, sir. So this was quite extensive discussion. So I have to summarize few points from above discussion, that the shock is inadequate tissue perfusion. So it is nothing about the BP number, and in isolation, it is never helpful in diagnosis of shock. So good history, clinical examination, lab investigation, and overall functional echo will help defining the pathology of shock and guide its management. And always start with TABC. Ensure good oxygen carrying capacity of the blood and good perfusion by addressing underlying pathology. Fluid has to be given with caution in small babies and babies with AKI and SIADH. In other cases, after initial fluid boluses, the further fluid bolus should better be guided by functional echocardiography. And all vasopressor do not have same effect in all regional circulation. So selection should involve understanding of underlying pathology and differential effect of vasopressure or inotrope on different regional circulation has to be there. Ventilated baby should have chest X-ray to look at the cause which can aggravate shock like hyperinflation, pneumothorax, which can adversely affect the course of shock management. Functional adrenal insufficiency should be considered in case of catecholamine resistant shock, specifically in VLBW babies. Shock can be presentation of cardiac disease, and this should be kept in mind after initial resuscitation. PG1 can be started pending echo. So without echo also you can start prostaglandin E1, and functional echo should always be performed in all cases of difficult to control and severe shock. So here, just to summarize the effect of different inotrope and vasopressor on different regional circulation. So this is a very beautiful diagram which says that if you look at dopamine, it is only vasopressor, increases systemic arterial pressure, and dopamine here it is having some effect of increasing cardiac output, and similarly some effect of pulmonary effect. So if you just follow this diagram, probably each inotrope or vasopressor will have overlapping effect on heart and different regional circulation. So deciding a particular inotrope or vasopressor, if you have this chart, you can better understand which is a better choice for a particular baby with underlying particular pathology. So thank you all the panelists. Thank you, the audience.
Thank you, sir. And we're very, very sorry for interrupting your talk, but I assure you that we're definitely going home with a treasure trove of knowledge. Thank you, sir. Thank you, ma'am. We would now like to request the moderator to extend a token of appreciation to our panelists. To Dr. Sahana Devdas. Dr. Gayatri Hemant. Dr. Padma Kumar Patil. I would also like to request the panelists to appreciate our moderator, Dr. Manas Ranjan Upadhyay. Thank you, sir. Thank you, ma'am. Now we have our panel discussion, Approach to Surgical Neonate, moderated by Dr. Mukunda Ramachandra. He is a consultant pediatric surgeon and a pediatric urologist in Rainbow Children's Hospital, Bangalore. And these are the panelists for the discussion. Dr. Nijagal Mut is a consultant pediatric surgeon, urologist, and surgical gastroenterologist in Madilu Children's Hospital, Tumkur. Dr. Alex Mani, chief consultant neonatologist, Marian Medical Center, Pala, Kerala. Dr. Binesh Ramachandran is a consultant neonatologist and a HOD pediatrics in Haster MIMS, Kottakkal. Dr. Babu Madarkar, consultant and head, Department of Neonatology, Rainbow Children's Hospital in Bangalore. And Dr. Jagdish Somanna, associate professor in Department of Pediatrics in MVJ Medical College and Research Hospital, Bangalore. I welcome all. Over to you, sir.
Good afternoon, everyone. I'm Dr. Mukunda Ramachandra, consultant pediatric surgeon working in Bangalore. So I'm going to discuss about the surgical references, what you get in NSU setup, and how to manage about the each and every patient. So we have a slight PPT running in the background, and our panelist is going to explain the surgical approach. So without wasting any time, so the first patient, a very common scenario in NSU, preterm on feeds, suddenly develops bilious aspirates. Then there will be some abdominal distension, then some hypertension or plus minus hypertension. And this is the X-ray picture. This is for Dr. Babu. I think he's on virtual. Okay, yeah. So how are you going to manage this patient, sir? What's your probable diagnosis?
Yeah, thank you so much for giving this wonderful opportunity to be one amongst this August gathering, to have a very fruitful discussion on surgical emergency, which we see in day-to-day practices. So when we see this symptomatology, abdominal distension, temperature instability, bradycardia, and thrombocytopenia, none of them are very specific for any disease. They can be commonly seen in sepsis, or they can be commonly seen, these symptoms can be seen just in baby who presents with hypothermia. But then looking at the background, wherein baby's preterm was previously on feeds, probably formula feeds, and temperature instability, bradycardia, thrombocytopenia, they probably look at, showed indicated towards necrotizing enterocolitis. Maybe early necrotizing enterocolitis, early stage in NEC.
Okay. Thank you, Dr. Babu. So this, okay, same thing now. Okay. See, are you going to involve a pediatric surgeon in stage 1? Maybe when there is a non-specific diagnosis, as you told, sepsis, NEC, some other scenario. So, Dr. Alex, are you going to manage a pediatric surgeon, involve a pediatric surgeon in the early course of the disease of NEC?
Of course, we should involve a pediatric surgeon even in the stage 1 itself. Actually, we should manage the baby along with managing the cardiorespiratory and hemodynamic instability. We should, regular RT aspirates should be done, and we should counsel the parents about the chance of progressing the disease. So always pediatric surgeons should be involved in the stage 1 itself.
Okay, thank you, Dr. Alex. No, the same patient. For Dr. Jagdish, no, so ultrasound in cases of NEC. So how do you practice very frequently in your unit? And what's your take on ultrasound in the management of NEC?
Ultrasound has made a difference in the early diagnosis as well as follow-up of progression of NEC. And as such, mainly it has a great spatial resolution in detecting the peristalsis, perfusion, as well as motility, and which is going to indicate and to detect ascites, early impending perforation, which is going to be, as you see, by thinning, as well as decreased perfusion, impending perforation, and also in especially extreme preterms where you have just they present with silent intestinal perforation. So if you want to detect it early, then ultrasound is definitely going to help you. And of course, vis-a-vis your X-ray, the previous standard of diagnosis, you have more specificity as you compare to all your signs of NEC. And apart from the older previous, which we are all comfortable, that is your pneumatosis intestinalis or your portal venous gas, the specificity and sensitivity is much higher in your ultrasound. Of course, it has a bit of pitfalls, like you have inter-observer variability. Sometimes the baby can deteriorate. You can have some heart rate instability, apnea, etc. during that time. And of course, if it is having a bowel gas shadow above, then you are going to have problems in interpreting. You can use a more jelly and then you can use it. Definitely, it's going to help you to detect it early. And also, as I said, it's also helpful for progression of the disease. So suppose you've kept him NPO and started your antibiotics, you can follow up with a follow-up ultrasound and you can see improvement in perfusion, improvement in the peristalsis. So it's not only going, and also it helps our surgeon to take a decision to go ahead early. So
Okay,
this way,
thank
I
you.
think ultrasound has made a
Thank you
difference.
so much. No? See, now, this is for Dr. Nijgal. See, impending perforation, perforative peritonitis. A small baby, 1 kg, around 800 grams to 1 kg. How do you decide about the further course of action, surgical management, when the baby requires some kind of intervention?
Actually, it depends on the cardiovascular compromise. If the child is cardiovascular stable, cardiorespiratory or cardiovascular stability is there, then if there is a perforation, then only a surgeon is required. Only when there is perforation. Otherwise, I don't intervene. When there is instability, we just put in a drain, glow drain, or any drain, and then make the child stable. Then we go ahead with the exploratory laparotomy. If the child is clinically stable, then we can go straight away with the exploratory laparotomy.
So
if there is
once-
perforation,
Okay.
perforation is the thing which decides whether it needs surgery or not.
So I think many of us follow the perforation is a criteria to go in rather than impending perforation is very, very difficult to diagnose. And until you have a very solid evidence of thinned out bowel wall, a localized disease, then only we can think of before perforation, we can go for a laparotomy and do the needful for the child. Maybe majority of times ileostomy is required to tide the crisis. Depending on that, on the baby grows, we have to take a call about further treatment. Okay. Okay, this is how we covered it, no? So this is the same thing, okay. So again, the next one, the most common thing in a NICU setup will be the respiratory distress, increased work of breathing, increased oxygen requirement in a preterm. So what are the things you're going to think about whenever there is a problem like this? This is for Dr. Binesh.
Good evening. So right from the X-ray, it's very clear that you can see that on the right side is a jet black lung with the collapsed lung margin. So it's a clear case of pneumothorax, and especially in a baby like this, with a sudden distress, there is no option left otherwise to drain the pneumothorax, to put in an ICD tube and drain the pneumothorax as soon as possible. That being said, you can also manage a pneumothorax conservatively if it is in a stable baby with this relatively asymptomatic baby. But even in that case, you should have the you should keep in mind that a pneumothorax in a newborn baby at any time, to begin with, it may be asymptomatic, but any time it can progress and make problems. So even if you are doing a conservative management, you should have the facility to monitor the baby adequately, and also to do you should have the adequate facility and expertise to go for a ICD tube insertion when in emergency. So if it is a unilateral pneumothorax in asymptomatic baby, and especially the small pneumothorax like occupying less than 30% of the lung, in that case, special case only, you can go with the conservative management. Otherwise, you, as soon as diagnose it, go for a ICD and draining of the pneumothorax.
Thank you, Dr. Binesh. The small pneumothorax can be managed conservatively with a serial monitoring of the child. If there is a coronary respiratory compromise, then immediate intervention is required by putting in ICD to drain out the air. This is for Dr. Nijgal. See, whenever there is a hyperlucency, you can see the two X-ray pictures here. The hyperlucency. What are the other things comes into your mind when there is a unilateral hyperlucency with a coronary respiratory compromise in a preterm child?
Actually speaking, the pneumothorax is the primary diagnosis when we have an hyperlucency. But the main thing is we need to look for the mediastinum, whether it is being pushed to the opposite side or not. Usually in a case of pneumothorax, the lungs will be collapsed. In the case of CLE, that is the other diagnosis which we'll have in mind. It will push the mediastinum to the opposite side. That is when you require an emergency thoracotomy. If at all, if the child is in distress, if the child is stable, then we can plan for investigating it further with a CT, in-house CT if we have. Otherwise, if the child is distressed, then we'll go ahead with an emergency thoracotomy.
Yeah, that's on top of Nijal. See, one is congenital lumbar emphysema should be kept in mind whenever there is a hyperlucency. There's a mimicking a pneumothorax. As Dr. Nijgal said, where is the lung? At the hilum or at the base of the diaphragm? And then there is a pleural herniation to the opposite side. So then the CLE will be there. ICD is not going to help. So you have to involve a pediatric surgeon and proceed further. See now, this is for Dr. Babu. See, antenatally diagnosed congenital diaphragmatic hernia. How are you going to counsel the expected parents and what they should expect when the baby is born?
When we have to counsel the parents with respect to the CDH, the predominant part of the counseling depends on the outcome. They would be wanting to know the outcome. Now, this outcome depends on how much is the degree of lung hyperplasia. So to understand the lung hyperplasia, we have only the surrogate markers. One of the marker is presence of liver in the chest, or if there are other ratios which can be ultrasonographically and done, like lung head ratio, and there is something also called as observed to expected lung head ratio. Third thing is percentage predicted lung ratio. So many things are there. Usually we have one cutoff value of 1 as a cutoff value, below which the outcome will be poor, and if it is more than 1.4, the outcome will be good. So the presence of hypoplasia will actually determine the degree of PPHN that baby would have after birth. So both of them are correlatable. If the baby is going to have severe PPHN, the outcome is going to be poor. And if the baby is going to have severe hypoplasia, the outcome is going to be poor. So I think it is the LHR ratio or other ultrasonographic detected ratios that we need to use to counsel the parents at the time of detection.
Thank you, Dr. Babu. So it's about Dr. Alex. So once the baby is born in the delivery suite, what's your approach for the baby? How do you stabilize and how do you proceed further?
Sometimes the baby might be asphyxic, so we might have to intubate immediately, and we might have to do an emergency, intubation, and otherwise we'll have to do elective intubation later. Sometimes, so another one is but make sure that no bagging with bag and mask with mask should not be done in the delivery room itself. So that is very important. And without knowing that it's a CDH, many people used to do this bag and mask in the delivery room. So if it is not antenatally diagnosed, then it can be a problem, like if you do bag and mask in the delivery room. Another thing is do regular, keep NPO, and the large bore orogastric tube should be inserted, and regular aspirate should be done. Keep the uninvolved area of the lung should be on the elevated side, and along with managing the cardiorespiratory and hemodynamic stability also should be managed appropriately along with us.
Okay. Okay. So this is what the summary. So what is Dr. Nijgal, how do you manage a case of CDH once it is born? What's your approach?
No, the thing is, my approach is very simple. I'll give it to the neonatologist for initial 3 days. If the child is clinically stable and no desaturation or anything, then I think we can keep the child and we can manage him with conservative means for 3 days. And if the child is in distress, if the child is having desaturation, then we'll ask for an elective ventilation or emergency ventilation depending on the saturation. Then once the child is clinically stabilized, then I'll go ahead with a repair of the diaphragmatic hernia after 3 days. At least 72 hours, I'll wait.
Okay.
And there are 2 approaches for diaphragmatic hernia repair. You can do it thoracoscopically or else with an open.
So the take-home message is CDH should be managed by the neonatologist. The pulmonary pressure should be stabilized. Then only the surgical role will come. Surgical role is minimum. It's very, very straightforward surgery for a pediatric surgeon. Unless the lung hyperplasia, what are the pulmonary pressures is been controlled, the outcomes will not be better. This is what I talked about. So, Dr. Jagdish, can you differentiate between a diaphragmatic hernia or eventration in a case of an antenatally diagnosed scans when the fetal medicine specialist tell that there are some loops in the thorax?
I think antenatally, no, because both of them present in a very similar fashion. So antenatal scan, probably no.
Okay, yeah. See, this is for, because eventration and diaphragmatic hernia, what is your take on, Dr. Nijgal? Which patients will have a better outcomes?
Better outcome will be eventration of the diaphragm.
Yeah, eventration, invariably the lungs will be better. So once you do a newborn X-ray, eventration, if you see that, we can confidently counsel the parents that this baby is going to do well. So that's very, very important to keep in mind whenever see that eventration and diaphragmatic hernias. So the next things what we commonly see is again the bilious aspirates in a normal looking child, no sepsis, hemodynamically stable, no abdominal signs. So what's your approach, Dr. Balchandra, when there is a tummy is not distended, abdomen is soft, child is not sick, child is stable, my baby is yawning? How are you going to do about this case with the bilious aspirates in a normal looking newborn baby?
First of all, any case of bilious aspirate to be taken as significant case of purulent organs. Hello. And the child should be kept NPO, put in an RT tube, and you just examine the child. Look for whether the child is septic or not septic, how the abdomen looks like, whether it is distended or not, how the abdomen veins are present or not, and then how the abdomen feels like, whether it is tense or tender, and how's the bowel sounds, whether it is there or not. Then you insert, if there is already not an IV line, insert an IV line, send septic screens and electrolyte, then start an IV fluid. Then you go for the first, any significant case of perineum, the first investigation should be an abdomen X-ray, ideally in a erect posture. And depending on the gas shadows, you may get some clues regarding what is the diagnosis. And especially in a case with the suspicion of malrotations, like if you have a normal looking bowel pattern and with the persistent bilious aspect, then you go for a barium meal follow through. But if the X-ray shows something sinister, like a sigmoid sign or clear-cut bolus or gasless abdomen, then you may directly go for a laparotomy also.
Yeah, so the contrast meal follow-through is one of the important diagnostic thing. What may do have bilious aspirates in a newborn thing, we have to keep malnutrition in our mind. So this is the normal X-ray on the left side. This is a malnutrition X-ray on the right side. The DJ will be on the right side of the abdomen. The loops of the bowel will be the left side of the abdomen, the right side of the abdomen in malnutrition. And this is the normal X-ray for a contrast meal follow-through when compared to the other X-rays. So
I differ a little bit here.
So
I differ a little bit here.
Yeah, yeah.
What my approach is.
Yeah.
Whenever there is a neonate with a flat abdomen with bilious aspirates, I think we need to suspect a malrotation and go ahead with a laparotomy. This is what I usually follow when I'm strongly suspecting there is malrotation. When you have a scaphoid abdomen.
Yeah. So
because we might be losing a lot of time. We might end up in whatever you're showing in the next photo.
Okay. So next question. See, when you are worried about malnutrition, is one of the simple procedure for a pediatric surgeon. It's a standard procedure. The results are excellent. But as Dr. Nijgalmat was talking about, if you lose time, the volvulus is one of the major problems. So if you see a gasless abdomen, then what are you going to do? What do you suspect and how do you counsel the parents?
We usually suspect a malrotation with volvulus, probably a gasless abdomen. Then I'll counsel them for malrotation and I'll go ahead with a latch procedure directly.
Yeah, so this is one of the dreaded complication of a malrotation with volvulus, going especially the mid-gut, from the second part of the duodenum to the one-third of the transverse colon will go. Once you have this kind of a gut, unless we can't see how the baby is going to do well, we have to do the procedure, do a redo laparotomy after 48 hours, hope that it may improve. So the counseling is very, very tricky. And I had to keep this in mind in a bilious aspirate, abdomen distended, X-ray showing gasless abdomen, volvulus is the thing we should keep in mind. So, next question. So, bilious aspirates, okay, bilious aspirates with no abdominal signs. So, whenever there's a bilious aspirates with abdominal signs, like distended abdomen, dilated veins, what are the other possibilities you think of?
It can be Hirschman's disease.
Okay.
With abdominal signs.
Without abdominal signs, bilious aspirates. You can rule out malrotation, still having bilious aspirates.
Yeah,
Then comes for Dr. Babu, this question is?
Yeah, so most of our neonatal literature says bilious aspirate, unless proved otherwise, is malrotation. But then there is difference of opinion between neonatologists, neonatal practice and the pediatric surgeons, because it all depends on pediatric surgeons' expertise to identify. It can be, it may not be a malrotation as well. But other common causes are dural atresia and ileal atresia. The basic thing is wherever any stricture beyond the point where beyond attachment of common bile duct to the small intestine, if there is any obstruction, it might have bilious aspirates.
Okay, so thank you, Dr. Babu. So again, I skipped one question. No? This is for Dr. Nijgal. When there is bilious aspirates and abdominal signs, abdominal distended, dilated veins are there. So what are the things you keep in mind?
With abdominal signs, that is abdominal, the abdomen is distended, then I'll always think of, most commonly, if it's a term baby, term neonate, then I'll think of an Hirschman's or meconium ileus or meconium plug syndrome can be a possibility.
So how do you decide about when to do contrast enema or whether to wait?
Contrast enema, I usually decide, I'll just go about with a meconium history. If the child has not passed meconium for 24 hours, this is what I do. If the child has not passed for 24 hours and there is abdominal distension progressively increasing, then I'll go ahead with a gastrography enema straight away. I don't even wait for long.
Yeah. So
and then start on washes.
Yeah, contrast enema will be therapeutic in meconium ileus, meconioplex syndrome, and sometimes Hirschsprung cysts also. So this is for Dr. Alex. If the child has got abdominal distension, dilated veins, and there is no anal opening, so what are the things you look for before involving a pediatric surgeon?
Yeah, see the anal opening. If it's absent, then see whether the baby is a boy or a girl. According to the gender, it's going to be a different conditions. If it's a boy, the common thing is like see whether there's a meconium passing through the through the urethral opening. So the commonest in boys are recto-urethral. One is the commonest in boys. So see for that and manage accordingly.
Okay. So Dr. Nijgal, when you see meconium per urethra, so what's the first thing comes to your mind, and how do you proceed further?
Usually, if you see a meconium pearl, that's called meconium pearls. If you see in the perineum, then it is usually, most of the times it is low ARM, where you can do a single stage procedure and finish off in the NIC only, where you do a anaplasty.
Okay. So when you suspect, like if you have a meconium, frank meconium, and there is no meconium pearl, so when you decide about the colostomy in a baby boy?
Colostomy, we will usually do a colostomy if at all, if it's an intermediate or a high ARM.
So this is what Dr. Nijgal is trying to tell us, because with this one is a recto-bulbar fistula, the rectum opening into the bulbar part of the urethra. Next is the recto-prostatic fistula, with the prostate is opening the prostate, or the rectovesical fistula. So these things is definitely needs a colostomy and we have to do a next procedure, and the baby is 3 months old. Okay, if there is a baby girl, again is for Dr. Nijgal, how do you manage?
If it's a female child with a anal opening inside the vagina, it can be what is that, rectovestibular fistula.
So colostomy is required or not required?
Yeah, I don't do a colostomy. Start on rectal washes straight away and do a primary PSCRP or ASCRP depending on the comfort quotient of the surgeon. I do a PSCRP now.
Okay.
At around 5 to 6 months.
5 to 6 months. Okay. Thank you, doctor. So what again is for Dr. Nijgal, if there is a single perineal opening, there is no urethra, there is no vagina, what is the diagnosis and how do you manage this patient?
It's a cloaca. It's a very difficult case to manage. We usually do a transverse colostomy and then leave it alone if the child is passing urine. That is what we most of the times do.
So cloaca is one of the very bad anomaly for the child, where the bladder, the vagina, and the rectum opens into a single channel and opens into the perineum. So again, this is for Dr. Nijgal. This is more purely a surgical patient. So sudden onset abdominal distension, bilious aspirates. We can see when they do bag and mass ventilation, the child is getting more worse. Child is not getting better. So what is the diagnosis and how do you manage this patient?
Probably looks like a NEC with perforation. It's a preterm, right?
Yeah. See, a spontaneous gastric perforation.
Spontaneous gastric perforation is also a possibility. Or else, because it's a preterm, even NEC should be kept in mind.
Maybe NEC has to be kept in mind, but
But
you
such a
see
huge
gas
pneumoperitoneum.
and the liver is smaller.
Yeah.
Gastric perforation should be kept in mind. The NEC is also a possibility, but a simple grout drain placement, waiting for 4 to 5 days, that is going to spontaneously heal and the child will get better and no further intervention is required.
No, I have seen, I have a case with this same thing. There was a gastric perforation. Whatever you told, we kept a grout drain, but it didn't recover. So I had to do a laparotomy and then close the gastric perforation.
Depending on case to case, we had to give time. If you put a grout drain, there is no bilious bile coming, only no fluid is coming, only serious fluid coming. That means we are not breached the intestines. We can give time for natural healing for 3 to 5 days. If there is still a problem, then we may require laparotomy and close the gastric perforation. So this is the same patient. Okay. So next case is I'm going to touch about some pediatric urology conditions which are going to be seen in a newborn child. So whenever you do a antenatal, because anomaly scans becomes a very common thing, the first thing they see is a hydronephrosis in a expectant mother. What are the things you look for, Dr. Jagdish?
So antenatal detected hydronephrosis, as Sir said, is the second most common abnormality you can see. You can see it right from 12th week onwards. So what we are interested mainly, whether it is unilateral or bilateral, and then we want to know where exactly the site of obstruction, for which you would like to know whether it's only the calyceal dilatation or whether there is a ureteral dilatation also. You would look at bladder wall thickening. You would look at specific signs like keyhole sign. You would look like for other surrounding anomalies like perinephric urinoma. And then you would also look at what is the kidney status. That means you would like to look at the thinning, cortical wall thinning. You would look at cyst echogenicity. So to look at and prognosticate the baby. And of course, we have the grades based on the APT diameter and the SUF grading. And based on that, we are going to take as well, if you look at antenatal diameter, we are going to warn whenever it is above 4 millimeters in the second trimester, above 7 millimeters in the third trimester, and anything above 15 most likely may require a surgical intervention. So basically to classify, to look at unilateral or bilateral, and to look at where is the site of obstruction, and other associated things like oligohydramnios and specific lower urinary tract abnormalities. You would look at bladder wall thickening more than 2 millimeters, keyhole sign. And then of course, as I said, you would also like to look at what weekly scans you need to do. So suppose if it is bilateral, then he requires further an intensive follow-up, 4 to 6 weekly scan. But if it is unilateral and detected at second trimester, you can follow it up. And one just thing, it's most of them, you can see around 40 to 80% would be transient. And it's a part of developmental origin. So therefore, I think that's the importance of detecting it. And all of us should know about the grading and how we do for each.
Okay, so when the baby is born, this is for Dr. Binesh, we have a pelvectasia, there is no hydrorator, bladder is normal, other kidney is normal. So what will be the likely diagnosis?
Most likely to be a PUG obstruction as localized obstruction.
Okay, so thank you. Yeah. See, next though, this is for Nijigal. This is what we always, as a, how do you decide about the SFU grading and further management?
The severity is assessed by SFU grading. Grade 1 and 2 usually don't require anything. That's the lower grade. Or there are mild cases where we can do just a follow-up. Grade 3 and 4 will require some kind of an intervention at some stage. It is not that we need to do it in a neonatal age. Sometimes we might have to wait.
Okay. So how do you manage grade 1 and grade 2 hydronephrosis in a newborn child?
The good thing about hydronephrosis in neonates is that it tends to heal by self, unlike in adults or pediatric age group. So I feel watchful expectancy, regular follow-up is what it matters. We have to keep on following up these babies. Maybe over time it might heal by self. But in case of need, there will be a requirement of ultrasound, which may be performed at 6 weeks or 6 to 8 weeks. And depending upon the worsening, depending on the status, we might have to plan a rhinography also.
Okay. So, Dr. Nijigal, if there is a grade 4 hydronephrosis, thin down renal parenchyma, and you see there's like a bag of worms, there is no parenchyma at all. So what's your approach when you see a palpable lump, grade 4 hydronephrosis? How do you going to proceed further?
Usually when there is a thinning of parenchyma and a palpable lump, PCN would be the ideal choice in these kind of children, if there is a palpable lump.
So how long you going to keep the PCN once you keep the PCN?
At least for around 15 to 21 days. That is what they tell. But sometimes we can keep it a little longer also. But that should be good enough if the urine output is good.
Okay.
And then do a DTPS scan and evaluate, and then go ahead with a definitive procedure.
Okay. So, so this is for Dr. Alex Manning. As Dr. Nijigal was telling you, 2 weeks of PCN and pyeloplasty. What are the benefits of early pyeloplasty? Because people used to say, wait for 6 months, 1 year, baby becomes bigger because they're worried about the anesthesia. So what is your take on early pyeloplasty done in the first month of life?
Sir,
Pro-
sorry to interrupt, but we have 10 more minutes.
See, there is a chance of progressive deterioration of the condition. So if you can do in the early days of life, it's much better because it's if there is a damage, it's irreversible. So if possible, it has to be done as early as possible.
Yeah, so early pyeloplasty, as the baby is growing, every organ in the body is growing. So when you take out the pressure, the functional outcome, the reversible factors for the what the kidney was there in the before the baby is born, sometimes the hydronephrosis improves better and the kidney function will be preserved very well. Early pyeloplasty is that because initially we used to think about the surgery will be delayed because the neonatal anesthesia, very good NICU setup, we can do interventions as early as possible, depending only looking at the condition rather than the weight and age of the child. So the next thing we commonly see in a labor delivery suit is one kidney is not descended, absent testis in the scrotum. So how do you going to counsel the parents and take it for the further treatment plans? For Dr. Jagdish, this is for.
So any approach is in the three forms like history, examination, and investigations. Looking at history, you would like to know whether it's a term or preterm. So definitely you don't know the gestation. You would like to know if mother was any androgens, or if you had, there could be a family history, or even there could be like what could be the previous history if there was, and then you're going to ask for the examination. So on examination, you want to know whether it is unilateral or it is bilateral undescended testis. You would look at examination of the testis right from what we call as a milking from the inguinal canal downward. So you want to look at whether it is in the inguinal canal, and also you look at whether it is in the surrounding. It could be in perineal or surroundings, whether it is there. And if it is there, the other common differential for an undescended testis is a retractile testis. So when you milk it down, if you're able to get it down to the demetin portions, then probably it is a retractile testis. And the other thing is you would also look like other symptoms like when you're seeing on the examination, that could be asymmetry of the scrotum, or there could be a hypertrophy of the contralateral testis. And then, of course, when we are looking at it, it's mainly for deciding and giving the time for expectant management. That is, by itself, is it going to come? So you're going to look at what is the time and age of presentation when you have detected it. So you see whether it comes down spontaneously by 6 months, and therefore gestation I would look at where is it, whether it's presented unilateral or bilaterally, whether it's in the inguinal canal or the other place.
Okay, Dr. Nijgal, what is that ideal timing of orthopexy when you dissect undescended testis in a newborn period?
Newborn period, we don't do any orchidopexy. It's around 6 months, which is the ideal time.
Okay.
That's the ideal time for doing an orchidopexy. But sometimes you might get late presentation somewhere around 10, 11 years, 6 years, 7 years. The chances of fertility is really very less if you're doing an orchidopexy at that moment. But the only thing why you have to do an orchidopexy is to prevent cancer, to prevent they becoming cancerous lesions.
Yeah. So ideal timing, 6 months to 8 months. Dr. Nijgal, correct? 6 to 8 months is the ideal time to.
8 or 12 months. That is what they
12
tell.
months is the ideal time to fix a undescended testis problem. So in this time now, thank you so much for these presentations. I mean, allowing me to talk in this forum. Thank you, Dr. Nijgal, Dr. Jagdish, Dr. Binesh, Dr. Babu. Thank you so much. Done, no?
Thank you for enlightening us with the topic, sir. We would like to. As a token of appreciation, we would like to give. I request the moderator to felicitate the panelists.
And Ratnesh, I've already joined. Yeah, okay, okay.
Now I request the panelists to felicitate the moderator. Thank you, sir.
Thank you so much, sir. So I would like to request Dr. Rahul Yadav, sir, to join us on a stage and introduce the panelists.
Please come. Good evening, friends. Please sit. It's great to be here as a part of this panel discussion. Topic is art and science of reading X-ray and MRI. And we have got eminent panelists. We are fortunate to have a radiologist, actually, pediatric radiologist, Dr. Dhananjay, Dr. Vishwanath Kamoji physically, and other panelists are actually joining us virtually. So as far as this art and science is concerned, basically we'll focus more on X-rays rather than MRI. And in last panel discussion, we have a lot of abdominal X-rays. We'll focus on chest X-rays. And of this one, the clinician view and radiologist view both will take into account because clinician ultimately has to correlate it clinically. So we'll go through slides, X-rays, and in between we put MRI also. Yes. Yeah. So our panelists are Dr. Suja Mariam, Dhananjay, Vishwanath Kamoji, Dr. Rahul, and Dr. Vamsi. So first of all, this X-ray we'll discuss. This question goes to Dr. Vamsi. Dr. Vamsi is there virtually?
Yes, sir. Yes,
Yeah.
sir. Am I audible, sir?
Yes, yes. So
Yes,
Dr.
sir.
Vamsi, this is a baby, which is extreme preterm baby, 23 weeker, and
Yeah.
day 2 of life. Had
Yes.
RDS and received surfactant twice. Now what happens is
Yes,
that, I agree, 23 weeker baby is actually surfactant deficient. So
Yes.
we thought that this after second dose of surfactant, baby should improve, but baby was
Yes.
not improving. In fact, his effort requirements are worsening. And then we got this endotracheal tube. So
Yes.
what is your take on this X-ray and how to correlate clinically and how to treat it?
Yes, sir. Basically, I thank all the organizers for this opportunity. And since the topic is art of reading X-rays, I would like to touch the basics also for the mixed population of the audience. So for any X-ray, I think there are many mnemonics to read in chest X-ray. So one such mnemonic, which most of us know, is called as ABCD. So which we clinically, I will be touching upon the clinical part, which is easy for a clinician to read. A generalized strategy to read any X-ray so that we will not miss upon findings. A, you can keep it as a mnemonic for airways or airway pathology. And also we assess the quality of the X-ray. We see the positioning. It is a AP view and also the inspiratory phase or the expiratory phase. A good inspiratory X-ray should always be having at least 8.5 to 9 posterior ribs. And also the exposure. In the exposure, we should have a clear lung marking, and there should be clear demarcation of the vertebra. So this X-ray is having good exposure, and also we should make sure there is no proper rotation. So in this X-ray, if you can see, the clavicles are not symmetric on both. There is slight rotation, which is very evident. So you can read the position is good. It's a respiratory film. exposure is good, and having mild rotation. With this background, in this X-ray, we can see homogeneous lung pathology involving bilateral lung fields. A reticulogranule pattern is there, and also the tube position is high up. Generally, maybe my pointer is the I can't point from here, sir. If somebody can point out the ET tube in the slide there, it is normally the ideal position of ET tube should be somewhere 2 centimeters below the vocal cords, or it should be between the vocal cords and the carina. So anatomically, the position should be below the T1, which corresponds to the bilateral clavicles, and between the T3. Here we can see classically the ET tube is above the T1 vertebra, so it is very highly placed. It might be one of the cause for improper aeration and good expansion of the bilateral lungs. And even after surfactant, there is clear-cut ground glass pattern, which means the ventilation of the lungs is not appropriate. Second thing is B. B is basically we look at the bones and the soft tissues also. Here all the bones are looking normal. There are no fractures. And also in extreme preterm, you should always look for opportunity to assess the metabolic bone disease whenever you see X-ray. We should not miss metabolic bone disease. And coming to the C. C is for ABC of reading X-ray. C stands for circulation. Circulation, you should also comment about the cardiac border and any vessels. Here, there is no obvious cardiomegaly, and also in preterms and newborns, X-ray is not the gold standard to look for cardiomegaly. We should always do a bedside 2D echo. And the fourth thing is D. D is you look for the disability or any, again, fractures or all these things. These are the mnemonic to read a proper X-ray. And E is everything else other than what we had discussed initially, like the tubes. We already discussed about the tube position in this X-ray. And also, what else we have here? We have a umbilical vein there. And the umbilical vein is positioned in the liver. The right position of umbilical vein should be at the junction of IVC and the right atrium. Here it is in the liver, so we can say the UVC is slightly placed low. So I think with this briefing of this slide, I hand over the proceedings to Dr. Rahul Yadav, sir.
Yeah, thank you, Vamsi. So Vamsi actually focused on basically endotracheal tube position here. Endotracheal tube position is high up. Now problem happens practically is in endotracheal tube position keeps on changing with the position of neck. When you take X-ray, the position may be different. And after taking X-ray, position is different. So I would like to ask Dr. Dhananjay, what is the effect of extension and flexion of neck on ET position?
Thank you, nnecon, for giving the opportunity to talk. While taking X-ray, 90% of the time the position will be changed.
Yes.
So it will not be normal. So when we ask the radiographer what position you have taken, and you have to mention in the form before sending for reporting. So when we have the clavicles seen in both sides symmetrically, we think the frontal radiograph is taken properly. But next extension and flexion is not so well observed in frontal view.
Yeah.
So what we do is you see the soft tissue of the neck.
Yeah.
If it is wider, then we think it is little bit flexion is there. Otherwise, it is in normal position.
Very good.
Extension
So,
is obviously not made out.
Very good. So this one is a variable thing. So what he pointed out nicely, you look at the soft tissue of neck. The soft tissue of neck is looking like a very unusual, then we have to success unusual position. And we have to mention on form whether this extension flexion should be consistent. The consistent position, changing position or inconsistent, that makes a big difference. And it is a big artifact for this sort of confounding factor for this position of ET. Thank you. So we'll go to the next slide now. So he's available. Dr. Rahul is available. Rahul.
Yes, sir. Yes, sir. I'm here. Hope
Yeah.
I'm audible.
Yeah. So this is another baby. This is a first-born twin. Another extreme preterm baby, 23 weeks and admission. So here, this baby was also having respiratory distress, and he was intubated, and we got X-ray like this. So what is your take on this X-ray?
Thank you, sir. Before going into the X-ray, as Vamsi sir said, I would like to add some more points. It is about it's in general things about reading an X-ray. Like you have to look at the name and the hospital number, as well as the date at which the X-ray is taken. So that also has to be considered. Now, coming to the X-ray, as Vamsi sir said, that is ABCDE approach. Whatever each person will have their own way of reading an X-ray. So here, looking at the X-ray, you can see the lung shadow. There is some fine granular opacities, as well as a bit of air bronchogram. And while looking at the endotracheal tube, you can see that the endotracheal tube is lying slightly on the lower side, probably somewhere around T4 or T3 to T. It's around T4, so it is at the level of carina, I would say. So an ET tube at the level of carina is not good. It is not a good position because it can either slip mostly into the right main bronchus, thereby causing hyperinflation of the right side, and the just opposite, that is maybe collapse of the left side of the chest. So we have to position it in such a way that it is in the ideal position. That is, as sir said, it is around T1 to T2. That is the ideal position of placing an ET tube. So if you have an X-ray software, you can measure and pull it back, and then what else you need to do is you just need to document the tip to lip position of this ET tube, so that next time if you need to reintubate this baby, you don't need to take an X-ray again. So you just can use that measurement to fix the ET tube. So that can be done. So in this case, you need to pull the ET tube a bit and pull out a bit to make it at the level of T1 to T2.
Thank you. Thanks a lot. I would like to ask both now, a combination of clinician and radiologist. Sometimes clinically looks different and radiology look different. For example, X-ray is showing that ET is low and the air entry is good, saturation is good, blood gases are good, and sometimes vice versa. When sometimes ET position looks good, but clinically it is asymmetric. So there is lack of correlation is there. At that time, how we should proceed and how, because withdrawal of ET, sometimes we try, ET comes out. Sometimes we try to push down ET, cardiac touch happens. Baby suddenly goes for bradycardia, vagal syncope. So in this conflicting situation, how to proceed?
If you see the radiograph,
yeah,
without any history, I'll say there is no abnormality. Yeah. Just ET tube is in lower position, and I don't give any comment on this.
Yes.
But if you give a history of, okay, the baby is deteriorating or not maintaining,
okay,
then I'll say, okay, you may have to pull the ET tube up. Yeah. Otherwise, lung is fine, lung field is fine, except for the lower basal segment, some haziness is there. That may be because of preterm and the position of the baby and bed.
Yeah. Vishwanath.
I agree with Dr. Dhananjay. This tube is, and Dr. Rahul has, a tube is slightly on the lower side, possibly at the carina. And at carina, the air is going to go to both the lungs. That is why we will see that the saturations are good and there's practically nothing happening. Now, we must document that we have noted the tube is low, and at any desaturation, we must take that into account to pull the tube up slightly by about whatever centimeter it is, half a centimeter, quarter of a centimeter, pull it up to see whether the air entry is equal and the saturations are improving.
Very good. So this is, both of them agreed that don't treat the X-rays, treat the babies, and X-ray and baby clinical condition should be correlated, and you should be open to ideas. Suppose, as sir said, if at all in future, please note down that it is low, at present baby is fine, if required, we can pull out. The problem faced by many people in last many years is about the length of insertion. For example, there was a mnemonic like a 6 plus weight, 2 kg baby, 8, 1 kg baby, 7, like this. But this whole things are turned now because of this extreme preterm babies. Sometimes we don't follow that. So this so-called appropriate length may not be appropriate. So this high flow AT and low place CT is going a big way problem in packaging extreme preterm babies. So we'll go to the next slide. So this is actually MRI. So I would like Dhananjay to comment on this. It's a 19-day-old neonate. So what do you feel about this MRI picture and how to interpret it?
First of all, I always look at the request form, and then I'll see the baby. How is it? And if any attending doctor is there, I will ask them, how is the baby and how is it doing? And what is the reason you have sent for MRI? And is the MRI necessary at this age? Because MRI is not always necessary when you have ultrasonography, like cranial ultrasound or neurosonography. If you're doing, you don't require MRI. But what is the like? Why you want MRI? That is the question here. So if I get an answer, I'll just then go through few sequences which I feel which is important, like 3D T1 sequence, T2 sequence, flare sequence, which is done probably a 5th or 7th day and onwards, because before that it is not that much helpful. And diffusion weighted imaging, and one more last imaging is GRER, a susceptible weight imaging for blood. So here the images provided shows dilated ventricles, okay, predominantly dilated ventricles, which is more than normal, maybe mild to moderate. That is the, you can see on the right side, it's a T2 image. So middle one is diffusion weighted image, and the left side one is T1 contrast image. In T1 image, T2 image, in the first slide, on the right side, it shows only ventricle dilatation, nothing else. Except that there is small hypointense area in the posterior horn of lateral ventricles. If you come to the middle image, the bright structure is the diffusion restriction of the dependent debris or fluid in the lateral ventricles, which shows that some pathology is there. On extreme right, there is a diffuse enhancement along the wall of ventricles, and also increased vascularity, which is suggesting there is a meningitis as well as ventriculitis. With this, is it sufficient to do MRI, or you have to do something else? So that is the question here. So this is enough for clinician, but for us, follow-up is very, very important, because the next thing is it's going to obstruct the aqueduct of Sylvis, and then it will be obstructive hydrocephalus, non-committed obstructive hydrocephalus. After this, we have to follow up with the serial neurosonogram.
Thank you. Thanks a lot. So actually, he actually highlighted the need for follow-up. Don't depend on one MRI picture. Serial MRIs are very important. And this one, it will give us a clue to avoid actually development of hydrocephalus. So these are already done now, I think. We'll go to our next X-ray now. So who's taking this question? Soft tissue? Suja. So she's there, Suja?
Yes, I'm here, sir. Yeah.
So yeah, good. So this is the case for you. It's a 70-day-old baby. There's a big postnatal age is big, but it was very severe IUGR actually. Only 430 gram at birth, severely malnourished, had sepsis, BPD, more than 26 weeks, had low albumin level, edema, and this X-ray comes like this. The trouble happens is the water everywhere. Everywhere there's water. So now this particular baby is having generalized anasarca, and also there's a lot of whiteness in the chest. So how will you differentiate between this overlying skin edema and pulmonary edema, haziness?
Okay. Good evening, sir. Yeah, this, as sir mentioned, this X-ray has a lot of findings. So our eyes always go on to the lungs, which shows a lot of patchy opacities with streaky shadows. Probably this baby is developing bronchopulmonary dysplasia, as mentioned in the history. Now, to differentiate, we are very obviously, we can see the subcutaneous edema also, which is seen as a diffuse homogeneous opacities overlying the bony cage. It extends uniformly from the entire rib cage to the abdominal wall, and we can see a little bit of edema in the thigh areas and the extremities also. Now, to differentiate a subcutaneous edema from a lung shadow, one thing is a homogeneity. So when a baby is lying supine on the X-ray plate, if it is subcutaneous edema, one thing, the scapular subcutaneous edema would have been spread out evenly so that you have a mild granular shadow rather than reticular shadows like this. Then anasarca is usually not focalized. You won't have edema on the chest wall alone. So you have to track the subcutaneous edema to the other abdominal walls also and see whether try to differentiate the skinny part and the pulmonary shadows also.
Thank you very much. I would like to discuss with Dhananjay. We are facing a lot of problem in deciding about diuretic use in these chronic lung disease babies. If excess use of diuretics has got its own problems. And if you don't give diuretics also, there is a lot of accumulation in lungs, in chronic lung disease. So is there any recent development happening in the ultrasound of lung? In ultrasound of lung to complement our decision making in use of diuretics about interstitial edema?
Yeah, ultrasound is very important modality because you should not do X-rays, so often. But it is inevitable because ultrasound is not available, or trained person for doing ultrasound is not available. Maybe if somebody is doing, he may not pick up everything. So ultrasound is very, very helpful in interstitial edema because you can see the pattern of edema, the involvement of lobes, and whether it's dependent part, either it's in the upper lobe, and is it associated with the effusion or any other abnormalities, and any underlying consolidation available, or is progressively going on. So and also if you have ultrasound, you can monitor every day, and you can tell the clinician, okay, it's improving or it's reduced, or there are some predicting values where you nowadays a lot of research is going on predicting the outcome or prognosis of the interstitial edema and treatment pattern. So for that, I think we need to have a regular follow-up with the single radiologist, not
Yes.
different radiologists.
Yes, this is very important that this one, we are actually in learning curve right now. That ultrasound of lung is a learning thing, new thing. But in future, it will be very good. But as sir pointed out, one radiologist should keep on looking at it serially. So this one, that person, there are no normograms, there are nothing to compare. So we have to generate more and more experience and then titrate our therapy based on this. Thank you very much. So this one, Dr. Vishwanath. This is a baby with IDM, infant of diabetic mother. He had hypoglycemia, he had polycythemia, his PPHN, and you got an X-ray like this. So what is your take on it, and how it will be helpful for managing these babies?
This baby is in clearly a lot of distress. Infant of diabetic mother, there is hypoglycemia, there is polycythemia and PPHN. You look at the X-ray, the heart seems to fill the whole of the chest. And as Dr. Vamsi initially told, we go through the ABCD series, but with the story, I think it is Bangdol that the heart occupies the whole of the chest. So there is some cardiomegaly. Now we know that IDM babies will have one or the other heart diseases. So we have to rule out the most basic question, whether this baby is having hypertrophic cardiomyopathy or there is something else associated with this baby. The baby may not have HOCM, but the polycythemia itself can cause cardiac failure and this kind of a picture. So this baby will need multi-pronged approach to maintain the sugar, to reduce the polycythemia, PPHN treatment, and more importantly, if we diagnose HOCM or the asymmetric septal hypertrophy, as it is called, that management is very tricky. Further, if you look at the X-ray, the comment should also be on what else we see. The liver seems to be quite big, enlarged, though we cannot comment on the X-ray as such, but it looks quite big. And the UVC seems to be on the lower side. It must be quite high. The NG tube seems to be in good position. I cannot see the ET tube. Maybe it is in the right position there. If I can possibly trace it up, it seems to be in the right position. So having said that, the baby needs ventilation. The baby needs normalizing the values, which may include ventilation, high frequency, which may include inotropic support and management of the HOCM, which may need, lusotropic agents, not inotropic support, because that will again compress the outflow tract and make the situation worse. If we don't have milrinone, dobutamine is an alternative to use in such situations, not dopamine. So dobutamine plus or minus milrinone, ventilation, treat PPHN, get the blood pressure up, and we'll probably have a better outcome.
Thank you very much. I would like to ask Dhananjay, we are having doubts about this right heart border. Right heart border is traditionally formed by right atrium. So the roundity of right heart border, or it is a straightening of right heart border, it was thought initially that volume status, the volumes, like you said, at volume, right atrium is dilated or not. So can we use the right heart border serially to monitor intravascular volume?
X-ray is not an ideal. Echo will be.
Echo is better than right heart border, because you can have actually a false impression that right side is round, but actually may be hypovolemic.
Sometimes thymus, shadows.
Yes. There are so many confounding factors there.
So many things will be
Fine.
there.
Please, Vishwanath.
So we have just heard about the functional echo being very important in sepsis and management of fluid overload, management of inotropic support in all such babies. Is another situation where we'll need an echo and serial echo for that.
Very important. So now we'll go to one more question to Dhananjay. This is a MRI like this. So how would you interpret this MRI this in this film?
Yeah, this MRI shows increased intensity, hyperintensity in deep gray white matter and along perirolandic white matter and cortex. So this is case of severe HIE.
Yes.
So how to differentiate severe HIE from other disease? So we always depend on the history again. So if we give the history of perinatal insult, hypoxia, or baby is not doing well and some episode of seizure, then we go with the HIE. Otherwise, we'll think of mitochondrial disease or some other metabolic disease. But it is too early to say. Again, here the age is not mentioned. Maybe 5-day-old, right? So 5-day-old. So with this, one more thing I have to say is infarcts. So infarcts also very, very important. It's not so easy to tell whether infarct is there underlying or not, but HIE has a pattern of involvement. So whether it is periventricular or deep gray white matter or perirolandic, it all depends on the timing of MRI. So usually we advise to do on 5th to 7th day, not before that. Because if you do before that, the brain, whatever the intensity signals shows, it will be what is a false or artifacts. And a diffusion weighted is very, very helpful in this condition. Diffusion weighted will show the brightness, which will directly reflect the date of injury. So usually it will be on the 2nd day or 1st day the injury happens. It will be there for a week, 7 days. So we can see the findings up to 2nd week of life.
Yes. Thank you very much. So this is a second question to Dr. Suja. Dr. Suja is there? Dr. Suja?
Yes, I'm here.
Yeah. So this question is for you. This is the day 1 of life. Baby came with meconium stained lacquer. Baby was having distress at birth. This received delivery room CPAP. He's on HFNC support. Now an X-ray comes like this. So what is your take on this X-ray?
Okay, let's forget the X-ray. Let's look at the forget the history. Let's look at the X-ray alone. What strikes us, like if you go through the ABCs also, the airway looks okay, the bony cage looks okay. But when you come to the pulmonary shadows, the thing that is striking is the asymmetry. On one side, we have a snowstorm appearance with heterogeneous opacities, whereas on the other side, we have an hyperlucent. On the left side, we are having an hyperlucent lung area. And we are able to see that the costodiaphragmic angles are also very sharp and very pointed. And we are able to track the to an extent the lower border of the heart also. And what is more important is we are seeing a border within a border. So below the ribcage, we are able to see another border, which should be the lung border. So this is a classical X-ray of an air leak, which is most probably a left-sided pneumothorax.
Dhananjay, your take on this X-ray?
So here, if you see, as Madam said, there is asymmetry in lung opacities. So if I see on the right side, lower lobe, it is more confusing. It is more asymmetric in itself and involving predominantly in the mid and lower zone.
Yeah.
And if you have to rule out bronchopulmonary dysplasia also in this kind, but only thing is it's unilateral.
So here it was this one, we suspected some air leak, but there was no air leak by cold light and serial course of the baby. But there was something like a partial obstruction of airway because of meconium can create gas trapping, this one. So this baby actually was about to have air leak. In this case, if you use CPAP support, then more like to have air leak. HFNC is better. So in X-ray is very useful for ruling out gas trapping, because once you have gas trapping and we use CPAP, then there's no chance of air leak happens, this one. So we'll go to Dr. Vishwanath Kamoji. This is last X-ray. I think this is over, no? Time running out, organizers. So with this X-ray, we'll finish off. This is an X-ray of 1 month-old baby. Actually, this baby was admitted in different hospital, and repeated extubation failures were there. The baby came with this repeated extubation failure, weaning failure, and 1 month-old baby, and with pneumonia and sepsis. And this X-ray comes like this. Trouble with this type of X-ray is there's this pistoning of ET. ET picks on up and down. So I would like to know, how will you prevent this complication? And once it has happened, this one, how will you treat this one?
Okay, commenting on X-ray itself, we've gone through ABCD and looking at the tube. It seems to be in the right main bronchus, practically in the right main bronchus, which is causing a collapse of the right side because you can see the heart pulled onto that side. That's number one. And it is not as dense to call it as a consolidation as such. There's a collapse with mediastinal pull on the other side. This is a month-old baby. So it is going on for a little while. So there are some radiolucent black spots on the right side, which I don't know whether we call it as infection within those areas. Now, how do we prevent this from happening is to have a acronym called DOPE, displaced tube, obstructed tube, pneumothorax, and extubated tube. I would suspect this baby is on ventilator or somebody has pushed in the tube too far at the time of intubation, but unlikely that you will do that immediately. You'll get this kind of a picture immediately after intubation. So this seems to be going on for some time. And the tube has migrated down is what I would suspect from the X-ray. Now, to prevent it, we must be very certain about where the tube lies, the air entry to be checked on both the sides, chest movements to be on both the sides, and the nursing staff has to keep a close watch on what site or what size the tube has been fixed. If it is moving, then we have to retape that again. So that is what I would think this baby will need, how to prevent it from going forward.
Thank you for
Dhananjay, sir. Yeah, okay.
Dhananjay, this one, here what happens once you get this called commonly, this sort of situation, right upper zone, this one. So actually physiotherapist comes in an ICU and they give physiotherapy. So based on this X-ray type picture, because the right upper zone is commonly affected, apical, anterior, posterior, there are 3 segments. So how will you focus on certain segments based on this X-ray?
In X-ray, we just see the zones first.
Yeah.
Then after that, we see the pattern of involvement. We have to see the fissure. So if it is close to the fissure, then if, for example, if it is upper lobe, if it is close to the fissure, usually it will be anterior segment. So in the middle lobe, again, if it is close to the fissure, and in the posterior, it will be on the medial side.
Okay.
And in lower, again, it will be medial and upper and close to the fissure.
Right.
In this case, what I feel is there is multiple extubation failure.
Yes.
So we have to rule out underlying lung pathology as well.
Yes.
So, and CCAM or any infected bulle or anything with underlying empyema. Even in this case, ultrasound is very, very helpful.
Yes.
It will clearly make out whether it's a consolidation or any lesion is there, any effusion, syndromic effusion is there, or empyema is there.
Yeah.
So one more important point I would like to just add
as
and
far as
quickly,
this one
sir.
concerns lateral X-ray, there was a time when lateral X-ray was actually promoted for this one, but lateral X-ray also was not very useful. And ultrasound can give a location of the collapse, nature of the collapse. Serially, we can monitor also. Vamsi wants to talk something?
An important point about the prevention aspect. We also have to make sure we have a proper ventilator care bundles of which we train our sisters. We appropriately change the positions. We take care of proper humidification. We do timely suctions and infection control. All these things when we do in a structured fashion, I think these things can be significantly decreased, sir, for prevention part.
Thank you. Thank you. So with this, we'll finish off for this one, this sort of panel discussion. I'm quite happy and grateful to all the panelists for this discussion, especially Dr. Dhananjay. He gave a lot of insights from radiology angle of point of view. Thank you. Thank you very much.
Thank you, sir. Just a small token of appreciation. I request the moderator to kindly hand over the flowers. As we move on to the last panel discussion for the conference, checklists in NICU, I request Dr. Sunil to kindly take over the stage.
Hello. Okay. So we are coming to the end of this academic extravaganza, we can say. Myself, Dr. Sunil, I'm a moderator for this panel. And actually speaking, see, this concept of checklist in ICU is not very old. It's something new, more of theoretical, I can say till now. Practically, very few are implementing it. But this is something which is practiced daily in and out in a corporate industry, aviation industry, or in a business class. So this is something which they are doing for a long time. If you see the aviation industry, why there are, like, suppose Indigo flight is operating, you must listen, like 1,500 flights per day in India, but hardly any accident or hardly any mishaps happening. Rarely. This is all because of something called as checklists or checkpoints, which they are implementing in their daily routine. In NICU also, if you see most of the errors or morbidity or mortality is happening, there are reasons, there are errors, human factors, environmental factors, some uncontrolled factors also are there, which can be tackled with checklist. So to move forward for this topic, we have very eminent learned panels. 3 are physically present here and 2 are virtual. A short introduction, I'll point this. Okay. Next slide. Okay. So we have Dr. Amit, Dr. Sarvanan, Dr. Chandrakala, Dr. Rajat, and Dr. Nilesh. Dr. Amit is here. Dr. Amit is from Maharashtra. He is a national EB member. He's a director of WIMS, Nagpur, a very academically oriented person. Then we have Dr. Nilesh, sir, very tech-savvy person. If you just Google on him on YouTube, Dr. Nilesh Darvadikar, and you will see like how much he has contributed to neonatal cares. And the last, not the least, but Chandrakala ma'am, she's everybody knows that she's from Bangalore. Maybe the only person from the Bangalore to be here physically. So she is a professor and HOD of St. John's Medical College. And like that itself is more than even for introducer. Dr. Rajat and Dr. Sarvanan, they will join virtually. So without wasting much time, let's move forward. The first question, like this checklist part, like if you see, this is a part of quality improvement. The quality improvement is, as I said earlier, it's still in more of like developing stage. What I feel, it should become a part and parcel of daily routine and not something like we have workshops, VMEs on, then like we do some research on quality improvement. No, it should not happen. So checklist is one of the important part of quality improvement. And see, this is how it goes on. So to start with, I'll ask Amit sir, like, what do you think, like this concept of quality improvement in the NICU?
Well, quality improvement, as it is a revolutionary topic now. Everyone is talking about quality because we have come out of that era where only we were concentrating on the survival of the baby. Now it's the intact survival and the quality of life we know which we focus. See, sepsis, asphyxia, prematurity, all these common causes of neonatal mortality are mostly preventable. And with a proper QI initiative, we can improve the neonatal care. And asking someone the concept of quality is just simply asking like, कि आपके toothpaste में नमक है क्या? So it's like, you may be working in a small setting, you may be working at a periphery, you may be working at level 3 NICU, maybe level 4, level 7 NICU as well. But yeah, the answer is yes, quality is very much important. Quality is the answer to everything.
Okay, so the thing is like, it's a broad term, quality improvement. It can be implemented, as I said, as Amit sir said, everywhere, like all the aspects of life, from the safety, from the like procedures, from the outcomes, from the follow-up, everything can be checked or improved quality and quantity wise, both by just implementing call implement projects. So moving ahead, next question is, I'll ask Madam is, Saravanan sir is there, I think is online here virtually. So what are the different indicators of quality care in the NICU? Indicators of the quality care in the NICU. Like if you want to improve something, like what are these indicators of quality improvement in the NICU?
Yeah, hope I'm audible. Am I audible?
Yes.
Yes. Hi. Good morning to one and all. Thanks for the opportunity. Well, this the indicators, what we call it a dashboard indicators. Okay. So what it would help us is, one is to compare between units is one, and next is within our own unit. It will give us an idea of what all the practices we are doing and how good we are following them. So these are the two concepts why we have these dashboard indicators that should be in the board in each NISU. Now, what are the ones which we may compare within a unit or over a period of time? As we all know, these are a part of all the NABH as well as any NICU mentoring visit which we take. They are the mortality rates, the morbidity rates, and the nurse patient ratio, along with the ventilator associated pneumonia, those ratios, CLABSI rates, and the most important I would say is about the thrombophlebitis, which is very common. Sometimes the rarer ones we stress a lot, whereas the most common like a thrombophlebitis rates are sometimes missed out. Now, this is for a comparison with between units and to know about each. But when it comes to our own unit protocols, what are the things which we need to be very, very strict is having a dashboard indicator about the initiation of breastfeeding within the first 30 minutes to 1 hour. Now, that ratio would give us a clue about how is the breastfeeding rate. Next is, are we following delayed cord clamping? Now, what is the rate about that? Then comes the KMC rate and about the antibiotic usage or the antibiotic stewardship indicators. Now, a rough indication about all this should be analyzed on day-to-day basis and weekly basis within the unit, and then we have to compare it over a period of time also. Hope that answers the question.
So as you said, like these are the very few representative you can say, like simple skin care also is a quality indicator. Readmission is a quality indicator. PD opening is there. ROP is there. So like you take any like outcome, newborn outcome, maybe it's morbidity, mortality, or some sort of like skin damage is there. Simple sore, bed sores are there. These is the quality indicators. Temperature. So like any newborn outcome where you're treating a newborn, that becomes a quality indicator if you take it and in that sense. So as you rightly said, it should be done daily basis, and it is something which is a benchmarking your efforts, or how you're doing good, doing bad, doing fair, and it can be used to compare, as you rightly pointed out, Dr. Saravanan, it can be used to compare also different units. So moving ahead, next question is to Chandrakala Madam. Like different methods or approaches which can be used to implement or which can be implemented to improve quality in the NICU.
Yeah, go to the next slide, please. Thank you for your question. There are many proven QI initiatives which can be used in NICU to improve the outcome of the babies. One of that will be the maintaining the hand hygiene, maintenance and optimization of the central line, improving mother-infant interaction, and some of it already has been discussed. These are the proven evidence-based improvement. So there are different, next slide please. There are different quality improvement methods which we can do in NICU to improve our outcomes. That is clinical audits, plan, do, study, act, and model of improvement, and so on. So move on to the next slide, please. What are these clinical audits? These clinical audits are the one, this measure the effectiveness of the healthcare
And this outcome of this, which we compare against the standard, and we will move up our standard to improve the quality of care. How do we do that? We do that with the previous slide, please. We do that with a plan, do, and study act PDSA cycles. Another important one is that model for improvement. This is what I mentioned already. What are we trying to accomplish? How will we know that the change is an improvement? And what changes can we make it that will result in improvement? So this also we can do from PDSA cycle. Next slide, please. And also performing benchmarking is the same. Let us look at our performance indicators and move that benchmarking and to improve and create an awareness to improve the standards. And there are different methods to improve the outcome. Process mapping is one. Next slide, please. And also the statistical process control ones, and the root cause analysis, which all of us have done, and the fishbone analysis to know what is the deficiency, how we can improve our care. So next, there are other two more methods to which we can implement. That is communication tools as well. This is one of the most important one when we hand over, when we take over, and we tell about the patient status to the seniors. This is one of the tool SBAR, that is situation, background, assessment, and recommendation. So this is one of the communication tool. The next one is the decision trees. So these are the different methods which we can adopt to improve the care of the babies and the outcome of the babies.
Right. So initially it looks like some new terms like SBAR is there, SMART is there, Pareto is there, PDSA is there. These are something terms like once you start doing the projects, quality improvement projects, or you want to improve something, slowly you will realize that these are actually very simple things, and we'll see on the next few slides also how simple they are. Just like we have to start practicing. Now, moving ahead, I'll ask Dr. Rajat, who joined virtually. What are these examples of quality improvement in the NICU? Dr. Rajat.
Examples of quality care improvement in the NICU.
Yes, sir. Go ahead.
Sorry, I was a bit thrown off. I joined a little bit late. Apologies for that. See, quality improvement starts with identifying whether you have a problem. Okay, so the first step to that is always assume that you do. Okay, so if you go about saying that we are providing the best that we can, and there is no scope for improvement, then that is not a place to start. So we need to look at what outcomes we need to achieve. I think, as Dr. Chandrakala was mentioning, have audits to identify QI. For example, we can improve, suppose we have admission temperatures for all preterm babies coming low, less than 35.5, let us say. And we know that mortality in extreme preterm babies is 4-fold higher if a temperature is less. Then we need to look at improving that, certainly. And then if we go about it in a very systematic way, we will be able to identify the whole process. You can do a process mapping and then adhere to certain protocols and policies. For example, if you have a checklist for thermoregulation, and then the whole team performs according to the checklist, then you can see that you would actually improve. And then the question of sustaining it comes. So crucial ones would be like, how do I improve that? How do I improve provision of mothers only milk to babies who are very preterm or who are surgical neonates and cannot latch on to the mother's breast?
As you rightly said, like there are so many things we can take. Any problem we take it becomes a quality improvement indicators. Anything like, as ma'am said, like feeding, breastfeeding, something like KMC is there, something like antibiotic, babies without antibiotics, something like class Bs, anything like you take, it becomes a quality improvement like indicators. So just find out what is the problem. Like if your KMC rate is, kangaroo mother care rate is less, like as either like fishbone, or you can do, or like you can analyze other way also, like bottleneck analysis you can do, and find out what are the reasons, and that can help you. Now the same thing, like Dr. Nilesh, can you just explain what we discussed about this PDSA and Pareto principle?
PDSA means plan, do, then study and act. So it's something, if you identify some problem, suppose in my unit I find that there is an increase in a sepsis rate because of central line. So this is a problem. I have to identify how much percentage it is. Then what is the standard? Then what are the causes for increase in the line associated sepsis, and then how can I prevent it? So this all thing will become in planning actions, and accordingly I will
And
plan something.
you will involve all the stakeholders also in that. Like something, the problem is there, you involve everybody, including staff, maushis, nursings, everybody,
Yes.
like all the stakeholders, so that you can not miss anything.
Yes, so that will be a planning part. Then whatever solution you find on that, you just do it, and you again evaluate. You study it.
Yeah,
You
you can
study
do
it
interim
whether it is
analysis in
causing any
between also.
improvement, whether it is helping or not.
Right.
If it is not helping, then you have to see why why it is not working, and accordingly you have to change the plan or you have to adapt something.
Yes, you can in between, you can add some questions, you can add
Yes.
and like something. And like same, like add on that, like there's something called Pareto principles. Once you do something like analysis, you act and evaluate it, you will find that like there are 3 or 4 reasons why your sepsis rate is too high. So this is called as Pareto principle or Pareto analysis, where you will focus after this like only 3-4 things, which will at least reduce your incidence of infections by almost 80%, you can say. So this is like after analysis, Pareto principle or Pareto analysis. Once you know the problem, you know the reasons, you will find out which are the common reasons for this problem, which are majorly or contributing for the problems. Okay. So this is how it goes down. Now, next question goes to how to identify problem in ICU and design the checklist. Amit sir.
Well, first of all, the most important thing in identifying problem is to do audits, and you should have your quality indicators in place. Audit can be internal audit as well as external audit in the form of assessment, like NNF accreditation activity we conduct. And then there are quality indicators, mortality, your sepsis rate, and there are certain methods, like in which we can design these things, like with fishbone diagram, root cause analysis. So in that way we can identify a problem, we can formulate a team and write a name statement. Then we need to keep on analyzing and measuring the quality of care, and it should be we should start with small goals. We should not at a time try to correct the whole house in a single go.
Something
And
which is
then
practical,
we should
doable.
develop and test the changes.
Right. So take one simple problem which is practical, doable, analyzable, measurable, and then you can succeed. You don't take something which is hi-fi thing, very something which is difficult, then moral will go down. You start with the small things, and definitely it will click. Okay. So the next question is to Dr. Sarvanan, like delivery room checklist and usefulness. What I'm asking you, Dr. Sarvanan, is apart from NRP, apart from neonatal resuscitation, how should be the delivery room checklist and what all things it should include? Dr.
Yeah.
Sarvanan.
Yes. Yeah. Dr. Sunil, thank you. So when it comes to the delivery room, being prepared is half the battle one. I think all of us know about it. In fact, what all things we have to be prepared is, first is, in all the delivery room, we should have a checklist of the antepartum factors and the intrapartum factors. In fact, your registrars can go through it, because there are many times some of the questions are missed out. So going through that entire checklist, ticking it, and whichever is there, you should ask the questions to the obstetric registrar, whoever is there. So running through the checklist, that is the risk factor checklist, the first job, that is the preparation before the delivery. So antepartum and the intrapartum factors. Next comes is the knowledge about your environment. That is, you choose, okay, which is the spot the baby is going to be delivered. Is it drought free? What is the temperature required? So the temperature and knowing the environment is very important. Third is the personnel. That is, you have to anticipate and plan, and who's the person who's going to take the leadership role, because having a leader for the NRP is very important. So who's going to be the person who's going to be the lead, and effective communication. That's very, very, very important. So all this has to be done. And one more important thing, which we, after going through a lot of experience, is the knowing the environment around. Okay, is the mom there, then who are the attenders along, so that maintaining the professional behavior during the entire so that you communicate effectively and use your choice of words effectively. Now all this has to be planned before the delivery. Okay, you got the nurse there and your team there. Okay, this is the person who's going to do, this is the person who's going to communicate. So that's preparation is very important. Okay, so that's about the preparation before the delivery room, and the checklist which you can make and have it also.
Right. So you can have something like that: manpower, environmental, antenatal history, transports if required, or if required bed is required, arranging the bed. So everything is checked. Your tick mark. Your if you want help, extra help, that is also arranged. you know your environment, then only you can work in that environment. If you suddenly ask somebody to go to the delivery room and attend the delivery, which is a new place, it's really difficult. But if you checklist in the place, if you display on the board, if anyway you are going to attend in new place also, it happens like you are getting some call from the something like the new delivery area. Then there will not be a problem if you have checklist and everything is in place. So that's very important to avoid the unnecessary like communication gaps or the treatment gaps. Okay, so moving ahead, now next is, this is most important, crucial, neonatal resuscitation checklist. So I'll ask madam just to like in details about the NRP checklist, because this is, without this you can't work in NICU, not only delivery room, even NICU also.
Thank you for this question. All of us know that the importance of first and golden minute. So it is always important to ensure that all the things required for neonatal resuscitation are in place before attending delivery. So if in case, if you don't do it, do the checklist and keep the things ready, in case if I want to give positive pressure ventilation, if the bag is not inflating and it is not okay to run for the bag to get the bag and then start resuscitating, that's the importance of first golden minute. So this is a sort of checklist, which is that we need to inventories kind that we need to keep in the delivery room, and it's very important to have an organized checklist of all the things which is required in the delivery room. Starting from the warmth, clearing the airway, auscultation, ventilation, oxygenation, intubation, medication, all the things needs to be checked and should be there before resuscitation. So that is very important.
One thing I'll stress is have at least 2 sets of batteries for the laryngoscope and 2 sets of blades also. And I make sure that your laryngoscope bulb is working. This is most common problem. Like sisters don't know where it is kept. One thing, they will run when you ask. Other thing is, if you get it, the bag will not work. Or if you get it, laryngoscope will not work. Batteries either placed strongly or batteries are at least outdated. They're like, this is not working. So this is a very common thing. At the minimum thing you should have. Yes, checklist is definitely going to help you, but minimum thing you should have that is. So the next question I'll ask to Dr. Rajat is like how to develop and test neonatal resuscitation skills using structured checklist.
I think NRP itself is such a task-oriented sequence of events. So this lends itself into very much into being tested, audited, improved upon with the use of a checklist, because it is protocol driven and steps are sequential. It involves equipment and personnel, and it involves practical skills. Next slide, please. So as we have told, you can have a checklist pertaining to preparation, which Dr. Saravanan was saying. Next slide. You could have, as Dr. Chandrakala was mentioning, the first minute. So you could divide these into, and then first minute is the golden minute, and whether we have got the baby going at that point. Next thing, ongoing resuscitation. So I have listed quite a few. So when we train our nurses and doctors to perform NRP, we can make them aware of this checklist, and when we make them perform either in real life or in simulated scenarios, we can have it checklist. For example, ongoing resuscitation, has he identified the need for chest compression? Has he prepared for use of drugs, prepared for UVC? So all these things can be checked. Next slide, please. So there is a lot of publication into whether developing and testing of performance checklist aids in codes, in code blues and this thing. So they have implemented this, and they have actually seen, see, NRP is a fantastic training, but it happens over a few days and you learn. And then when you actually go and implement those skills, nobody is then observing you. So I think it is very, very important that we do train and retrain ourselves and audit ourselves. So this is a useful reference you can look up. I think this has come out of Canada, where they had this checklist based approach to train and sustain NRP skills. So this can be something that could be implemented. Thank you.
So like it's like a bird's eye view. Somebody is monitoring, somebody is assessing, the skills are done properly, communication was correct, skills were permitted, steps were correct, and the time given was correct, and the sequence was correct, and at the end outcome was also correct. That things will be monitored by somebody which is actually like a bird eye view, third person, and there will be a team leader. Their communication should be good. So everything will be checked and their skills at the end. Everything will be checked in the assessment of NRP checklist. There will be a structure checklist. Is already there. It is again one of the quality improvement. This can be done in a like skill labs are there, like dummies are there, a demo like my mannequins are there. So there can be done, and usually it is practiced most of the medical colleges. So the next question is to Dr. Nilesh. Can we use something like or a team sport model to improve the briefing and debriefing in the neonatal resuscitation itself? Like this thing, continuing with that.
Yes, as we all know that it's a team effort. It's not a one man's job to do a neonatal resuscitation or rather running an NICU. So this sports model shows how to communicate with the others, what are the principles. So this is basically taken from a senior woman England lacrosse team. It's a kind of sports where they used to use all this model, like equipment preparation, self preparation, role identification, team alteration into a neonatal resuscitation. Next slide, please. So for briefing and for debriefing will be done after the scenario is over. Suppose we have done one resuscitation. After that, there will be leader summary will be there, success and failure will be discussed, team involvement will be there, and accordingly they have collected some around 13 points on which we can train the staff and we can train the team, and accordingly they have analyzed that. With that, with this, there is a initiation of communication is early, assignment of role is proper, adherence to the established protocol will be there, and flagging of potential problems, standardizing a process, everything become easy. So this is how this sport team model is utilized in the neonatal resuscitation team.
Okay, so like all of us know cricket, all of us know Formula One. We know that how they, if your communication or briefing or team communication is good, the results usually they are better. You must have observed, like if they have interharmony, they communicate with each other, their plan is there, they discuss with each other. Like even in the football team also, like football matches, you must have seen that those who are actually practicing this team briefing and debriefing model, definitely there is a lot of like they have while playing also the results are much better. So coming to the moving forward, next question to Amit sir, like NICU counseling, can we better check? Must everybody should practice something
Counseling is the the most important thing, and we should have a strategy to do the counseling, because NICU is a very frightening setting for parents. They are anxious, there is separation anxiety, and the parents, they depend heavily on the NICU staff for the information and the support. Well, the parents, no one is ready for this unannounced emergency. They learn about the NICU settings over time, like how it is different, and they get accustomed to the language and the clinical procedures later on. And in the time of crisis, they require daily updates and routine updates, and then they should be encouraged to ask questions. And the parents, they should respect and have follow the whatever you are saying. So first of all, documentation and recording of the counseling is foremost important. We should have video counseling or the proper individual hospital counseling form with proper date, time, signature, the person who is doing the counseling. As far as possible, we should maintain the same person is talking to them, and all the team members, they should be on the same page. The counseling should be in simple language, innovative. It should consist of the disease nature, the long-term prognosis, the short-term prognosis, the risk factors, the duration of the treatment, and the point which is the doctors, they are not good at discussing the financial aspect of the treatment, and this should also be the column. And ultimately, the parents' decision from the time to time should be mentioned. So I think these are the couple of things they should be there in the NICU checklist of counseling.
Yes, this is something, if you have, you will not miss the thing. You will avoid a lot of other complication. If something goes wrong, if this was not told to us, we were not aware of this. If something like outcome suddenly goes bad also. Like if it is documented, everything signed by that doctor and the even the attender or the relative of the patients, must, this is something which can't miss it. Like it's not only for like improving the quality, but avoiding the medical legal issues also. The checklist for counseling, not only for NRP or NICU admissions, for most all the procedures, the counseling checklist should be done, and it should be have dedicated time. Dedicated time should be given. And as you said, Amit said rightly pointed out, time, date is must. and in a good legitimate manner, your handwriting should be good in a vernacular language or language which you're using should be there. Better to have audio video counseling, if possible. If possible, that will actually save you a lot. So that is must, and the clarity, of course, should be good. So moving forward, very important aspects of the NICU care, which as NRP or admissions, we can't miss, Dr. Sarwan, is like hypothermia, prevention, and checking for hypothermia in the newborn. So how can you implement checklist to prevention of hypothermia? Yes.
So the checklist, yeah, thank you. So the checklist here would include how do we prepare prior, then during the delivery, and then during the transport. In fact, the Achilles heel is always at the time of transport. Okay. And another important thing is ensuring the delivery room temperature, the operation theater or the delivery room temperature is maintained. Now here, the most important is getting the obstetric colleagues also in the same page, so that as a team, we have to ensure that the delivery room temperature is maintained. So the preparation before the baby is born plays a huge role. Then the next is many times we end up having trouble during transport. Now, there is one amazing, nice article which is done by British Association of Perinatal Medicine, which was published in AAP. Now, this had about 4 temperatures. That is the first temperature when the baby is born, then the temperature just prior to transfer, and then at the time the baby is in the NICU, and then 1 hour later. So analyzing this data, they found that many times it's during the transport, it's when the problem happens. Okay. So having the incubator ready, so that checklist of, okay, is the equipment working? Is my incubator ready? Is the current on? Is it on battery backup? So these kind of checklist is very important prior to entry into the NICU. Okay. So I would stress on that checklist, so that the transport is when the most common causes of hypothermia happens. Okay. Yeah. Next slide, please.
Starting from the NICU, like when the baby comes out of the womb till the baby is at home. I'm not saying like while going home, at the home also. Everything, at every point of time, you should have checklist so that the baby is not going to the hypothermia. So like if you design a good checklist for hypothermia management, it might go like you may have to cover like 50 or more than that points. But this is something which you should not like miss on. Hypothermia is most common cause of morbidity and mortality in NICU. It's quite proven, evidence-based. Even admissions, if you see, like almost maybe 70% babies are hypothermic by definitions also. Something you want to add, madam, something? No. Okay. So coming to the next question now, like how to standardize this ensure therapy. Now, when the baby is delivered, NRP is done, baby is admitted, counseling is done, you prevented hypothermia. Now you found that the baby is having RDI, distress require ensure surfactant therapy. Now, how to standardize surfactant therapy and roll up checklist in standardizing surfactant therapy?
Yeah. This ensure is a technique where this is used in those babies who are requiring FiO2 requirement more than 30%, and they are on CPAP. And in case if there is those babies, the FiO2 requirement goes more than 30%, or in some books mentioned more than 40%, then we'll have to give surfactant. Surfactant is an important part of RDS management. So ensure is a technique where we intubate the baby for the sake of giving surfactant and rapidly extubate the baby after giving surfactant by looking at the baby. So there are many, now there are so many other ways of giving surfactant, that is least invasive and minimally invasive, all are there. So having a checklist for intubation, that ensure, is going to ensure that we are going to give a correct way. So we need to ensure that the respiratory assessment of the baby is done, the respiratory distress score of the baby, and chest assessment, distress score, vitals, hemodynamic status, and then patient status, how is the baby, RDS score, how sick is, shock status, chest X-ray, all that we need to have as a part of checklist. And then it is important to have the equipments to keep ready for the ensure technique. And the intervention before surfactant therapy is ensure that pre-oxygenate the baby and do the suctioning beforehand, so that for next 4 hours, we are not going to do any suctioning after giving surfactant, and ensure the lung recruitment is done and record the vitals as you are giving surfactant.
Yes.
And and also we need to they be there in the checklist that what are the things we should not do and what are the things you should monitor after giving surfactant. So all this should be, it is important to have it in the checklist.
So starting from the indication itself till the complications, if you have checklist, will not miss, the procedure will be uneventful. most of the time, surfactant administrations, if your checklist, the procedure will be like uniform. There are different ways. The way people give surfactant is different. Some people will change the position. Some will give 1 aliquot, some will give 2 aliquots or 3 aliquots. But if you have checklist, surfactant admission will become a standard, like protocolized care. If you see like in different NICU, the way they are giving surfactant is also different. So if you have a checklist or a standard way to do it, definitely is going to help it. Coming to the next, like if you're doing any procedure like surfactant administration, Dr. Rajat, can this bedside pre-procedure safety checklist will help it, and how it is going to help the baby when you are having this bedside pre-procedure safety checklist for any process?
Yeah, so basically bedside NICU means procedures, and procedures means both risk and benefits. So, and procedures again lend themselves into standardized practice. So there should be less errors. So checklist, for that, you can have a general checklist where you identify the patient and you make sure that a consent has been taken, any pre-medication or comforting for analgesia has been done. You know the exact working weight, and you know how which tube to use and other things. Then you can have a small thing about endotracheal intubation, which is a specific one. You know, what is the length of the oral tube, size of the tube, where do you want the tube to be fixed at. UAC and UVC again decide length. And then, for example, LP, you can have somebody has actually checked that the baby is stable, and then blood tests are checked for any coagulopathy and other things. And then for example, for insertion of long line, this has to be used in conjunction with CLABSI kind of checklist. Aseptic technique, and somebody is observing and fixation of the line. And it's also very important to mention the lot number or anything like that which you have used, so that if there is a problem, you can actually go back and look at if it is a device issue rather than anything else. So I think a bedside procedural safety checklist will ensure that whatever procedure you're carrying out, you're doing it in the most safest possible way. Thank you.
Okay, so moving forward, we are a lot of, like any neonatologist who asks, they don't want to intubate or they don't want ventilation for babies, that too premature babies. So like surfactant, it is non-invasive now. Like respiratory care also, we want to be non-invasive. So how can we have some checklist or preventive measures which can be designed in the form of checklist, which will help us to, or these bundles to reduce exposure to mechanical ventilation? I'll asking, like Nilesh sir, anything like we can be done in preterm baby, especially in preterm baby.
So ventilation.
Avoid ventilation in
Avoid
preterm
ventilation.
baby.
So this is quality improvement bundle, which consists of differing cord clamping. It doesn't reduce the intubation rate or ventilation rate, but it does reduce the mortality in the premature infants. Then early use of nasal bubble CPAP. If there is a start of distress right in the delivery room, you should apply the CPAP right in the delivery room. Then, as Madam rightly told, minimally invasive surfactant therapy, this actually avoid the barotrauma and volutrauma caused by bagging. So if we try to implement these three strategy, then we can definitely reduce the mechanical ventilation. These are the three mains. Many people added two more, including antenatal steroids, and there are other difference of non-invasive method to avoid invasive ventilation. But these three are widely investigated, and they found that it reduces the intubation rate in the first 72 hours, and it also reduces the
this will
percentage of
reduce the,
babies going
like,
home on
intubation
oxygen.
rate almost by 60-70%. Okay, so coming to the next question, like sometime we might not be able to avoid ventilation, but when the baby is, definitely some babies are very severe RDS, pneumonia is there, extreme premature is there, or apnea prematurity is there, where you can't help with non-invasive ventilation might not work. So in that case, when the baby is intubated, now this baby suppose gets ET like intubations. Now, when you're going further round, what all things in a checklist should be checked daily to avoid like these machines and baby asynchrony or working environment is optimum when the baby is on ventilation?
Well, first of all, like, when you're making your NIC round, before to make sure, like, the ventilation is working properly, first of all, have a overall holistic look over the baby. First of all, don't directly jump over the machine if the machine is having alarms. Look at the clinical scenario of the baby, and then if the baby is fine, and after your clinical examination, then you go for your ventilator machine setup checklist. That is, first of all, the machine is calibrated properly, the flow is proper, the alarms are working properly, then the pressure check, volume check, the filters are proper. When you had changed the water or the filter, the humidifier, then the ventilation monitor, you can go back in the history of the ventilator records. Then the paperwork, if it is proper, the self test, it is passed, the venti ID and the therapist initials. Then we need to see at like, the last the tubings were placed and when the tubings were changed. Is there any nasal injury? What is the size of the ET tube where it is fixed? So it should start from the baby, then to the machine, and then again it should come back to the baby. So in that way you can remember
So
easily.
starting from the, and if you have this in the form of checklist, like gas is appropriate, the pressure is appropriate, the ventilation is appropriate, the mixing is appropriate, there is no humidity or there is no oil or water dribbling in the ventilator like posterior ends also, ventilator is functioning well, graphics are normal, baby ends, inspiratory limb condensations, expiratory limb condensation, humidification, temperature, ET positions, like stickings are there, interface properly, injury is there, chest rise, air entry, all these things, if it is included in the checklist till the blood gas and X-ray, including nutrition also when there is a ways on ventilator. So humidification chamber, humidification water, temperature, everything. If you washed your temperature sensor is clean properly or not. So if you have checklist something like that, the chances that you'll have a VAP or infections or pneumonia or failure or dope, something like that, that usually will not happen. And as I said at the initial beginning itself, the checklist is going to prevent the morbidity and mortality to a minimal like percentage or minimal level. So that's the ultimate motive of having checklists in the baby. Now you ventilated the baby as you're done the check, everything is done, but still like specifically to prevent the pneumonia, now when the baby is ventilated, how and what all things you will check or put in the checklist so that baby will not develop VAP or ventilator associated pneumonia and ICU. So this question goes to question number anybody can ask.
Yeah, Dr. Saravanan here. Yeah, I'm there. Yeah, next slide. So, I mean, as we all, the definition for VAP, we go as per CDC guidelines, which says that beyond 48 hours, if you have features of clinical features as well as radiologic features, you call it as a VAP. Well, the first way to prevent this is obviously avoid ventilation as much as possible, or less than 48 hours, less than 24 hours. So that ensures that your VAP is less. Okay, next slide, please.
Okay.
Yeah. So what all the things we'll have to look out at? Next slide. Yeah. So when we are considering a VAP bundle, now this is a bundle which has to be followed by the nurses, but still the doctors as well as registrar's responsibility also is to ensure that each of the checklist is being analyzed every 6 to 8 hours. So the first one which we always look out is the readiness for extubation. So each time we do a rounds, okay, this baby, is the tube supposed to be there? Is it time for the baby to come out? So as early as possible we come out. Next slide, please. So assessing the readiness for extubation is the first thing. Then this is a small study which is done in America, if I'm right. So here they analyze what all the things which helps. And among this, if you see, the last one is the one which is the best, but still, first, I would like to hand hygiene. As we all know, in NICU, hand hygiene is the first thing we always stressed on. A few controversial things which have not been put as a slide here is one of the about the suctioning. As we all know, we don't do routine suctioning unless the baby is needed. Next is the need for inline versus open suctioning. The evidence says that both have the equal chances of VAP, so there's no added advantage of using an inline suction. Now, another thing which, in fact, many of the anesthetists who asked me this question is, okay, sir, why don't you start using a cuff tube in newborns also? In fact, there are 3.5 size cuff tubes also be started coming out, which anesthetists use, though we neonatologists are not comfortable using cuff tube, because in adult as well as in pediatric patients, it is found that the use of a cuffed tube reduces the risk of VAP. But the evidence in newborn is still, and especially when you're going to deal with a preterm newborn, still there is not enough evidence. Okay, so that's about the suctioning. And then obviously second one I told you about the daily readiness to wean the baby out of the ventilator. And third is the presence of any visible soiling in the circuits. So ideally we don't advise to change the circuits regularly unless it's visibly contaminated. Now ensuring that there's no visible condensate in the circuit plays a huge role. Now this is a responsibility of the nurses. And then head end elevation, and then oral care. Among all this, the most significant of part of the bundle which is ensure that VAP reduction happens is the usage of the VAP care. Whereas those which are not useful is obviously the use of H2 blockers. And then probiotic also they say is not much use in ensuring that VAP is reduced. So among this, I would like to stress on the oral care, hand hygiene, and the readiness to wean the baby off the ventilator. So this would be the components of the VAP bundle.
Upon the oral care, like how you are doing in your unit, how is your protocol about oral care to avoid VAP?
Correct. So these two things can be. Now in our unit, what we do is we do a colostrum swabbing, which we ensure that we do it every 4 to 6 hours. In some units, they also use mouth care with candid ointments also, candid mouth paint also. But I think using colostrum has a huge role in ensuring the gut immunity also, and has other benefits also, which is better when we consider oral care.
Yeah, simple milk also can help. Like
Colostrum swabbing, either you can swab it or just using a syringe, a 0.2 ml in each side, you can just gently inject it into the mouth. That plays a huge role in ensuring that the tonsillar lymphoid tissues also plays a role in preventing the VAP incidence.
Frankly speaking, if you don't have checklist, I don't think these things are regularly practiced. If you don't have checklist, I don't think these are regularly practiced. That's the importance of having checklists in the ICU. We know all these things, theory we know, till the time we don't display that on the bedside or at the warmer, somewhere that this is done regularly by staff, most of the time there's not be compliance, or the staff will do it like just whenever they feel or whenever they free, they will do oral care or do something like VAP. Even the simple things, having the distal end of the ET or little lower than the baby side. So that simple thing like bottle trickling to the baby side, baby or lungs, that also can help. So this is something which is preventable, but if you have checklist, this will be done. As I said, everybody knows quality, but if you don't implement it, it's not going to work. Like having knowledge is not enough. And to implement it, you should have something visual things which will be useful more. Okay, thank you. Very nice, Dr. Saravanan. The next question is like, now this baby, like term baby is there, like intubated, like he's already asphyxiated, was asphyxiated, he had developed meconium aspiration. Now you feel that infant is ready for extubation. How the extubation checklist should look like? Chandrakala ma'am.
Next slide, please. It is very important to have a checklist to know whether this baby is ready for extubation. One. So there are so many studies where there is evidence that following the checklist for readiness of extubation is going to improve the success of extubation, or it avoids extubation failure. So it is important that before extubating a baby, it is ensured that it is a term baby who is on minimal parameters with these parameters, and preterm baby with this PIP less than 13, PIP less than 5, these parameters, and ensuring that the blood gases are normal range, and the baby who passes SPT test. SPT test is nothing but the spontaneous breath test. Go to the next slide, please. So, and ensure not only that from the baby's point of view, the equipment which is required for extubation should be kept ready. That is ambu bag, and ensure that the resuscitation trolley is ready and suction apparatus is ready, oxygen is ready. In case if you are extubating the baby to CPAP, that also should be ready with the interface, and also the monitor. So after extubation, we are monitoring the baby for at least 2 to 3 hours to know whether this baby would go back for extubation. And this is the protocol. This is what we use in our NICU. This is the checklist to before extubating the baby. We tick all these to ensure that ABG, this we have discussed now, ABG is normal and the saturation baby is maintaining, SPT test passed, and hemodynamically is stable, and the sedation has been weaned off 12 hours prior, and his minute ventilation is maintaining in the ventilator more than 50%, and his spontaneous respiration tidal volume is good. So we ensure that all these parameters are met. before extubation.
You want to add something like physiotherapy in the checklist? Yes or no?
Yeah. Chest physiotherapy also is, yeah.
What is
So
the role
after
of, like, just
extubation,
asking, like, if you want to include, like, if in a routine as a checklist, or
yeah.
you want in a specific case?
Yeah, this is usually after extubation. So along with the monitoring, we can ensure that we can
So,
add
like,
it. We
if
can
you
add
have
it in
maybe
it.
was prolonged ventilations, like the pre-extubation checklist, you have some medications or physiotherapy also, like, which will help, like,
Yeah, we
like
can
if
add
there's
that.
edema, is there inflammation, is there collapse, is there secretion, that can be helpful.
Right.
Okay. So next question is going to Dr. Rajat. Like, this baby, now we are done ventilation, we are extubated, but we have the same very small baby, which comes to NICU. Now we're moving to the nutritional aspect now. What shall be the nutritional policy to prevent extrauterine growth restriction? How nutrition checklist? Like, just everybody knows, like, UJR, IUJR, or HEH, but is there any checklist which we can have to prevent UJR, like as a ready-made thing, like staff can follow?
Yeah, thank you. So we know that EUGR rates are upwards of 60% in preterm babies in most of the units. And people have been grappling with this issue. And then what most of the published literature suggests, that it really doesn't matter what your feeding policy is, but have a feeding policy if everybody does things consistently. So you need to have checklist as to how do you segregate the babies into high risk and low risk for feed intolerance and NEC and other feed related problems, and low risk. So if you have high risk babies, for example, very preterm babies or babies less than 2 kgs, so you need to think about early initiation of feeds, type of feeds initiated, escalation of feeds, what volumes we reach. And you need to have checklists about what do you consider as feed intolerance. Otherwise, feeds often get stopped and they do not get restarted. So you need to have a checklist of how to restart feeds once you have established there is no diagnosis of NEC or sepsis or other dangerous things. Do you go back to what the volume the baby was receiving? There needs to be checklist about when do you need to use donor EBM, for example, who qualifies for that. You need to have in your checklist points about when do you think about introducing breast milk fortifier, for example. So the units that use breast milk fortifier with a lot of experience have started using it much earlier. So we used to previously wait till the baby is about 150 ml per kilo of mother's milk feeds and then introduce, but there is a certain advantage of starting it a bit earlier also. So whatever we do, we need to have a checklist, and you can then see whether you have done everything and then the baby is not thriving, putting on weight and growing. Thank you.
So moving on to the next important part of NICU is like central line insertion. So this is to Nilesh sir. Maintenance, and I'll say prevention also later on. Like, I'll cover all three questions in that.
Okay, so checklist for central line, it start before putting the central line. So you should be identify the patient, then there should be written consent should be there, and appropriate size catheter is available. Then the consent should be signed by both doctor and the patient's relative. All then transparent dressing, your sterile CVP tray, then pain relieving measures, and you should mention the reason for central line insertion, because if you mention that, the infectious disease sister will come and ask you every day, sir, we have completed antibiotics, should we remove the PICC line? Because the time at which the need of central line is over, you should remove it. Then during putting this catheter, during procedure, hand care should be done. Then
Just enumerate the points which will check, put in the checklist. Just points.
whether the hand hygiene was done or not, whether all the aseptic precautions were followed or not.
Okay.
And then after procedure,
So
you
when
have
you're
to see
putting the lines, hubs are cleaned or no, line is placed properly, TP is checked, dressing is transparent, dressing is checked, redness is not there, at the line redness is not there. The
Yes.
infusion which are adding, like there is like having heparin. Okay, so there's no signs of blood infections in the baby. There's no swelling or edema at the site also. And that the tip points also. So you need to, like, if you soil dressings are there, that you want to change it or no. So that also should be checked. The line should have marking on the days of insertion. And most important thing is you mark when you want to remove it. And there should not be anything like in checklist earliest when the baby is having some like tolerating feed, remove it as possible. Just for the sake of like 7 days or 10 days, don't do that as a protocol. Remove it earliest. Is it point to remove? That also can be done. Okay, so all these points can be included. Now, I'll ask the next question, to Dr. Sarvanan, like what is this class B or central line associated infection and how we'll prevent it?
Yeah, I think I'll keep it short. I'll just get to the bundles. Next slide, please, because due to want of time. And there's a lot of slides here. I won't go into each of this, but as Dr. Nilesh already told about the insertion, but when we are insertion, 2 points which we usually forget is the more difficult it gets, what happens is we drop our guards. So whenever it's a difficult insertion, again, stop there, go for a hand washing, again gown and glove and come back. So that will again start the entire process. So that is one. And always check it with an x-ray and then fix it and then come out. The last is ensure that there's no blood at the end of the procedure. So this is very important. And last, one more thing is when I think the other slides are not there, but what I would say is the most of the infection happens during the not at the point of insertion, but when the nurses are taking care. So there are two people, one person to monitor the when you're giving IV fluids or starting the TPN, and when anything we are going to handle the lines, one person to monitor and one person doing the procedure. That's very important. In fact, I don't know whether this is right. We had a short period of time whenever the lines are being inserted, a video was recorded of the entire procedure, and then we audited it later on. So that, in fact, we felt that people were sticking to the checklist like a T. The same thing we did for the NRP also and hypothermia Welch. But then over time, we also realized there's a lot of ethics to it also. So when we wanted to get a consent, we had trouble in that. I don't know, the moderator can give an idea about the ethics related to taking a video of the procedures also.
If as the indication, if I give options, you have baby who is 700 grammar in the NICU. If I ask as a checklist, like if there's an option, you want to put the option of either umbilical or peripheral central catheter, you want to have UVC or PICC. Do you want to have a point in or one of the point in the checklist?
That would be, sir. I mean, we should have what is the site of insertion would be a part of the protocol, definitely. In the checklist, where are you choosing it? It definitely part of checklist, obviously.
I want to add something.
Yeah. Your question, if I'm not mistaken, is would you prefer UAC, UAC, or it is PICC line? That's what is
PICC line or UAC in ELBWs as a part of checklist.
Yeah. As a part of checklist. So, I mean, what I want to say, mention is
like if you're given options like checklist, like preference in the checklist, UVC or PICC, UVC or PICC.
In the immediate, within 1 week of life, it is very easy to get UVC. I would go for UVC, and then when the baby is stabilized, I go for peripherally inserted or percutaneously inserted central line.
Okay, if your answer is like that, I will add one more point there. Remove the umbilical as early as possible.
Yeah, within 1 week.
Earliest.
UAC or,
I'll say earliest again.
Yeah,
earliest. Remove the umbilical earliest. That should be a point in the checklist for prevent the central line infection. Okay. So this is the checklist for time also here.
Yeah.
Oh, there's no checklist. There's no checklist, I think. They're tired. So their checklist should work at least. Huh? Okay, we'll finish in 5 minutes. Now the very important question. Last question I'll take. Last question, ma'am, like very important. And as you have, like your position is like your HOD of the department, you get the Klebsiella outbreak. So how will your checklist of control, the infection control audit checklist should be there in your unit?
So this already we have discussed now. Dr. Saravanan has already mentioned. All these are the part of, the checklist that we need to ensure that when there is any outbreak of Klebsiella infection, we will see what is the culture sensitivity pattern of that Klebsiella, number one. Number two, all these, whatever the policies, whatever the procedures we have been doing, we need to audit it out. So whether maximum asepsis has been, precautions has been taken during insertion, during maintenance, during removal, and whether they have all the central line card, whether they have reviewed the need for any line, whether they are doing that, are they having the preparation of the medications under laminar flow, whether ANTT being followed, whether the hand hygiene has been followed. Next slide, please. Next slide. So these are all the checklists we need to go through. Skip this. This is the checklist we need to have. So as soon as we identify there's a break, that is infection, Klebsiella outbreak, we need to identify the isolate and look at the culture sensitivity pattern. That is the first step. Cohorting those infants who are infected is the next important step. And next is the surveillance. So auditing and culture, we need to send the swabs of all the dispenser, COGS, NICU equipments, TPN charts, feeding bottle, all that swab we need to send to know the source of infection. Then review the infection control policies, whether they are following or not, and then evaluating the NICU staff complaints. Then restriction of NICU admissions temporarily will help us in sorting out the problem. Then swabs I've already taken. Move on to the next slide. So yeah, we need to have a multidisciplinary meeting with the infection control committee, with the staff of NICU and the doctors of NICU to know the complaints. And of course, we need to see the hand hygiene has been followed, safe disposal of diapers into specific bags has been done, and these infected neonates has to be cohorted and screened weekly or bi-weekly. So cohorting of infected babies from rest of the babies is very, very important step. Go to the next slide, please. Yeah, this is a checklist. This is a checklist for evaluation of the sick, the NICU staff compliance for the infection control. The next slide, please. Next slide. Yeah, that's all.
So we will stop here. Before I'll stop here, I'll ask all the panelists one take-home message: how to design, implement, audit, and how to practically make it work at the ground level in the NICU. One line answers, or your take on the checklist, madam.
It is important for us to have a checklist for each and everything, and that we need to follow strictly.
Okay, Nilesh sir.
You have to modify checklist as per your requirement, as per your protocol.
customize as per your
It's not necessary that you will download from some site and you will adapt to that. You can add your own points.
Right, Amit sir.
Start with small baby steps in a quality initiative, quality improvement study. Have a simple program and then proceed further after reviewing it.
Rajat sir.
So I think checklist should not become a tick box. So just a paper and boxes to tick for all of us. So to make sure that this doesn't happen, involve all the stakeholders in developing your own checklist. For example, involve your nurses and trainees to sit and do a checklist so that they will own it and then they will actually use it.
Right, sir.
Yeah. So as I already told, the dashboard indicators should be evaluated daily. And another thing is, I don't know whether this everybody else follows. Sometimes we do a video of the procedures or the thing, and then everybody who's gone through the entire process again sits and they again see them doing it. Sometimes like how you play cricket, once you see that, when you see ourselves playing, we realize, oh, these are the mistakes I did. But the consent regarding and the ethics regarding this, I think is again should be taken with consent and those things. But I think video recording of the procedures gives us a lot to analyze the checklist other than just ticking and going.
Okay, so it was very fruitful actually. Hope there's no audience, but still at least we ourselves will start.
Yeah, but thanks to Dr. Sunil, because we learned a lot.
The most beneficial person of any presentation is the person who presents or participates, either panelist or somebody who is speaking. So let's see like how we improve at least. Thank you everyone. Thank you all the logistic support also.
Check.
Thank you nnecon team. Thank you.
Thank you, sir.
Bye.
Thank you to the moderator and the panelists. Just a small token of appreciation.
Wait.
We have one cutoff value of 1 as a cutoff value. We have one cutoff value of 1 as a cutoff value.
Okay, thank you.